Sorry. I got 11 people on the Zoom already, and it's not for a half an hour.
To get you to the second double A. I don't think the double A's will last the entire time.
Oh, okay.
Depends on what the temperature is. You got it, right? You're sure you got the sound and everything? Yeah. There you go.
You need that brain to catch up with the motor plan. I have to write down her stuff, buddy. Don't be all over her. Hey, Lindy. Gentle rocks. Yeah. A fast and gentle rock. Whoa. What do you think? You wanna go get Lincoln? You wanna go get him? Yeah, get him. Yeah, she's like, what sleep sacks do you use?
Good morning. I'm hoping that everyone can hear me. I'm Don Abrams. I'm chair of the Department of Ophthalmology at Sinai and director of the Krieger Eye Institute.
I got the shoes on. Sorry. Oh. Oh, it is so gross outside.
And please mute. Please mute.
So if you want, you have to put this under there for them to put the speakers. And unplug the fan so you won't get that vibration.
Okay. So I just heard that people can hear me, so that's good. I apologize for any technical difficulties. I want to welcome you to our annual symposium. We did not have one in 2021 for obvious reasons. Our last one was on 2/20/2020 for our pre-pandemic symposium. But again, I want to welcome you here. I also want to sincerely apologize for any administrative issues we had with registrations and sending out Zoom links and things like that. We are learning how to do hybrid meetings. This is our first major hybrid meeting since the beginning of the pandemic. Almost all of our other meetings have been totally Zoom. We will be making an effort to do most of our future meetings more in person than online, because I know a lot of you like to come and see us personally, but we will be exploring different technologies for next year's meeting to make this a little more seamless. In any event, we're very happy to welcome all of you to our symposium this year. It's the same format as our previous years. We will be having some presentations by our residents in a couple of subspecialties, and there will be questioning from the audience. I'm going to let Dr. Pillai, who is our Associate Program Director and who is running the symposium, speak to you for a couple of minutes about how we're going to deal with questions from the audience for our speakers. So without further ado, I'm going to introduce Dr. Parvati Pillai, who is going to be talking about what we will be doing for questioning and things like that. So I'm going to turn it over to her. I hope you enjoyed this symposium, and I'm sure we'll be getting feedback from all of you towards the end. So here's Dr. Pillai.
Hi, good morning, everybody. Thank you for bearing with us as we get all of this sorted out. We do have some great lectures for you this morning. I'm going to ask that everybody please stay muted throughout the morning. If you have questions, I think the easiest way to do this is going to be to type it into the chat at the end of each speaker's lecture. We will read the questions and the speaker will address them from the podium. That way everyone can get their questions answered and we won't have to worry about people trying to speak over each other and figure out who is unmuted. So now we're going to go ahead and get started with our first lecture. Dr. Laura Green, who is our cornea specialist and comprehensive ophthalmologist, also our residency program director, is going to be talking to us a little bit about innovations in med ed.
Thank you, Parvati. And hello, everyone, near and far. This talk is also known as How to Learn Better, Faster, and with More Fun for yourself in terms of continuing medical education, your hobbies, maybe you want an additional degree, your learners, residents, techs, yourself, students, med students, your family and friends. You know, this could help you if you have teenagers or young children who are having difficulties in school. I have no financial disclosures related to this talk. I am the past chair of the American Academy of Ophthalmology Committee for Resident Education, and I'm the vice chair of the ACGME-RC for ophthalmology, and my opinions expressed are my own and do not reflect any organization. The learning objectives for this talk are to update you on the science of learning, to think about practices and acquire new learning skills, to think about each patient encounter through the lens of social determinants of health, and to know where to go to find more information. Well, how do we learn? Do we just read and read and reread? Do we highlight? Do we go through with one color and then with another color? You know, there's a lot of historical practices that have been kind of passed down or that people empirically figure out for themselves that may or may not actually be evidence-based. And over the past 20 years, there has been an incredible burgeoning of the neuroscience and psychology of learning. And this was beginning to be applied in elementary education. And now it is finally percolating up into graduate medical education, continuing medical education, adult learning, and undergraduate medical education as well. We have so many tools and technologies that we can rely on these days in terms of simulation, interaction, apps, podcasts. I mean, you can go for a walk in the park while also listening to a really great educational ophthalmology podcast, and not to mention the website content that's available. So it's a little bit mind-boggling in terms of all of the different things that we have available these days. This is reached into pop culture through things like TED Talks that you can find on the science of learning from different experts. Hidden Brain is a great show from NPR that focuses on how our brains work, but a lot of it really gets to the science of how we learn and acquire knowledge and skill. You hear talks on NPR about this. It's in PBS and Nat Geo. It's really reached into pop culture in a broad way. Well, what about see one, do one, teach one? There's a number of researchers. Is there a problem?
The slides don't appear to be changing online.
Oh.
So let's see if we can.
Okay. It says that we're sharing.
No, the slides are definitely there, but it's the small screen, but where it doesn't look like there's this before you click on
Oh,
slideshow.
I don't know if you want to do something. Sorry.
Hold on 1 second.
Wow results from the beauty secrets that I'm revealing today. Secrets that make the look of eyeballs disappear. This is amazing. Oh my goodness. Look at that. Oh my God. Here's the deal. If you want to discover a simple way to shrink under eye bags from you in minutes and finally put an end to the frustration of old, puffy, exhausted looking eyes without injections or expensive surgery, then pay close attention. Because in this presentation, you'll also discover closely guarded secrets used by A-listers like Meghan Markle, Alicia Keys, and Gwyneth Paltrow that can keep you in control once and for all. Hi, my name is Cecilia Long. I'm a holistic esthetician, and I help celebrities, fashion models, and men, just like you, get red carpet ready using natural techniques. Today, I'm excited to be sharing my eye bag secrets with you. If you watch this video and do what it says, you will be shocked by the incredible transformation you'll experience. Just watch what happened to my client. See how she looks younger by the second. Puffiness shrinks from view, skin visibly tightens, and fine lines, wrinkles, and pores appear to smooth away. Her eyes become brighter, younger, and more alive, all in less than 7 minutes. It's an amazing transformation. Now, before we get into how you can get these same results, the one thing you need to understand is most advice for getting rid of eye bags is simply dead wrong or dangerous. You've probably been told to get more sleep, change your diet, use
okay, so what about the idea of see one, do one, teach one? There's actually been extensive study and research that has debunked this over the past 10 years. One example is in this study, they studied people watching a video of pulling a tablecloth very quickly out from under objects on a table. And people who watched it 20 times rated their competence much higher than people who watched it only 5 times, or people who just thought about it or read about it and didn't watch the video at all. They also then, another example is they asked them to watch a video of dart throwing and then to estimate their competence at that task. This has also been done with moonwalking, juggling, playing computer games. There's no correlation. And in fact, the more they watched the video, the better they thought they would do. Now, if the activity that they were watching was anchored somehow in reality, if they held in their hand a bowling pin while they watched someone juggling bowling pins, they reduced their estimates of performance. So we can think about these ideas as we think about trying to acquire surgical or technical skills as well. Watching is not enough. You need to combine it with some sort of manual activity and practice. And you need to watch out for the idea of false knowing, overestimating your competence just because you watched that video over and over and over again. Practice retrieval is an idea that has been very well established in the educational and neuroscience literature. The idea with this is that practice retrieval produces more learning than the idea of elaborative studying with concept mapping. So you can make these like bubble diagrams and say, here's this and this connects to that, and that's useful. However, the action of trying and struggling to recall something foments stronger memories than just kind of like regurgitating everything you know and putting it down on a piece of paper. So in studies of concept maps versus retrieval wins. Students were also not good in these studies of judging the success of their studying methods. So there tended to be a lot of wasting time and using things that weren't quite as evidence-based. And the idea of struggling to recall creates a better memory. Make it stick. And this is a great book on the science of successful learning. It's very succinct. It's very brief. We read it before in our residency program a couple of years ago. And it really presents in about 150 pages, really key ideas that can help any learner of anything to employ more evidence-based techniques. Key ideas and points from this are learning takes time. Retrieval is key. You need to mix it up by alternating or not just studying things in the same order all the time. When you can read through a chapter and take notes, but then when you study, you don't just want to study chapter 1, then chapter 2, then chapter 3. Mix it up. Do 2, then 5, then 1, then 3, so that you're not just memorizing things in the same order. Your retrieval is better when you mix it up. Spaced retrieval is the idea of study something on Monday and then don't study it again until Thursday or Friday. Let yourself forget it a little bit, then struggle to retrieve it. So spaced retrieval enhances that idea of retrieval in general. Struggle and effort are good, and all of these techniques help you to avoid false knowing. You can self-quiz. Ask yourself at the end of reading a passage, what did I do? How can I do it better? What needs to be changed? What doesn't make sense? Or what don't I know? What can I learn better? Recall certainly can be useful. You can fill an empty sheet, but having someone else prompt you either by taking quizzes or by practicing with a partner or by having a chart or flashcards where you kind of cover something up or an answer can be revealed. Quizzing is better than just filling an empty sheet. Chunking and grouping things, grouping like concepts is another effective learning practice. Acquiring and maintaining a growth mindset. Believing that you can learn and improve versus a fixed mindset where you say, I'm either smart or dumb, I am what I am, I can't improve. And for many of those of us who are older, these are new ideas. We weren't raised in a culture where this was the norm, but I can tell you that from having teenagers who are in middle school and high school, this is how kids are being taught in schools over the past 15 years. So it's helpful to understand, where your kids are coming from, where modern elementary education is coming from, because these are the people that are going to be our students in medical school and graduate medical education. Mnemonics and humor still work. They help you to remember. They engage a different part of your brain and can help to make things stick. So sometimes the more ridiculous, the better. Ultra Learning is another great book on mastering hard skills. They purport to outsmart the competition and accelerate your career. They call it meta learning, and they look to content experts, and they advise breaking things down into concepts, thinking about, okay, what do I need to understand? Facts, what do I just need to memorize? Because I've got to have the facts in order to be able to manipulate them. And then procedures, what do you need to do? What do you need to know how to do? And keep in mind that testing is learning. So there's been a lot of criticism of teaching to the test, but just taking that test is learning. And so you might ask, well, what's the point of taking a pre-test before you even learn the lecture material and then taking the post-test? Study after study over the past 20 years has shown that you learn better. It stimulates you to pay different attention to the lecture material when you have been stimulated by a test that you perhaps know nothing about, or maybe you only know 5% of what's on the test before you then listen to that lecture or go through that active teaching session. Effort is good, and remember to mix it up. All right, some examples of simulation. So many of us learned how to do retinoscopy from watching classic videos from the 1980s, like this by David Guyton. He also reminds me of like a James Bond character in these films. I don't know. And, so you just watch these videos, and then, you got some tutelage in clinic, with the orthoptists and with your pediatric ophthalmology attendings. But there are some better ways to do it. We now have a retinoscopy simulator available in the Pediatric Ophthalmology Education Center on AAO.org. And you literally can practice streaking and neutralize different refractive errors. And so again, you can just do this over and over and over again without torturing a child and annoying a parent before you actually go in, and then hopefully don't, belabor the process when you actually get in there. So it's more engaging, it's fun, it allows for lots and lots of practice before then interacting with a human being. Another example we've created is one on ROP, and these are interactive cases that present a patient with ROP. And we published on how the residents who interacted with this simulator, all the residents in the study, multi-center, did a pre-test, then they either read the BCSC or they did this interactive module, and those who did the interactive module did much better on the post-test. They also rated it as being more fun. Still need to read your books, but very important to make use of these additional technologies that help then to make the concept stick. We've created interactive OCT modules with very high resolution images, and you can hover over these different layers of the retina and identify different things. And again, there's case-based pathology that you can go through and work through these cases as well. We have an online ophthalmic pathology atlas that we've created as well, and we're working on case-based learning for this as well. One other note, the online pathology atlas is available even to people who are not members of the American Academy of Ophthalmology. You do have to create a login, but it is free to be able to access this. So the key point here is that cognitive research shows that we learn by trying to get knowledge out of our brains, not by trying to force it in. Avoid that false sense of security of reading and rereading, becoming familiar with text in a predictable format, and not being able to manipulate the facts. So another thing that we've been working on is a center on AAO.org on diversity, equity, and inclusion. This too is available for free. It does not require a login. Anyone can look at this. We wanted to make sure that this was available to practices, optometrists, staff, medical students. So this is aimed towards ophthalmology educators and residents, and those are the people who are creating the content, but there's really very broad relevance for this. And I just want to talk a little bit about why this should matter to every physician, why the social determinants of health should be considered in every patient encounter, and what you can do to learn more. And, you know, we can provide, whether we're talking about our learners or whether we're talking about our patients, we can provide equality and give everyone the same size box to look over the fence, regardless of how tall they are. That's not really fair. Equity, you know, would allow for everyone to be able to see over the fence. But, you know, if we can actually eliminate structural barriers, that's even better. Well, how should this affect patient care? We should think about it every day. We need to think about the why. Why is the patient having difficulty, you know, accessing a medication regimen? Why are they missing appointments? You know, we need to be thinking about what we can do to actually allow them to access that. What are our hours of operation? What are the transportation needs? A few years ago, there was a massive overhaul of the Baltimore bus system, and that was going to affect our patients. And I met with the traffic engineers and our vice president for governmental affairs to make sure that they understood how vital this was as a center of employment in Northwest Baltimore, but also that our patients really relied on this. And it wasn't just about trying to get commuters downtown during rush hour and back home, you know, at the end of the day, that there was, you know, people needed to come here all day long, every day for their appointments. And we need to think about economic justice. You know, should premium IOLs be offered as an option? Should be recommended? What are the ethics around, you know, telling people that that's, you know, what they need to do? Is that really the case? I mean, there's a lot of different things you can think about in terms of this realm. How do we judge, you know, patients, and do we judge them, and do we do that equitably and fairly? This chapter on social determinants of health has been added to the BCSC series, and it is available for free to everyone. You can use this QR code, or you can just go to aao.org and look for the DEI content, but it's available for free to everyone. And I encourage everyone to look at it, because medical treatment is meaningless without context. And we need to think about where our patients are, and we need to think about whether we're communicating with them in a way that they can access and that is effective. And so this gets to cultural competency, it gets to not being judgmental, it gets to being compassionate and culturally sensitive. And you know, we need to think about how issues like poverty, unemployment, stability of housing, food scarcity and nutrition, and racism directly affect our patients and their eye health. And also in our workplaces, diverse teams make better choices. How does your decision-making team reflect your patient population? Our practice created a council that represents all different kinds of employees. So there are front desk staff, and there are technicians, and there are managers, and there are doctors, to diversify and find new solutions to difficult problems. And a great book on this concept is The Diversity Bonus by Scott E. Page, which elaborates all of the literature around how diverse groups, diverse teams make better decisions. So the take-home points I would like to leave you with are to think about ways to learn better and faster using evidence-based strategies as opposed to just your personal historical methods. Use interactive resources and tech to make it more effective, but also to make it more fun. Diverse decision-making is better decision-making. And to think about the barriers your patients have to accessing care and what you can do to reduce those barriers so you can directly improve care, and commit to learning more about the social determinants of health. Thank you. Any questions in the chat? Okay.
All right. Thank you, Dr. Green. Next up, we have Dr. Michael Altman, who is our pediatric ophthalmologist, who's going to be giving us a lecture on Brown syndrome.
down button. Okay. Hi, good morning, everybody. Welcome to breakfast in the class. We're going to move from the classroom into the clinic. Talk a little bit about Brown syndrome. I'm kind of excited about this talk because yes, we're going to talk about Brown syndrome and what it looks like, and how you see it in the clinic, and what are the cardinal manifestations of Brown syndrome. Yes, we'll talk about all that. But what we're really going to get to is a unique and different understanding of what causes Brown syndrome. I find that if in life and also in medicine, that if we can really understand what is exactly happening, what is the core of the matter, what is the problem at hand, then we can better devise a strategy for treatment. Treatment is always more successful if we can get right to the core of the matter, as opposed to trying to treat a manifestation or an occurrence that or a secondary cause or a secondary manifestation, something downstream. If we can really get to the heart of the matter and we can treat that exact problem and devise maybe a technique, in this case, a surgical technique, to improve the issue that targets that issue precisely, then I think we really are often more successful than trying to treat a sort of a secondary downstream matter. In this case, I'm going to be describing an innovative, very elegant surgical procedure to pretty much cure Brown syndrome in certain cases, not all cases, but in certain cases. And that's why I had a little fun with alliteration, calling this Brown syndrome a beguiling beneficence, because I think it's an elegant, innovative technique to benefit the patient. But first, let's go back into the clinic, and we are going to say that we have no financial interests or disclosures. Brown syndrome is when the eye does not elevate well. It does not elevate well, mostly in adduction, and it elevates a little bit better in abduction. When the eye moves into adduction, oftentimes there's a downshoot of the eye, and oftentimes when there is a downshoot in the eye, in the differential diagnosis, we always consider something called superior oblique overaction, because that also can cause a downshoot of the eye in adduction. However, these patients don't have true superior oblique overaction, and that's very helpful to distinguish whether the patient has Brown syndrome. When they look up, well, the Brown syndrome eye does not look up very well. And when it tries to look up, it sort of splays out into like an exotropic position. In a few moments, I'll show you many, many different pictures and slides of patients with Brown syndrome, so you'll really get a better idea than me actually describing it, because a picture is worth 1,000 words of how I describe it. The hallmark of Brown syndrome, however, whether it's a congenital Brown syndrome, which is the most common, or it's an acquired Brown syndrome, is the fact that when the patient tries to elevate the eye, it does not elevate. And when the doctor tries to elevate the eye, it also does not elevate, because it's a restrictive process and it's forced duction positive. We only tend to treat patients surgically if we want to keep them binocular, if we want to keep them using both eyes together. If we see that there's a Brown syndrome, but it's not causing a hypotropia, then we tend to kind of watch it and follow conservatively. Now, but if the patient is trying to remain binocular because they are adopting a significant head position, so some of these patients will elevate their chin. Elevating the chin will bring the eyes down, and since the patient can't look up, they prefer to have their chin up and move their eyes down so that they can use their eyes together. Here's a typical patient with Brown syndrome, so like a pointer thing. In the middle, is there some kind of pointer or no? Or not? Okay. So this patient has. There you go. Thanks. This patient looks really great in primary gaze, but as you can see here, the right eye tends to shoot down in adduction. The right eye does not elevate well here in adduction. It elevates a little bit better. in straight up gaze, and it elevates quite a bit better in abduction. So this is a patient with sort of a milder Brown syndrome of the right eye. We always look down here to make sure there's no superior oblique overaction, a pretty typical patient with Brown syndrome. Brown syndrome again here in a different patient. Again, the right eye, as they move their eyes, the right eye into adduction, maybe there's a little bit of a downshoot. The eye does not elevate well. Again, in adduction, it's better straight up. And you can see how this eye sort of starts to splay out into exotropia when she tries to look up. Here's a patient with Brown syndrome too, with a significant head posture to keep their eyes together and binocular. And this patient has a Brown syndrome of the left eye because the left eye does not elevate well, and it does not elevate well in adduction. So therefore, the patient wants to move their left eye away from adduction and away from upgaze. So the eyes are, the left eye is moved down and out, and therefore the patient has to adopt this type of head position just to keep their eyes together. This is certainly a patient that we'd offer surgery to. Now, not all patients get surgery, only the patients that we want to keep them binocular and have them have depth perception, because it's really not worth living otherwise. There is a differential diagnosis. We always keep differential diagnosis. I'm not going to go into this in great detail because I really want to get to the more important part of the talk, which is the surgical intervention that I want to describe for you. But there are other causes of an eye that does not elevate well. These are all of them or most of them. And we have to certainly put our minds to the matter to see which one it is and why it's a specific cause. Because again, if we can really figure out what the cause is, then we really can devise the best treatment. Well, what is happening with Brown syndrome? Why does the eye not elevate? And why does it not elevate in adduction? Well, the truth is, nobody really knows. Helveston thought that the superior oblique muscle acted like a telescope, like it ratcheted through and it lengthened itself through the trochlea. And this telescoping action of the superior oblique to lengthen itself was not working properly in Brown syndrome, and therefore the superior oblique muscle was not working properly. Ken Wright had a different idea that it was just a very tight superior oblique muscle. There's a whole complex of strabismus called the congenital fibrosis of the extraocular muscles syndromes, and he thought maybe it was part and parcel of that. But truthfully, it's not so clear. Quickly, just the anatomy of the superior oblique muscle. It begins at the orbital apex, right above the annulus of Zinn and right medial to the optic canal. It comes forward as a muscle, but as it approaches the trochlea, it becomes a tendon. It goes through this pulley called the trochlea, and it bends very, very sharply backwards, posteriorly, and inferiorly and laterally to attach itself to the globe in the supratemporal quadrant right under the inferior rectus muscle. Now, when the eye elevates, I was actually having some trouble understanding what happens to the superior oblique muscle when the eye is trying to elevate. What is the superior oblique muscle doing? So I called a friend. Oops, sorry. His name is Dr. Bert Kushner in Wisconsin, and he was trying to show me what it's like from his home, what it's like for a superior oblique muscle to move as the eye elevates. So this is the superior oblique muscle here, and here's the trochlea, and here's the tendon coming backwards and inserting onto the eye. So the fist is the eye. And here he is in down gaze. He's looking down and he says, Michael, and watch what happens when I look up. So when I look up, the whole thing moves forward and more laterally and more posteriorly as the globe looks up. He says that's what happens. So what happens is this. Oopsies. Yeah. The superior oblique tendon advances forward through the trochlea, and it moves more laterally and posteriorly along the globe. If there's something that is impeding the movement of the superior oblique through the trochlea, here I've depicted it by like a bulging bulbous piece of tissue. If there's something like that that is impeding the flow right through that trochlea, what happens is the eye tries to elevate as it comes up, and then it's immediately pushed right back down again. So what are the treatments, the previous treatments, surgical treatments for Brown syndrome? Long ago, they used to just go and cut the superior oblique muscle. They would just cut it and let it fly. That was a little scary. That usually caused a superior oblique palsy and didn't seem like the safest thing to do. So instead, these last three in yellow are the ones that we use mostly today. And that is that we cut the superior oblique tendon. Yes, we do. But for the attached ends of now the cut tendon, we attach between the two cut ends some type of material to just lengthen the superior oblique muscle. So Ken Wright described placing a silicone 240 band, it's a retinal detachment device, to put and sew between the two cut ends. He just wanted to put some silicone there. Some people just put a suture between the two cut ends. Some of us do something called a split tenotomy, which is where you actually take the tendon itself and you lengthen it. Since people were a little bit scared to cut the tendon and not put something between it, this suture that is placed between the two cut ends was called a chicken suture. Because we were just too chicken to just cut it. And in COVID, the chicken suture becomes, why did the chicken cross the road for social distancing? It's a little joke. But I wanted to describe to you something else, something that I saw in a talk a few years ago, and something that I think gets to the root of the matter and the cause of at least certain types of Brown syndrome. I'm not going to say it's all types of Brown syndrome, but certainly some forms of Brown syndrome are caused by that bulging thickening of the superior oblique muscle, not allowing free flow and facility of translational movement through the trochlea. So what would we do in that case? Well, if we could really make that diagnosis that there's some kind of thickening that's impeding the movement through the trochlea, maybe we could just reduce the diameter. And this was in the Spanish literature, not really in the American literature. So I got some papers that were translated into English so that I can understand them. I ended up calling some of these physicians that were doing this to talk to them a little bit more about this, because I found it very interesting, because it's sort of my way of thinking that if we, again, get to that core problem, and we can treat the problem, not something else, maybe we really could help patients a little bit more successfully. So the usual treatment has been to cut the tendon and increase the length of the tendon. Now that could be a 240 band, that could be a suture, that could be anything that would lengthen it. And I never actually understood why that worked. Why does that help? And now you see the eye is elevating properly. And I can see now that maybe what's happening is we're moving this, this bulge more posteriorly by lengthening the tendon here anteriorly. We're moving this bulge more posteriorly, so we do not even let it approach the trochlea, and therefore it does not impede the flow and the movement of the tendon through the trochlea. So all we're doing is we're doing something over here to correct the problem that's more posteriorly. Can we do something that more directly attacks that bulge? It's interesting that some patients with Brown syndrome just show spontaneous improvements. I remember still in fellowship, the attendings would always tell me, we rarely see Brown syndrome in adults unless it's acquired, but we don't see congenital Brown syndrome in adults. Somehow over time, over years, it seems to go away, and we're not sure why. There are many reports, scattered reports of patients that just have spontaneous improvement. In fact, some patients went to the OR as children, and when the doctor performed a vigorous forceduction test to move the eye into elevation and into adduction, they just suddenly felt a little pop, and the Brown syndrome was gone. They didn't have to operate. The patient was under sedation. They did this aggressive, exaggerated forced suction test, and they cured the patient forever. So how does that work? Well, maybe it's because with that exaggerated, very strong forced suction test, we are pushing that bulge through the trochlea and moving it anteriorly enough so that it does not impede the flow through the trochlea once again. And if we do that, if we have a patient that we've sedated for surgery for Brown syndrome, we do a forced suction test and it's positive, and then we do it more vigorously and it becomes negative, it becomes free. What we're doing is we're moving that widened area, bulbous bulge, anteriorly, maybe to a place where we can actually approach it and thin it out. And that's what they've been describing, to thin out the trochlea if we can find such an abnormality. So here's what we're trying to do, try and do a forced suction to move this, this bulge more anteriorly. And here it is more anteriorly, so that we can actually thin it out. I have a nice video of, it's on the desktop. This is a video sent to me by Dr. Alicia Galan, who has performed this procedure multiple times, and she was kind enough to share this with me. Now, again, not all patients will benefit from this procedure. It's only the ones that are forced suction positive on the table. And then when we do this vigorous forced suction maneuver and move that bulge anteriorly, can we approach it? So here we see that the tendon's trying to move through, and if there's trouble moving through, there's going to be an issue, right? Sorry, I edited this, but it's a little bit long. It's only another 30 seconds. Okay, so that is a nice, elegant way to treat Brown syndrome in this particular case. So it isn't this thing that they call in Spain sharpening is sharpening of the tendon. I'm not sure the exact translation. It would be for us thinning out the tendon or dissecting the tendon free. Not always. I happen to have one case just like this. She describes it as a thickening of the tendon. I actually found on this case, and I even think on her case, that the tendon itself is really okay. It's this other tissue that's surrounding the tendon, some other fibrous calcified tissue around the tendon that is the problem that we have to dissect free. Again, it's only an effective procedure in certain cases of Brown syndrome when we can free this forced duction test on the table. So sometimes, Mr. Ockham, we don't have to necessarily take a sledgehammer or a big, huge razor of an axe to take care of the problem. If we precisely understand the underlying mechanism, the underlying pathophysiology, we can move away from secondary downstream issues and we can really attack the problem itself. Sometimes all we need to do is thin out the tendon. Thank you.
Great. Thank you so much, Dr. Altman. Our next presenter is Dr. Nancy Kunju, who will be discussing retinal findings on OCT.
I'm going to be discussing OCT findings in medication and systemic disease. And when I started this topic, I realized there is a lot out there. So medications affect all the different aspects of the retina. It affects the retina, the RPE, there's vascular damage, there's CME, it can form crystals, it can create uveitis, and then there are miscellaneous things that medications and systemic diseases can do to the body. I'm going to concentrate on some of these areas where I could find the best imaging. So I'm going to start off with Plaquenil. Hydroxychloroquine, it's a common treatment for autoimmune disease. If you have increased exposure, you'll have increased likelihood of retinal toxicity. It's melanotropic. It deposits in melanin expressing tissue such as the RPE. And because of that, there is a slow chronic release causing delayed toxicity, changes in lysosomal pH, which causes the accumulation of lipofuscin. It's excreted by the kidneys, metabolized by the liver. Toxicity is dependent on the dose, cumulative dose, duration of use, weight adjusted dose. There is a synergistic effect with tamoxifen and kidney or liver disease. So looking at OCT would be an effective tool for early diagnosis before significant photoreceptor damage. And essentially what happens is that there is a focal area of ellipsoid attenuation in the parafoveal inner segment, then loss in the inferior temporal area that becomes to a characteristic flying saucer side. And then in advanced disease, you get the typical bullseye maculopathy and typical degeneration that develops. So in your top slide, you have a fundus photo, which doesn't really show you much, maybe some mild RPE changes. The autofluorescence doesn't show much. The visual field does show the early paracentral ring scotoma. And then if you look where the arrowhead is, there is a focal area of loss of reflectance there of the parafoveal ellipsoid zone. And then where you see the arrowheads, you can see that the interdigitation of that parafoveal zone is also missing. And then in the later slide, you can see there where there is a broadening of Henle's layer. Okay, so there is a broadening here of Henle's layer, which is your outer plexiform layer, because there is a loss of the outer nuclear layer. And again, you have this loss here, or attenuation of that parafoveal ellipsoid zone, which kind of gives you that characteristic appearance. So in the early phase, even though you don't necessarily see much on the fundus photo, you can see again, there is this attenuation or loss of reflectivity of the parafoveal zone. In a more obvious stage over here, there's the disruption of the parafoveal zone and an intact foveal ellipsoid zone. And then in the severe stage, there's disruption of both the foveal and the parafoveal ellipsoid zone. Too far. So of note, in Asian patients, sometimes the toxicity develops in earlier stages of the disease more eccentrically, and they have pericentral patterns of ellipsoid zone loss. On the autofluorescence images, you will see a more eccentric pericentral hyperautofluorescence ring, which I just mentioned. And then you will have, this is where there's photoreceptor atrophy, and it corresponds to the OCT image where you have bilateral severe intersegment ellipsoid zone loss in the temporal parafoveal area. So switching gears, I'm going to talk about pentosan polysulfate sodium. It's a treatment for interstitial cystitis. It's a pigmentary maculopathy. It happens with chronic use of the drug, usually over about 1,500 grams. Women are more commonly affected because there's an increased prevalence of the condition in women. Patients will suffer from blurred vision, metamorphopsia, pericentral scotomas, prolonged dark adaptation. Essentially what happens is that there are these pigmented deposits at the level of the RPE, vitelliform deposits, and they'll have patchy pericentral RPE atrophy, and it almost looks like a pattern dystrophy. So if you're not looking for the medication, you may miss it. On the OCT, you see these focal nodular RPE excrescences and late RPE atrophy and outer retinal thinning. Even though at this time there are no consensus guidelines that have been published, initial baseline testing should include an OCT, near infrared imaging, and fundus autofluorescence. So here, if you look at the fundus photos in 1A and 1B, you will see there is that RPE changes, and you'll see those yellow deposits, yellow orangey deposits, and patchy RPE atrophy on the color fundus photo. If you look at the autofluorescence, you see a dense array of hyper and hypo autofluorescence spots, much more so than you see on the fundus photo. And then if you look at the OCT and the infrared image, so the green line is through one of those nodular excrescences, and you can see that thickening on the OCT of the RPE layer and associated hyperreflectance on the infrared image. This is a later stage patient who is on the medication. The color fundus photography shows pericentral atrophy of the RPE. And again, you have these subtle yellow pale deposits. And then if you look at the fundus autofluorescence, you have this posterior pole with densely packed hyper and hypo autofluorescent spots. And then it's associated with RPE atrophy encroaching on the foveal center. And then again, if you look at the OCT there, you can have pericentral atrophy with outer retinal tubulations that you see in that image, right over here. Moving to thyroidazine, it's an antipsychotic, phenothiazine derivative. There are similar findings with other ones. Thorazine is one of them. It does produce a degenerative pigmentary retinopathy, unclear pathogenesis. Toxicity of the uvea and the RPE may cause secondary loss of the choriocapillaris with RPE atrophy. There is some thinking that maybe there's secondary inhibition of key retinal enzymes and binding to dopamine receptors. There may be oxidative disruption of the rhodopsin. Toxicity can be at different dosages that are reported in the literature. Usually they recommend routine examination at dosages greater than 600 milligrams per day. Patients will complain of blurred vision, dyschromatopsia, nyctalopia, problems with visual acuity, color vision may be normal. You essentially will have a salt and pepper fundus, pigmentary retinopathy with fine modeling or stippling of the RPE. So on the color fundus photograph, you can see there that there is loss of the general architecture, there's extensive atrophy and RPE changes, and this is mirrored in the OCT image where there is retinal pigment migration and retinal pigment atrophy. You can also see epiretinal associated proliferation there. MEK inhibitors, there are chemotherapeutic agents that are used to treat metastatic melanoma. There are high rates of ocular toxicity with this medication. It usually starts within a few hours to a few weeks of starting medication. Patients will have bilateral multifocal serous retinal detachments. Essentially, the thought is that the MEK-ERK pathway affects aquaporins, which control fluid transport. So the disruption of RPE impermeability, and there's an RPE induced dysfunction with accumulation of subretinal fluid. It can happen days to weeks after therapy. It usually resolves. And then if it's persistent, you can simply discontinue the medication and it usually resolves. The OCT finding is this characteristic dome shape. There's no choroidal abnormalities on the FA. There are no focal RPE defects or leakage. So again, if you look at the fundus photo, there's an area of modeling and you can see the disruption there. And then if the infrared image will show much more clearly, and then the OCT will show that area of the detachment. Moving on to talc retinopathy. Talc retinopathy, there are these yellow crystals that are found in small retinal vessels and within the retinal layers. So it's both within the vessels and outside of the vessels. So you can have emboli from talc and chronic IV drug abuse. They're insoluble inert material. You can get it orally because oral tablets are also crushed and injected intravenously. You have crack and cocaine, and findings can range from asymptomatic to retinal vascular occlusions. You can have ischemia with cottonwool spots, venous loops, microaneurysms, and eventual neovascularization. On the OCT, you're going to see these hyperreflective dots of varying sizes along the nerve fiber layer, all the different layers of the retina. And then you'll see also sometimes a thinning of the retinal layers as you do with a retinal vascular occlusion. So the yellow boxes, which it's a little hard to see, but you can see these multiple glistening yellow crystals that are scattered within the vessels and outside of the vessels. And then the picture C and D are adaptive optics images of yellow squares, and that shows you the crystals that you couldn't see both inside, those are what the arrowheads are pointing to there, both inside and outside of the vessels. And then the OCT images will show you there that those crystals are within all the different layers of the retina itself. And those are the hyperreflective dots. So the OCT scans through the various areas can show the different location of the talc crystals in the nerve fiber layer, the ganglion cell layer, the interplexiform layer. The second OCT in particular, if you look, there's some inner thinning of their inner retinal layers, and part of the reason that happens is from the occlusions that can potentially happen with talc retinopathy. Moving on, aminoglycoside antibiotics can cause toxicity. Gentamicin is the most toxic, tobramycin and amikacin as well. They can cause a hemorrhagic occlusive retinal vasculitis that's similar to what's described in the literature with vancomycin. You get intraretinal hemorrhages, intraretinal edema, cottonwool spots, arteriolar narrowing, venous beading, and retinal infarction. The OCT will show fluid, subretinal fluid. It'll show disorganization of the retinal layers. And then later on, you have loss of that fluid, thinning of the tissue, and complete disorganization of the macula. And the fundus photo is showing you the infarction that can potentially happen. CME is a common thing that happens with different types of medications, anything from topical epinephrine, nicotinic acid, prostaglandin analogs, antimicrotubular agents. The image I'm showing you here is a patient who was on Gilenya, in which they developed CME. I believe it was about 2 months after they had started the medication. And usually the CME resolves after the medication is discontinued. Tamoxifen, also crystals here. You have an anti-estrogen agent. They are these inner retinal crystalline deposits causing macular edema. They cause punctate pigmentary changes when you take a look. And then there's hyperreflectance, foveal cavitation, and focal photoreceptor disruption. Usually occurs 2 to 3 years. It's dose dependent, and it's associated with high BMI and dyslipidemia. Sometimes the macular edema can improve after drug cessation, but the crystalline deposits remain. So in this particular patient, it was a period of about 2 years, and there were very few changes to her foveal cavitation. And then a longitudinal follow-up of another patient over the course of 8 years, you see these crystalline deposits in the retina itself. And then over time, the crystalline deposits kind of diminish to a faint yellow spot, but then you still have this hyporeflectance and disruption of the photoreceptor layers. And then you can also see on the autofluorescence images, there are the changes there for the pigmentary changes. Anthozanthine, missed the end. It's a food coloring agent for the treatment of vitiligo and photosensitivity disorders. The high doses can be associated with this ring-shaped deposit of yellow-orange crystals within, and it can be throughout the entire retina, in the inner retina, ciliary body, and you clinically observed in the posterior segment. And the crystals can clear with discontinuation. So this is a right and left eye. The crystals are more so in this eye, and then over time, the crystals do dissipate. On the OCT, the crystals will be throughout the areas of the retina. And those are, again, pinpoint hyperreflective material throughout the layers of the retina. And they can also have atrophy of the superior retina. It can occur with or without CME, and it may show some foveal cysts similar to what you might see in MAC2 telangiectasia. Sulfa derivatives. So sulfa derivatives, which are commonly given, can cause choroidal effusion, retinal folds. And so in the first image up there, you can see there's edema and there are retinal folds of the macula. You can see there's peripapillary edema. And then following, once the administration is stopped, the fovea goes back to normal, and as does the peripapillary area. Alkyl nitrates or poppers, they involve isopropyl nitrate. There's a release of nitric oxide in large amounts that causes photoreceptor damage. Decreased acuity, central scotomas, and metamorphopsia. They might have a normal examination or yellow lesions. Basically, they have subfoveal damage. There's disruption of their ISOS junction. They'll get vitelliform-like lesions, micro holes. It may look like photic damage, and there's some partial resolution after drug cessation. So in this image, the first image is day 1 of the inhalation of the poppers, and there's development of symptoms. Retinal architecture overall appears normal. 3 months after the inhalation, there's disruption of the ISOS junction. And then 5 months after the inhalation, there's some improvement in the symptoms. And then indeed, they resume the poppers and there is some architectural disturbance there. And just before the bell, deferoxamine is a chelating agent used to treat iron or aluminum toxicity. They have these focal thickenings or bumps of the RPE resembling basal laminar drusen. They're hyperreflective material on the subretinal deposits, and the deposits itself will eventually interrupt the overlying external limiting membrane. And you can see these deposits here via the arrow, and they're confluent hyperreflective deposits, and then over time it can cause retinal atrophy and loss of the layers. And I'm going to stop there in the interest of time. Any questions? So it usually resolves after. Oh, she asked how quickly does the MEK inhibitors resolve? It usually happens right after the cessation. If it doesn't happen after the cessation, you just wait it out a few months after that. It usually generally resolves. It can also, once they become accustomed to it, it can also resolve after that, just a few weeks after taking it. And once they start having symptoms within the course before they even finish taking the medication, it does stop usually. Any other questions?
Thank you so much, Nancy, for that talk. Next up, we have Dr. Anthony Casalbono, who will be talking to us about treatment outcomes in the primary tube versus trabeculectomy study.
Good morning. Today, I'd like to present the 5-year new results from the primary tube versus trabeculectomy study. This information was shared at our recent American Glaucoma Society meeting last March. And I'd like to thank Steve Getty from Bascom Palmer for access to his slides and materials where most of the findings from today's presentation is sourced. I have no financial interest in the subject matter of this presentation. The PTVT study is a multi-center randomized clinical trial designed to compare the safety and efficacy of tube shunt surgery to trabeculectomy with mitomycin C in patients without prior ocular surgery. In order to be eligible for the study, patients had to be between the ages of 18 and 85 years, have an IOP in the 18 to 40 range on maximum tolerated medical therapy, and have no previous intraocular incisional ocular surgery. There were multiple exclusion criteria, which are listed. You'll note that several secondary glaucomas were excluded, such as neovascular glaucoma and uveitic glaucoma. Patients were also ineligible if there was a need for glaucoma surgery combined with other ocular procedures such as cataract extraction, or if there was an anticipated need for additional ocular surgery in the future. Enrolled patients were randomly assigned to treatment with a tube shunt or trabeculectomy with mitomycin C. Patients in the tube group underwent placement of a 350 Baerveld glaucoma implant in the supratemporal quadrant with complete restriction of flow through the tube at the time of surgical implantation. Patients in the trabeculectomy group underwent a superior trabeculectomy with a standard dose of mitomycin C of 0.4 milligrams per ml for 2 minutes. Here are the outcome measures that were used to discriminate the two treatment groups, all fairly standard ones for a glaucoma surgical trial. The PT-VT study used the same failure criteria as the TVT study, and they're listed. Patients who did not fail were classified as successes, and they were subdivided into complete and qualified successes depending on whether or not supplemental medical therapy was used. Here are the 16 clinical centers that participated in the study. Here are the demographic characteristics of the study population. The mean age at enrollment was about 62 years. Approximately 2/3 of the patients in the study were male, and about half were Black. The mean IOP at baseline was approximately 23.5 millimeters of mercury on an average of about 3 medications. A large majority of patients had primary open-angle glaucoma. The average mean deviation on Humphrey visual field testing at baseline was about minus 14.5 decibels. No significant difference in any of the baseline demographics and ocular characteristics between the tube group and the trabeculectomy group, indicating that randomization was very successful at creating two balanced treatment groups. Here are data on IOP and medical therapy. Mean IOPs were lower in the trabeculectomy group compared to the tube group at each of the annual follow-up visits, except at 4 years where they were equivalent. And the pressure differences were statistically significant at the 1 and 3 years, but not at other time points. The greater degree of pressure reduction in the trabeculectomy group was achieved with significantly fewer glaucoma medications at all time points. Here's a plot of the IOP data. Here are the treatment outcomes at 5 years, unadjusted for follow-up time. Included in this analysis are all patients who completed their 5-year follow-up visit and or failed during the first 5 years of the study. No significant difference in failure rate was seen between the tube and trabeculectomy groups. Although the overall success rate was similar between treatment groups, the rate of complete success was significantly higher in the trabeculectomy group, consistent with the greater need for adjunctive glaucoma medical therapy in the tube group noted previously. Using Kaplan-Meier survival analysis, the cumulative probability of failure at 5 years was 42% in the tube group and 35% in the trabeculectomy group, a difference that was not statistically significant. Shown here are the reasons for treatment failure. Most patients in both treatment groups failed because they had inadequate IOP reduction or a reoperation for glaucoma. There was a significant difference in the distribution of reasons for treatment failure, with the tube group having more failures because of additional glaucoma surgery and the trabeculectomy group having more hypotony failures. A risk factor analysis was performed to identify baseline demographic and clinical characteristics that would predict failure. Only preoperative IOP was significantly associated with failure in univariate and multivariate analyses. In particular, lower preoperative IOP was associated with an increased risk of failure. Interestingly, there was a significant treatment interaction between the preoperative IOP and cumulative probability of failure shown in this analysis, which subdivided the study population into 3 groups based on preoperative IOP. In the 2 group, there was an inverse relation between preoperative IOP and failure. In the trabeculectomy group, rate of failure was less influenced by preoperative IOP. As a result, at lower levels of preoperative IOP, the 2 group had a higher failure rate than the trabeculectomy group. However, the relationship was reversed at higher levels of preoperative IOP, with the 2 group having a lower failure rate than the trabeculectomy group. In conclusion, trabeculectomy with mitomycin C and tube shunt surgery produced similar IOPs after 5 years of follow-up in the PT-BT study, but fewer glaucoma medications were required after trabeculectomy. No significant difference in failure rate was observed between the 2 surgical procedures at 5 years. And the rate of failure of primary tube shunt implantation was influenced by preoperative IOP, and preoperative IOP may be a consideration when selecting a glaucoma procedure in similar patient groups. Thank you.
Hi, thank you all. So I am taking off my uveitis hat for the morning and kind of talking about something more comprehensive, something that comes up not only with patients in my clinic, but family, friends, and other people asking about this. And as I'm kind of on the precipice of presbyopia myself, it was something I became interested in learning more about. So I have no financial disclosures. These are my learning objectives. So just to kind of talk a little bit about presbyopia, up to 85% of people age 40 and older can develop presbyopia. In 2015, it was estimated that 1.8 billion people globally had presbyopia, and the prevalence is expected to peak at approximately 2.1 billion in 2030. It's undercorrected in many countries, with reading glasses available for only 6 to 45% of patients living in developing countries. And for women over the age of 40 have been found to have higher rates of presbyopia than men in the same age group. Some of that is hypothesized to be because of differences in tasks performed and viewing distances required. So current treatment options, obviously we have the optical appliances, we have some surgical options, and more recently we also have some pharmacological options as well. We're all familiar with obviously glasses and contact lenses. It's kind of generally assumed that spectacles are the most accessible intervention. You have progressives, bifocals, or trifocals. Unfortunately, they are more expensive than single vision readers and have restricted optical zones. Patients have to get used to looking through the various areas of the progressive or bifocal to be able to get the best vision they can. And as we spend more time on computers, intermediate vision becomes more important. So I'm sure you all have patients complaining that even with their progressives, they can't find that good intermediate vision that they need for the 8 hours they spend on Zoom calls and other things on the computer these days. Contact lenses, of course, are a great option for people who can tolerate them. Monovision is something that if you can learn to deal with it and put in a contact lens can be really helpful for a lot of people. The major limitation, of course, with monovision is there's a reduction in stereopsis and contrast sensitivity. For some people, that does interfere with their ability to do things like night driving. And then, of course, multifocal contact lenses are also available. Surgical options we'll discuss a little bit next. Of course, we do have the option to do refractive lens exchange, either a clear lens exchange or during cataract surgery. Monovision, single vision lens implants, of course, are only appropriate for certain patient categories, and effective patient selection is crucial for the successful outcome of the procedure. Many doctors, myself included, will have patients trial monovision and contact lenses first before committing to doing it during surgery, because if you are unable to neuroadapt, it can be quite frustrating. Multifocal and extended depth of field focus, lenses are also available now, with trifocal IOLs found to provide significantly better near vision than extended depth of focus IOLs, while providing similar intermediate and distance visual outcomes. When we talk about the extended depth of focus lenses, the two most popular would be probably the Technis Symphony and the Alcon Vivity lenses that create kind of a single elongated focal point. Difference between the two, the Symphony has a diffractive pattern, whereas the Vivity has a non-diffractive, which theoretically should lead to very low levels of potential glare and halos. Accommodating intraocular lens implants respond to ciliary body contractions, thus inducing accommodation, although current designs induce some inevitable side effects, such as limited amplitude of accommodation and a high rate of posterior capsule opacification. There's also some new generation accommodating IOLs that are under investigation. I'm not going to be going into all of that in this lecture. More recent development is the light adjustable lens, which permits post-operative titrations in IOL power after the eye has healed. And in a lot of patients, this may be a good option kind of going forward. Next, we talk about corneal inlays. So there's a couple that are available on the market, although the raindrop near vision inlay has been recalled by the FDA as of 2018 due to increased risk of corneal haze. But corneal inlays consist of a minimally invasive surgical implantation of an inlay into the corneal stroma of one eye. It has the advantages, it is reversible. But the disadvantage is that you have the potential compromise of night vision and distance vision, long-term, obviously, potential for corneal haze development. And the camera small aperture inlay, which is currently still being done, is basically creating a pinhole effect in one eye. It's supposed to not compromise distance visual acuity as much. The cons, of course, that you do still get the reduced contrast sensitivity in night vision. Many patients eventually do need readers again, and it can be cost prohibitive for many, costing anywhere between $2,000 and $8,000. Also, kind of more along my usual venue, it can cause chronic postoperative uveitis. So just kind of keep that in mind. I hadn't seen one yet in a patient, but that's kind of what it looks like. So if you start to see those, just so you know what that is. Right now, the camera inlay, they do have studies that go out to about 36 months that have shown effectivity of about 8.7% of patients that were studied out of a total of 507. So 44 out of 507 did have their inlay removed because of inability to adjust to it. So of course, then we have, and of course, the interstromal pocket is created by a femtosecond laser. So you do have to have access to a laser to perform these kind of surgeries. Going into laser vision correction, we'll talk about a little bit about monovision and multifocal LASIK and PRK. Again, monovision laser correction, in which one eye is optically corrected for distance, the other eye for near, can be great in the right patient population. Multifocal or presbyopic LASIK and PRK is aimed to correct vision by kind of increasing depth of focus in the peripheral cornea, and then it transitions centrally. But kind of going into the more new stuff, I guess, scleral surgery, currently not FDA approved, but interesting nonetheless. They're attempting to preserve or restore the accommodative ability of the eye by expanding the equatorial scleral diameter overlying the ciliary body and restoring zonular tension. So theoretically, this is interesting, right? Because it's a therapeutic approach aiming to sort of restore some of the static and dynamic physiological function of the eye. Scleral procedures can be performed after or in combination with other corrective surgery. So it can be done at the time of cataract surgery or on its own prior to. So early attempts at scleral expansion bands did achieve some success in restoring accommodation, but ultimately a lot of them were retired due to mixed results and low patient satisfaction and also events of anterior ischemia. One of the ones that is still currently undergoing FDA trials though is the visibility micro insert scleral implant that's being studied out by the Refocus group in Dallas, Texas. Basically 4 PMMA injection molded implants, each about the size of a grain of rice, are placed about 3,000 to 4,000 micrometers from the limbus at a depth of 400 micrometers within the sclera. The implants aim to lift the sclera and the ciliary muscle to tighten zonular fibers holding the lens. Patients are placed under MAC for the duration of the procedure. It takes about an hour supposedly to do this in both eyes. This picture here, picture A, shows a photo of the insert, and B is the sclerotomin docking station that's creating a partial thickness tunnel in the sclera. So in their attempt to get FDA approval, they studied visual function in 80 patients. After 24 months using a questionnaire, participants were asked to describe their unaided vision as excellent, acceptable, or poor pre and post-operatively. The percentage of patients reporting at least acceptable vision after 24 months was about 73%. And overall 99% had acceptable vision still for distance tasks. Approximately 83% of patients were able to complete near tasks such as reading newspapers, prices, and medicine labels without using readers. The cons, of course, we talked about a little bit: anterior segment ischemia due to mechanical vascular compression, subconjunctival erosion of the implant. There were some cases of severe to moderate subconjunctival hemorrhages, implant infection, and endophthalmitis. There was the first generation of this implant. FDA studies showed that about 75% had at least one implant move or be displaced. So the second generation is what is currently being trialed. The next scleral surgery option is a scleral laser micro excision. So the scleral laser anterior ciliary excision recently completed a phase 3 clinical trial. It's using a YAG laser to create a matrix array of micro excisions in 4 oblique quadrants of the sclera to the depth of 85 to 90% thickness of the sclera. So this is kind of based on the visiodynamic theory, which is a biomechanical model for the aging eye that pretends that as the eye ages, the connective tissues within begin to change and impact ocular biomechanical efficiency. The procedure is performed under topical anesthesia, and it takes approximately 10 minutes per eye. Risk factors include accidental microperforation of the sclera and subconjunctival hemorrhage, although these were both thought to be minor risks. So now moving into the kind of newer realm, which is the pharmacological options. There's 2 really ways being studied on how drops can affect presbyopia, either through lens softening or by creating a pinhole or myotic pupil. There is quite a few things sort of in the pipeline, which I was unaware of since there's only one that's currently FDA approved, but I'm going to talk a little bit about a few of these. So lens softening is kind of the first one I thought was interesting. It's thought to restore natural accommodation. Disulfides are thought to increase protein cross-linking in the human lens. So you can use lipoic acid, which is then reduced by endogenous antioxidants to dihydrolipoic acid. But lipoic acid has difficulty penetrating the cornea. So a prodrug called choline ester of lipoic acid, or LACE, it was used instead. So there is a drop that was being studied by Novartis called dioptin, but the phase 2 study did not meet the primary end objective. So they are still kind of back to the drawing board with lens softening. So myotics have gained a little bit more traction with research showing that reducing the pupil diameter to less than 2 millimeters drastically increases depth of focus. The pinhole effect acts as a surrogate for accommodation. Drops aim to improve near vision without impairing distance vision. So most of these are trying to give you between 6 to 8 hours of near vision. Some of them give up to 10 hours of intermediate vision without overstimulating the ciliary body, which then causes a myopic shift. So pilocarpine obviously is the base of most of these. Just going over a few of them, Inovia Microline is currently in phase 3 Vision 1 and Vision 2 studies of 1% and 2% pilocarpine. They're using something called the Optojet device, which administers a mist instead of a drop. The thought behind the mist is that it delivers 1/5 of the drug volume as a traditional eyedropper, so reduces the unwanted effects of pilocarpine while still getting the miotic benefits. Ocufire Pharma is studying something called Nixol, which is phentolamine 0.75% plus a low dose pilocarpine, which is currently undergoing a phase 2 proof of concept trial. This is something, phentolamine is pending FDA approval for use in the reversal of pharmacologically induced myopia. So that's what that drop is. Orasis Pharmaceuticals is currently under phase 3 trials, the NEAR 1 and NEAR 2 study to evaluate preservative-free low-dose pilocarpine plus some proprietary multifaceted vehicle that they are not disclosing. So what's the next step? We could add brimonidine and see what that does. So presbyopic therapies, calling this liquid vision, which is a kind of a cool name for an eye drop. It's eclidine plus brimonidine. Brimonidine appears to mitigate some of the adverse effects of miotics like hyperemia, headaches, and brow aches. According to the company, eclidine is a novel chemical in the US. Its unique mechanism of action allows it to target the full presbyopic market from ages 45 to 70 with a broader range of refractive error. So it can correct from -450 to a +150 and up to 2 diopters of astigmatism. So that's being studied now in phase 2B studies. It's supposed to work within 30 minutes and last for about 7 hours. We also have the Visus Therapeutics Brimacol, which is a proprietary blend of carbachol and brimonidine, currently enrolling patients for their phase 3 trial. Carbachol, as we most commonly know it, is myostatin. Okay, so another route, we can just skip the FDA altogether. So we have a company called iFocus, which is compounding their own miotic, which is a combination of pilocarpine, phenylephrine, phenuralamine, and ketorolac. Phenyramine is an antihistamine. It's available in 2 strengths labeled as iFocus and iFocus Plus. Because this is a compounded product, it does not need to follow the FDA regulatory pathway. The cost is about $100 for a 30-day supply, and they did a proof of concept study evaluating 9 presbyopic patients between the ages of 44 and 64 over 2 days. So that's not great, but that's what we have. At 1 hour, the reading vision was 20/40 in 66% of patients. Reading vision was 20/40 in 89% of patients during hours 3 to 5, and 78% of patients maintained 20/40 reading vision for 8 hours. So what is currently approved by the FDA is something called Vuity, made by Allergan. This is pilocarpine 1.25%. It can be taken daily, working in as quickly as 15 minutes and lasting up to 6 hours. They use something called PHAST technology that allows it to adjust the physiologic pH of the tear film. Their studies were called the Gemini 1 and Gemini 2 study. They looked at 750 patients between the ages of 40 and 55. They also showed a statistically significant improvement in intermediate vision for up to 10 hours. Most common adverse event, sorry, that should say less than 5% during the treatment period, was a headache. Most side effects were mild. Only 1.2% of patients withdrew from the study due to headaches. So the main mechanism of action, again, is to increase the depth of focus by constricting the pupil, improving near and intermediate vision while maintaining the pupil's response to different lighting conditions. They call this the dynamic pupil modulation. When you actually look at their study, it showed that about 30% of patients treated with Vuity achieved their primary endpoint, which was 3 lines of or more in high contrast binocular distance corrected near visual acuity without losing more than 1 line of corrected distance visual acuity. So this was statistically significant, but it seemed like it only worked at about 30% of the 750 patients. So pros for Vuity, it can be useful for early presbyopes who don't want to wear readers in certain situations. It can also potentially extend the benefits of LASIK for some patients who are not quite ready for cataract surgery. Some of the cons, though, it's not covered by insurance, so the cost is about $80 for a 30-day supply. You do get some restriction to the field of vision and night vision, so you want to caution patients that this is not something to use if they are driving, especially if they're driving at night. The myopic shift can cause blurry vision. The results wear off in about 6 hours, but since it can only be used once a day, patients will still need readers. Limited use is really recommended for early presbyopes with minimal refractive error, but could be useful for people who have desk jobs that require intermediate vision, because that intermediate vision can last from 8 to 10 hours. So take home message, are we ready to drop readers? For most patients, no, not yet. If they're between 40 and 60 though, and need mostly intermediate and some near, it's okay to try Vuity, but it's best in early presbyopes, and warn patients that they will get mild headaches and hyperemia, and that they shouldn't be driving at night while the drop is still active. Over 60, probably refractive lens surgery is still their best bet. Thank you. Any questions? Sure. Most of these are studying people. Oh, sorry. So the question was, are these drops, any of these drops being studied for latent hyperopes? And the answer is, so one of the drops is promising to work from a plus 150 up to a minus 450. That's about as far as they go into the hyperopic arena, is a plus 150. So the answer is not really. Sorry to your friend. Anyone else? Okay, great. Thank you. All right, we're going to take a short break before we have our first named lecture with our guest speaker. Thank you. We'll come back. We're running a little bit early, so should we say 10 o'clock? Okay, we'll come back at 10 o'clock. Thank you. All right, hi, everybody. Welcome back. We're going to just keep moving. We're a little bit early, but if we end early on a Friday, that's probably a good thing. We are very pleased to have Dr. Laura Copleen here with us in person today. Dr. Copleen is currently on faculty at the University of Wisconsin-Madison, where she serves as an assistant professor in the Department of Ophthalmology. She completed her undergraduate studies at the University of Wisconsin before pursuing an MD with a PhD in genetics at Case Western Reserve University School of Medicine in Cleveland, Ohio. She then went on to complete her ophthalmology residency and uveitis fellowship at KEI Institute in Portland, Oregon. She's published many articles, serves as the principal or sub-investigator on several current clinical trials, as well as co-hosting a podcast titled Headlight in the Fog, the uveitis podcast. So you can check that out on Audible. Thank you, Dr. Copleen, for joining us, and welcome.
Great. Well, thank you so much for having me. It's nice to finally be able to go somewhere in person again, even though I know this is still the hybrid model. Yeah. So we're going to do a talk on scleritis to change things up a little bit. And then after that, we're going to do some cases. Thank you so much. All right. And I have no financial relationships to disclose here. So we've got three main objectives for today's talk. The first is that we want to look at some demographic risk factors for scleritis, and I'm actually going to show you some data out of the IRIS registry on scleritis in that database. We're going to look at etiologic testing for scleritis and what are some of the associated diseases we need to be checking for. And then we're going to discuss a step-ladder approach to scleritis therapy. But I'd like to start it off with a case, and we'll come back to this at the very end to see kind of what were the therapeutics decisions we had to make. So this is one of my patients that I saw early in my practice, has now followed for about 5 or 6 years. She has a history of rheumatoid arthritis and was actually very well controlled with both her scleritis and rheumatoid arthritis on weekly Humira. Unfortunately, she got COVID, had to hold her immunosuppressive therapy while she recovered, and developed worsening arthralgias. They put her on some prednisone, and in fact, the arthralgias continued to worsen. And then she called our office saying, "Oh, my eyes are red, they're achy, and I've got these check marks on my eyes," which we decided was probably not a good thing. So she rushed on over, and this is what we saw for her. So you can see, normally I would quiz the residents on this a little bit, but since we don't have a good back and forth format with virtual, I'll just describe. But you see, we've got bilateral injection. We've got these corneal infiltrates. She has a history of LASIK, so there actually infiltrates right along her LASIK flap there. And we said, this is a scleritis flare, and you probably have some element of peripheral keratitis as well. We'll get back to what we did with her after we talk about what are our treatment paradigms for scleritis. But think about what you would want to do for this person. So what is scleritis? It's inflammation of the sclera, as the name implies. The thing I always like to remind my trainees is the sclera isn't just what we can see, though. Remember, it wraps around about 5/6 of the globe. So, from basically the limbus all the way back to the optic nerve. So we have to sometimes remember to think about posterior scleritis in the right setting, even if the anterior portion of the globe looks okay. It's uncommon, and that's why we're going to look at some IRIS registry data. So it's a little bit hard sometimes to study scleritis because to have a big cohort of scleritis patients, you need a lot of centers or to have been in practice a long time. Prevalence is about 6 to 20 per 100,000. Incidence is about 1 to 5 cases per 100,000 people per year. And we care about scleritis because while some forms are mild, some forms actually can progress to develop permanent scleral thinning or corneal thinning or even perforation of the globe, and this can then be vision threatening. When patients come in with scleritis, usually they're fairly symptomatic. Oftentimes they'll tell you they have a painful, deep, achy pain either on their eye or around the brow. Sometimes they'll even describe it almost like a toothache type pain in their eye. It can be worse with eye movement. Oftentimes it'll wake them up from sleep. It's that severe. They are light sensitive, they'll have blurry vision, and their eye, if it's an anterior scleritis, will often have this injection to it with kind of a deep purplish or violaceous hue. It can be sectoral, it can involve the whole eye. And the best way to actually assess for scleritis is not at the slit lamp. So when you walk in, and if you've already got, they've oftentimes already have those room lights down because they're light sensitive when this happens. Sometimes you got to apologize and turn them back up, because the room or natural lighting is the best way to probably look for scleritis, but most of us don't have that in our exam lanes with no windows. Room lighting lets you look at the whole picture a little bit better. When you're in the slit lamp, oftentimes you're almost too zoomed in, so you can't appreciate this as well as when you're zoomed out and looking in room lighting. But you're looking for that darker injection that seems to be deeper in the globe. Oftentimes, if you touch it gently, they're very sensitive. They don't want you to touch their eye. And you want to look and see if there's any nodular changes present. One of the biggest things we have to help differentiate it from is episcleritis. And the reason is it can have some similar features if you just look casually. And the treatment is quite a bit different. You know, scleritis is a vision threatening condition, usually needs systemic therapy, whereas episcleritis is self-limited and more of, I have patients that it's pretty bothersome, but it's a little more of the bothersome category, then you're going to lose your vision from this category. And so when we distinguish, we want to ask about the symptoms. Episcleritis is more like irritation, maybe some mild discomfort. It's usually not painful. Vision changes is a helpful distinguishing factor. But then on your exam, you can look at the injection. If you apply phenylephrine, either 2.5% or 10%, episcleritis typically will blanch with that, whereas scleritis oftentimes will not. The other trick that sometimes I like to use is you put a little numbing drop in, you can actually just take a cotton tip applicator. With episcleritis, you can see those injected vessels. You can usually just move them pretty easily with the cotton tip applicator, whereas with scleritis, obviously you can't do that. As most of you are familiar with different forms of scleritis, the most common is anterior diffuse. We define anterior or posterior based on its relationship of the injection of the sclera to the recti muscle, so either anterior or posterior to the recti muscle. People kind of localize nodules within the sclera, and then we characterize that as nodular scleritis. The big form there's probably two big forms I really like to make sure we're always acknowledging though. One is posterior scleritis, and this is something that you need to dilate to look for and not miss. You can have a posterior scleritis without an anterior scleritis. And so you do need to make sure that you're looking then in the posterior part of the eye for optic nerve inflammation, macular edema, choroidal retinal folds, things that could be a sign that there's posterior swelling. You can get a shift in refraction with the posterior scleritis because of ciliary body rotation. And then we also want to make sure we're not missing necrotizing scleritis. Now, if they have an angry, painful red eye with thinning of the sclera, that's a necrotizing scleritis that most of us probably aren't going to miss. But we have to be really cautious in this form without inflammation or scleromalacia perforans, because that typically is oftentimes that isn't painful. Patients will actually usually come in more because of complaints about, my eye looks kind of blue or funny. They can see that uveal show through scleral thinning, or because they'll have blurred vision and they'll have either a lot of astigmatism, maybe irregular astigmatism from the thinning of the globe itself. And that's when that's going to get picked up. And that's actually one of those ones that we really don't want to miss because they're at high risk for perforation. About 25% of patients will come in with bilateral scleritis at presentation, but about half, probably somewhere over the course of their disease, will have involvement of both eyes. So that's good for counseling purposes. And then people can also oftentimes have concurrent keratitis, and that will sometimes change our differential a little bit. And what I have accumulated up here are just some of the pictures of some of the scleritis patients I and some of my colleagues have encountered over the years. The top one on the upper left, there's a pediatric patient. So uncommon, even more uncommon to have pediatric scleritis, but it does happen. On the upper right, there's a nodular scleritis. We can see some where there's been some thinning. The one in the middle right is a patient that was a scleromalacia perforans patient that for decades from way up north Wisconsin had just been seeing a local optometrist for his red eye and was just always told to keep using his artificial tears until one day when he was in the shower, he bumped his eye and perforated one of them. And that was when they discovered that maybe this wasn't just some dry eye, I guess. And so you can see he also has a lot of these weird lipid deposits along the limbus. And then the lower left, that's a B scan showing the classic T sign where we get the fluid posterior, well, there's scleral wall thickening followed by a layer of fluid posterior to the sclera. Like I said, in addition to the scleral inflammation, we want to look for inflammation in other structures within the eyes. Keratitis concerns me oftentimes because that's one of the things where we want to make sure we're not progressing just corneal perforation. And we're going to get to hear more about that in just a couple hours here. So I won't dwell on that too much. The other thing though is you want to look for uveitis. It's actually the most common. I'm going to call it other ocular complication with scleritis. So about probably 10-15% of cases will have a concurrent uveitis. For posterior scleritis, macular edema, exudative retinal detachments, optic inflammatory optic neuropathy are all relatively common findings. And then as we go through the course, we want to be looking for any signs of glaucoma at initial presentation. So if they maybe have a posterior scleritis with some sort of ciliary body rotation, from a more of a direct angle closure type of mechanism, or from whatever, maybe someone's been putting them on topical steroids, so we can get therapeutic changes as well that cause glaucoma, as we all know. And then cataract from the inflammation or from therapies itself. But given how rare sclerosis is, how can we study it a little bit better? And there's probably two big approaches, and we're going to look at actually data from both of them. One is looking at these big quaternary referral case series, or oftentimes multiple quaternary referral centers or tertiary referral centers putting together case series. And the other is to try to start using some of these big data sets. And so in conjunction with the collaborator, Karen Armbrust, who has a grant from the AAO to study this in the IRIS registry, her and I have been looking at scleritis within this IRIS registry scleritis patient population. And so we're just going to share a little bit of that data here. This is a manuscript that we're in the process of submitting, and then another we're in the process of working on. Some of this was presented by her at Academy, and then by both of us at the American Uveitis Society meeting that we just had in the winter here. But we essentially took patients that were seen in the IRIS registry from January 2013 through December 2019, and looked at all the patients that had an ICD-9 or ICD-10 code for scleritis. We only included patients that had at least 3 visits associated with scleritis, because I do think sometimes people mark it and then later go on to decide they think it's episcleritis. We were pretty careful to exclude all the episcleritis codes. And then we basically looked at some of the information both at a patient level as well as at an eye level. But I think what's really striking is if you look at just the numbers here, there's 111,000 scleritis patients in this time frame in the IRIS registry. And when you're looking at some of the biggest case series out there, we're talking about a couple hundred. So this is like orders of magnitude more data. It has some limitations, and we can talk about this a little bit at the question and answer if we want to for using big data for this. But it's just a huge number. And then we also looked then for patients that had specific scleritis subtypes if they happen to be coded for that. And so similar to needing to have a scleritis diagnosis at 3 visits, they had to have been coded as a sclerokeratitis, an anterior scleritis, and not posterior scleritis for at least 3 visits to be included in these subtypes. But you can see here, scleromalacia perforans, it's still a small number, right? We're talking about 2,400 people out of the entire IRIS registry population. But if you look at bigger case, even those big case series of several hundred scleritis patients, most of them have maybe 5 or 6 scleromalacia perforans at most. So this does give us numbers that we just can't get to otherwise. So within the IRIS registry, we looked at some of the demographic features. This is a percentage bar graph basically that looks at the percent of the overall arching scleritis cohort and then each of the sub cohorts for which portion are male versus female, and about in the overall cohort as well as each of the subtypes, about 2/3 were female, and that fits actually pretty well with what we already know from a lot of the cohort studies. Scleritis tends to be a little more common in women, a little bit more common in some of the older female population. When we look at age distribution by the different scleritis subtypes, we see some differences. When we compare to anterior scleritis, scleromalacia perforans tends to have an older age distribution. It's actually about, they were significantly older by about 14 years compared to anterior scleritis patients. And posterior scleritis patients were significantly younger on average than our other subtypes by about 4 years. And that probably fits pretty well with our understanding of what causes scleromalacia perforans. It's oftentimes older female patients with rheumatoid arthritis. And others have kind of noticed this trend previously with posterior scleritis tending to affect a little bit of a younger patient population. So I think so far reassuring that the data that we're finding within the IRIS registry seems to fit what we already think of as our scleritis model. We also looked a little bit at race and ethnicity distribution within the different subtypes of scleritis. And in general, it's pretty similar other than that scleromalacia perforans cohort. These are, again, those stacked bar charts. And what we can see is within the scleromalacia perforans group compared to sclerokeratitis, posterior scleritis, anterior scleritis, there's a little preponderance for Caucasians there. And so within that subtype, it's made a little more common to have Caucasian ancestry rather than these other race or ethnicities. So demographics, I think, have been somewhat fairly well described in scleritis. So that wasn't necessarily our big ticket question that we were trying to look at in the registry. It's reassuring though to see that we have found similar trends. But what we've been really most interested in is what are the risk factors for having bad outcomes in scleritis? And we're just going to go through kind of two, because then we've done a lot of these different outcome analyses. But I wanted to share some of our vision outcome data with you, and then some of the surgical outcome data with you all. And so that's what this here is this chart is showing some results of a Cox proportional hazard regression of best corrected vision of some patients that reached a point where their best corrected vision was greater than 0.6 logMAR. So what we have taken here is all the patients who had at least one best corrected visual acuity measurement within that scleritis cohort, no missing data for any of these variables that we looked at. And we basically looked for associations with this bad vision outcome. And we can see there's a couple trends. So patients tended to be older. So for every 10-year unit, there's an increased hazard ratio for having a worse visual acuity outcome. Males tended to fare a little more poorly than females, as well as did people of Black or Hispanic race or ethnicity. But what's a little more interesting, and those are moderately increased risks, but it's a little more interesting when you look at the smoking status data and some of our scleritis subtypes. So when we look at smoking status, there seems to be a bit of a trend here in that active smokers seem to do worse than former smokers. Their hazard ratio is higher. Both are risk factors, though, for having a worse vision outcome in scleritis. And then when we start looking at some of the subtypes, we can really see that posterior scleritis, sclerokeratitis, so getting that corneal inflammation, having scleral malacia perforans, or getting that necrotizing scleritis, these are really some of the subtypes that also seem to fare more poorly. And so these should be patients then that are getting a little extra attention from us. Particularly if you have a posterior scleritis patient that's a smoker, that's a patient that's at pretty high risk, and you need to be fairly aggressive with what you're going to manage them with. I will preface this with this is just a little bit of preliminary. So we're a little bit further, not quite as far along in our data analysis of the looking at some of the surgical interventions in the scleritis patients within the IRIS registry. But I think it's an interesting thing that a lot of us, on the ground are interested in is like, who's going to need surgery and then how do they do with it? And so I wanted to share a little bit of that data here. So this is, again, looking at all scleritis patients. So basically everybody in this first set of data I showed you here is the first column there. And then we looked at the different people that underwent different types of scleral or corneal surgeries within this all scleritis cohort using CPT codes to identify it. And I guess the overall good thing is you can just look and see the sheer numbers of people that progress to needing an interventional corneal procedure is low. So people getting enucleated, well, less than 1% of people that get scleritis, right? Like 0.001%, very low. So that's good. But these are the complications where we worry about, people having potential for pretty permanent vision loss. And in general, when we look at who is at risk for this, it's a lot of the same people that were at risk for some of these worse vision outcomes. So on average, you can look across the top, we can see the average age of patients that are requiring these procedures is older than the general scleritis population. Men tend to be more likely to require one of these surgical interventions than women. Race ethnicity seem to not have as clear cut of a trend for this, although scleral reinforcement, there seemed to be a little more of a tendency for the Black and Hispanic groups as well to be requiring scleral surgical interventions. And so this is, and some of this may be numbers, right? Because we're talking about 59 people at a laceration repair out of 111,000. But I think this shows us that thankfully, at least what we're doing with managing scleritis for the most part seems to prevent these true devastating outcomes for the most part. We are starting to look at some of the vision outcomes now for what happens to you after these people undergo these types of procedures. And in general, the ones that undergo things like scleral reinforcement seem to overall do okay. They seem to have some improvement in vision. Some of the ones that needed some of the keratoplasty seem to somewhat not always see quite the same visual improvements. And I think that's a little harder to tease out because, you don't always have as much of the time points. And, with the kera, if you have a full thickness graft, suture removal, maybe they eventually someday need a scleral contact lens. So I think that's a little bit harder to look at. But I think at least overall, this is the type of data that you could never get to using a cohort study, really. When you look at what's published on surgical interventions in scleritis, it's basically case series. So this is one of the strengths, I guess, of using some of this big cohort data. So we'll kind of switch back gears just a little bit here and talk about, well, who gets this and how do we treat it, right? Because those are part of our learning objectives. So if you look at some of those quaternary and tertiary referral group population groups, or even some of these population-based epidemiology studies in scleritis, most will say about 30 to 40% of cases have an identifiable disease, probably lower, one cohort's lower, it's probably in the single digits. IRIS registry data actually isn't great for this. When you look at who bothered coding, about 5% get coded for some sort of systemic inflammatory disease. And we think a lot of that just has to do with what gets coded routinely in an eye clinic visit, right? Most of us aren't coding these secondary diagnoses all the time. But the two biggest ones that we want to be aware of with sclerosis is rheumatoid arthritis and vasculitis, especially granulomatosis with polyangiitis. Rheumatoid arthritis is by far the most common underlying systemic etiology of scleritis. So that's why we want to make sure we don't miss testing for that one if the shoe fits. And vasculitis, even though it's not as common as rheumatoid arthritis, is one that actually can have pretty significant mortality within 5 years if we don't identify it and get them set with a rheumatologist for treatment. So those are our big two not to miss. But I've listed some of the other ones. I think we probably pick up 1 or 2 inflammatory bowel disease patients that are new every year through our inflammatory eye disease clinic. Relapsing polychondritis is quite uncommon, but again, it's one of those things that you're only going to diagnose if you're asking, and those are the ones that get recurrent cartilaginous inflammation, particularly the ear. Lupus is another one that you don't want to miss, and scleritis isn't the most common thing that people come in with lupus, right? Oftentimes we're thinking retinal vascular occlusive events, but you don't want them to be getting unknown, lupus nephritis because you didn't diagnose it from their scleritis. Gout is one that I think is sometimes a little easy to overlook. And then spondyloarthropathy, sarcoidosis, Cogan syndrome. I add Sjogren's on here, even though that's not actually one that people have typically thought of, but there's been 2 recent bigger epidemiology studies, one out of the UK and one out of, actually I think out of Hopkins, that have found Sjogren's is an increased risk for development of scleritis. And actually we do see Sjogren's in the IRIS registry as well in about 1% of the IRIS registry patients. And so if you're thinking, well, about 5% overall had anything systemic coded in IRIS registry, well, 20% of that was Sjogren's. So it's something that I think is true. And you do want to be asking those questions then. So what should we test for? The biggest and best thing if you've ever come to uveitis clinic is, we need to take a medical history, find out about under any already known systemic diseases. About half of the scleritis patients that have a systemic disease, it'll already be known at the time of their presentation, maybe even a little bit more. You want to know about recent medications, including things that are given as infusions, because those won't always be listed in their EHR list. If it's an infusion medicine, a lot of times it's given as the infusion center, but doesn't go into their pushed list. And then these are some of the, and then a review systems to help direct some of this testing. These are some of the ones that I'll frequently include. I always check some sort of rheumatoid testing. I usually do a rheumatoid factor. If I have a high suspicion of arthralgias, I'll add a citrulated peptide as well. ANCA testing is standard for me as well as ANA. Usually with a reflex guy, I'm interested if there's SSA, SSB. If the shoe fits, I'll think about B27. I don't always test that in everybody, but if they have episodic inflammation episodes or they have a history of like low back pain or tendonitis, plantar fasciitis, I'll think about that. I routinely screen for sarcoidosis. I typically use a chest x-ray and an ACE if they're not on an ACE inhibitor. I do always get a CBC and a CMP. Partly this is because, as we'll see in a minute, we're going to talk about systemic therapies, and partly because I'm screening for anything like nephritis or thrombocytopenia or leukopenia, because those can be part of the lupus diagnostic criteria. I do like inflammatory markers in scleritis patients. A UA, oftentimes, similarly, I'm looking for any sort of nephritis, hematuria, proteinuria, uric acid if you think gout fits. And I get if people have unexplained weight loss, nuance at diarrhea, or any sort of blood in the stool, fecal calprotectins, oftentimes to help screen for inflammatory bowel conditions. But the number one thing don't forget is there's actually non-inflammatory causes of scleritis. Herpetic is actually a pretty common cause if you have sclerokeratitis, so you want to not miss that. I will also screen for infectious things, so for tuberculosis, for syphilis. Sometimes I'll screen for Lyme, but not that commonly, even in Wisconsin, and we are a Lyme prevalent area unless there's a very good history. The bottom picture here is a patient that got post-surgical necrotizing scleritis after a rectus muscle surgery. So surgical history matters. You have traumatic scleritis. And the 2 big medication classes I tell people not to miss are the bisphosphonates. Those are used for osteoporosis and sometimes are given intravenously. So again, they might not always show up on the med list. And then the new big categories of checkpoint inhibitors, pembrolizumab is a big one. And so if they're a patient with an oncologic history and they're getting cancer therapy, you need to ask about these. These are CTLA-4 and PD-1 inhibitors. And then the last thing is don't miss the masquerades. So the top one is my failure from early on in my career. This was a patient that came with what I thought was scleral keratitis. And I treated him for a good 4 or 5 months with Valtrex, prednisone. He'd never quite clear he'd do great. And then every time I'd hit a taper, it just came back. It just never started looking less like scleritis the longer I sat with it. And if you look, you can see he's got kind of this blepharitis look on the lash margin, you know, a little bit of almost like squamous ulcerative changes there. Does anyone, this one I will throw out. Any residents want to guess what this one might have been? What's on that chronic blepharitis unilateral don't miss it diagnosis? You guys remember? Sebaceous cell, yep. And so I didn't feel so bad. This actually hit also our cornea provider, and finally it was actually oculoplastics that figured out what it was, and he had a sebaceous cell carcinoma. So surface malignancies need to be on your differential. And that, you know, it's always a little humbling the first time you have one of your big career misses, but you know, try to learn from it. I definitely, the struggle to recall was helpful for me. I think that's one of the things that from this a little bit, sometimes you remember the things that you struggle with a little bit more. And you know, for him, it's a case I'll never forget. So for treatment, you want to rule out your infectious causes. You want to rule out anything that's a masquerade. And then if we truly think this is inflammatory, I usually use this stepladder approach. If it's a non-necrotizing anterior scleritis, especially while we're doing workup, I'll usually start with some NSAID therapy. The classic teachings is the indomethacin. You can use 50 milligrams 3 times a day. But there's other ones you can use sustained release indomethacin. Sometimes I'll actually use just for certain straight naproxen, so naproxen 500 milligrams BID, because a lot of people that are insurance will cover that just fine. It's, you know, pharmacies have it. You can even use ibuprofen, flurbiprofen 203 milligrams, a couple times, 3 times a day. But if NSAIDs are not adequate, or if they have necrotizing scleritis or posterior scleritis, I'm pretty quick to advance into glucocorticoid therapy once we've ruled out infectious things. And this is usually for me, prednisone 1 milligram per kilogram per day, up to 60 milligrams daily as a starting dose. And then we treat with that until they're quiet, and then we'll start to begin a taper. There is some role for local subconjunctival catalog, triamcinolone, since we're CME, triamcinolone. But it's a little bit controversial. You need to make sure you don't think it's a necrotizing scleritis, because you can induce scleral thinning doing that. For a mild, you know, for an anterior scleritis, that's you know, quadrantial, and you know, maybe they have poorly controlled diabetes and some diabetic nephropathy, and they're not a good glucocorticoid or NSAID candidate, and it doesn't look like there's already any thinning or evidence of necrosis. You can do though a small amount, usually like 0.1 cc's per quadrant. It'll often be enough, so like 2 milligrams in a quadrant. If patients recur with corticosteroid taper, or the corticosteroids seem to be just barely controlling the disease, then we'll move into steroid sparing agents. And I'll show you some our conventional immunosuppression evidence here in a moment. And then if that fails, then we will sometimes move into these other agents like biologics or alkylating agents, although really our level of data on that is pretty bad. So there's basically no randomized clinical trials in scleritis because it's so rare. It's just not been, and not necessarily we couldn't do them, it's that drug companies I think aren't very interested in it as a market. So this is all, most of our data comes from these retrospective cohort studies, and much of it's from the systemic immunosuppressive therapy for eye diseases study, which is a large retrospective cohort that combines several tertiary uveitis centers, and they use trained coordinators to do data extraction. And I basically summarized up like 5 of the site papers here, looking at these 5 agents. So the top 3 are our antimetabolites, azathioprine, methotrexate, and mycophenolate, T-cell inhibitor, cyclosporin, and then an alkylating agent, cyclophosphamide. And basically, you can see this is your scleritis numbers in this large quaternary multi-center cohorts, right? This is not high. But so, you know, when you look at how many patients by a month or a year of being on these therapies got control of their scleritis, you know, it's somewhere between 60 and 80 some percent. That's not bad. If you look at how many were able to get on the prednisone less than 10 milligrams, about half if you're lucky. So oftentimes we're not able to get control just with an anti-metabolite alone. Even with cyclophosphamide, some of these patients didn't get control. So these are often patients that need more than one agent. So what else is out there? There's limited reports on using biologics, although I will say we use probably both TNF inhibitors and B-cell inhibitors fairly routinely for this more difficult to treat scleritis, even although it's off label. But there are case series and reports of using adalimumab and infliximab, probably with the most support. Usually that's every other week or weekly adalimumab, and infliximab oftentimes at 5 milligrams per kilogram with dose escalation from there. In fact, we're actually looking at TNF inhibitors with several other centers right now as a retrospective study in sclerosis patients to see what the outcomes are with steroids varying on that. And then there was a small prospective phase 1/2 trial on rituximab, either 500 milligrams or 1,000 milligrams, given as 2 infusions separated by 2 weeks. And about 3/4 had improvement of their inflammation. And about half by about 24 weeks, so 6 months, had a reduction of steroids. But you can see, even with these therapies, this can be a hard thing to treat. Is anything else coming down the pipeline? We don't know. So there's some case reports on use of interleukin-6 inhibitors, interleukin-1 receptor antagonists, and JAK-STAT inhibitors, but this is very much case limited. And JAK-STAT inhibitors actually just got a black box warning about adverse cardiovascular events and blood clots with them. So I don't know to what extent that's going to still be a study. So what's my personal algorithm? So if it is a sclerosis associated with a systemic disease, my algorithm is let's talk to rheumatology and use whatever's going to be best for that systemic disease. And oftentimes for something like granulomatous polyangiitis associated sclerosis, that's going to be a rituximab or cyclophosphamide induction routine. For idiopathic sclerosis, I still do typically start first line with methotrexate or mycophenolate, and following that usually with either adalimumab or infliximab, occasionally rituximab as second line agents. With COVID, I've shied a little more away from rituximab because they seem to maybe have a little bit worse outcome from COVID if they get it when they're on rituximab. And then I've had a few patients actually that have done fairly well with adding in a T-cell inhibitor plus an antimetabolite, so methotrexate and mycophenolate plus cyclosporin. For those that didn't want to get into a biologic, or as our social determinants of health, sometimes it's hard for us to get insurance approval for adalimumab. And I've had some success. So we'll just finish off with, did we have a success story with our patient? We did. So we increased her prednisone further after she came in. Remember, she was on weekly Humira and 20 milligrams of prednisone. We upped that to mg per kg, which for her was like around 45 milligrams. Once the epithelial defects closed from the cornea, we also put her on some Durezol. And then for her, we added in methotrexate on top of her weekly Humira. And she was here successfully able to taper off of the steroids. A little bit of residual corneal haze there, but I think all things considered, good outcome, 20/20 at the end of this still. And her joint symptoms improved as well with the therapeutic change. So I have to acknowledge Dr. Armbrust, who's the one that's been doing the IRIS registry research along with me. It's actually her grant that helps fund that. So we've been having a lot of success in looking at that. And then I also have to send a thank you to my daughter, because without her permission, I wouldn't have been allowed to hop on a plane and come here. And so she's probably missing her mom, but she wanted us to still be able to help you guys learn. So thanks to Amelie too. And I'm happy to take any questions. And if anyone ever has a question they want to email me, feel free to reach out as well. Yeah.
For discussion purposes, what are your thoughts about scleritis control around doing like cataract surgery and that kind of thing, as far as patients who are on biologics or transfusions? I know there's some thought about how to time the surgery around their infusion. I was wondering if you want to talk a little bit about that.
Sure, and I'm just going to repeat that for everyone. So the question. Yep, sure thing. So the question was asking us about what are thoughts about perioperative management for the scleritis patient? Should we be timing surgery with some of their infusions or the dosing of their medications? So I think just like all uveitis cases, we like the longer you're quiescent, the happier we are. Most of us try to get to that 3-month mark as much as possible. I do try, say they're on an infusion-based medicine, so something like infliximab, I will definitely try to not have their surgery near the end of their infusion cycle. So if there are patients getting it every 6 weeks, I mean, my preference is usually to do it in the first half of their infusion cycle while they have the highest therapeutic levels. I'm very aggressive when it comes to people with like panuveitis, scleritis with my perioperative steroids. So I actually give most of my patients intravenous solumedrol during the time of their surgery. There's no real good true dosing algorithms of this. I'll usually err around a mg per kg, but sometimes a little more if I know they've got bad disease, sometimes a little less depending on comorbidities. And then I will oftentimes have them on a prednisone burst at least, oftentimes then a taper of about a mg per kg for at least the week after surgery. Some people will start them a couple days ahead of time. I kind of base that on how hard has their disease been to control to date? How do they do being on steroids, and what are their comorbidities? You know, for my diabetics, I maybe don't want an extra 3 days of 60 milligrams of prednisone a day for them. But yeah, I'm pretty aggressive, because nothing's worse than taking out their cataract and then having a flare of their scleritis that you have to manage on top of the regular post-op management. I think I'll defer on what we do if they have corneal thinning, those types of questions, probably to our other speaker. I'm not going to lie, if they have an extensive, so they've also had like a peripheral keratitis where they've had extensive thinning, I will usually chicken out and send those to our cornea service. I'll give them all the perioperative management recommendations, but then I usually have them do the actual surgical approach for doing it. It's just not, I'm not excited to get into a wound I can't seal. So, yeah, Laura.
You mentioned that there's not a lot of data around the underlying diseases because it doesn't get reported as much as
yeah.
But within those diseases that were reported, is there anything around like looking at the medications that they're on, or suggestive of like the severity of the underlying or the lack of treatment of the underlying disease?
That is actually an excellent question, and we're working on it. So the medication data, I think a lot of the people have done like iris glaucoma studies or have encountered this too, it's just messier. So we're in the process of looking at that. We do think that there's probably going to be some differences because of, I didn't share this here, but we had looked actually at some of the, we looked at patients with rheumatoid arthritis, as well as then we just looked at all other systemic inflammatory diseases. And it was interesting because rheumatoid arthritis patients came in worse, oftentimes with vision, at least as an outcome, but then did better compared to that other lumped category of other systemic inflammatory diseases. And part of the reason we suspect that may be is because there's a clear treatment algorithm for patients with rheumatoid arthritis. You know, you can get your rheumatologist on board real easy with, just like mine, you know, we went from weekly Humira to just, you know, methotrexate was prescribed within a day, you know, as soon as I said we needed more medicine. Yeah. Yes, exactly. Yes, and we were actually really interested at too in the people that progressed in needing corneal surgical interventions too, were these people that maybe should have, you know, they should have been more aggressively treated and was maybe part of the reason that they advanced, because right, they were just on NSAIDs for a while, and then maybe too low of a dose of prednisone, and nobody moved them to immune modulatory therapy. Yeah, I think that's actually really good questions, and we'll see. We're going to do the best answer we can with the IRIS registry data. But yeah, so maybe in a year I'll have some answers to that. Yeah. 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 Yep. Yeah, so the question, just so for the audience here, is there was a question about we showed how some of these groups that are oftentimes more marginalized within the healthcare system seem to have so much worse outcome. The question is whether or not there's data available within the IRIS registry to kind of look at some of that, whether by insurance status or access to care or delay in getting care. The answer is sort of. So that we do have insurance data. It wasn't as compelling. I'd have to actually go back and look at it. There were some differences in outcome, a little bit skewed though, I think, in that we have that confounder of like scleritis tends to affect older patients who tend to all be Medicare population patients there. The biggest problem with the IRIS level data is when you try to look at like where are the patients from, it's localized just by regions. They don't have it down to like zip code level where you could use like one of those adversity indexes, which is actually really frustrating to me because one of our groups at Wisconsin has actually developed a adversity thing that goes down to like neighborhood level, you know, socioeconomic status. It takes in a bunch of factors actually, and there just isn't a good way to link that back right now. That's part of the reason we did that Cox proportional hazards analysis. Initially, we had done this as just regressions, but we were trying to look at, the time to impact of time to bad vision outcomes a little bit there. And it's a little hard too, because that's the one problem with IRIS is once they're in, you can kind of track them longitudinally, but you don't really know what happened before they came in. And that's the limitation with a lot of these big data studies, as opposed to, my patient population, I have a very good record of what happened before they met me. And so I think Sort of is my answer. So I think with the insurance stuff, you can get to it a little bit. This is maybe a little bit of a hard population just because of that older age skew. But I do think there's something to be said there for it. But I really wish we had like more like zip code level data within it, but it's just not what's available right now. But yeah, I think those are very interesting because we do think some of this is probably access. Just, I mean, that's in our discussion when we write the paper, we think that should be looked at more for sure. Having used to practice in Milwaukee, I will say insurance plus some of the same social determinants, ability to go get your labs checked every 3 months when you're on antimetabolites, ability to even just complete your paperwork to get into an adalimumab copay assistance program was a much bigger challenge. Now I'm in a practice with a little more affluent patient population. And sometimes we would put people on infusion-based therapies because those were oftentimes, their insurance would approve coverage of those because it was administered within the hospital system, and we would know if they would get them or not, and they could get the labs while they were there. And, is that always our first line choice? Maybe not, but it definitely skewed sometimes how long it took though to then get to treatment too, because of, having to try to sort through all those things. So it definitely does have an impact. Yeah. Any other questions? Were there any chat box questions? I don't know how to look. Okay. All right. Well, thank you. I'll turn this back over to a resident. I think we're doing some cases.
Thank you so much, Dr. Copeland. That was a great lecture. A lot of questions that I have for you that we'll talk later about. So before I get started with our resident case presentations, I do want to just say today is National Thank a Resident Day, and we are very lucky at the Krieger Institute to have very, very wonderful residents. We have 9 of them right now, and they're all just smart and fun and do a great job taking care of patients, and we really enjoy teaching them. So we're going to kick off this next part by doing some case presentations. The first one will be by Dr. Adam Tanaka, who's one of our PGY2 residents.
All right. Thank you very much for that introduction. I'm going to be presenting a uveitis case, and I don't have any financial disclosures. So it's a 5-year-old girl who came in with 2 months of blurred vision and a painful red right eye after being hit in the eye a week prior by a classmate's hand. She was trialed on a drop that we don't know what exactly it was by the pediatrician, and she didn't have any change of symptoms after that first week. There wasn't anything of note with her past medical, ocular, or surgical history. She wasn't on any medications, didn't have any allergies. She had a brother with sickle cell disease, and this will become important a little bit later, but the only thing that we knew as part of her social history at the time was that she had other siblings that had medical needs, including that brother with sickle cell. Oh, sure. So for her initial presentation, she was seeing pretty well about 20/30, 20/25. She did have some tenderness to palpation over that right eye, and there was nothing of note with her pupil, extraocular movements are worth 4 dots. Her right eye had 1+ injection. It did have 4+ cell and 2+ flare. There were a few posterior synechia, and her posterior exam was within normal limits on both sides. Nothing of note on the left side on slit lamp or DFE. So a few questions to kind of kick off the discussion. What would be on your differential diagnosis at this time? What lab tests would you have ordered? And prior to the result of any lab test, what treatment would you have initiated?
Great. So I think it's always a little harder when we have this confounding history of preceding trauma and then a delay in the correct diagnosis, right? So in this type of situation, I actually sometimes will treat with just some steroid drops for a week and see what happens even before I go down the, is this a true uveitis path sometimes. The only thing that maybe errs me a little more towards thinking about some other things in our differentials, how much cell there is. 4+ cell plus posterior syndicate is a little more than you think kind of just for a standard post-traumatic iritis. And so that's a little bit extreme. So, for a pediatric patient population, I'm sorry, did you say the ethnicity?
I did, but she's African American.
Okay, African American. Okay. So for our pediatric patient population, I mean, we never want to forget juvenile idiopathic arthritis, although being symptomatic, and again, with posterior syndicate, not much cell, it's a little bit, and unilateral, it's a little bit less likely. Similarly, we do have to think post-traumatic for this one. In a child with African American descent, we can be thinking about something like sarcoidosis. There can be some rare genetic causes like Blau syndrome in a kid. It's unilateral, so a little less likely, but tubular interstitial nephritis and uveitis, that's more typically bilateral, but that's oftentimes a little more in our pediatric population. And then, there's the usual infectious things. I mean, this is anterior segment limited, but, for kids, toxocariasis, toxoplasmosis. I do still usually screen kids for syphilis, although I always hope that never comes back positive. I don't want to have that conversation ever. Doesn't sound like any travel or history from, so, with no out of country travel and the low endemic rate of tuberculosis in the United States, I don't always screen kids for tuberculosis if it's non-granulomatous. For something severe like this, so we might check that as well. So for this kid, I definitely would check an ANA and a rheumatoid factor. I would probably think about a B27 just because of how severe it is. They can have juvenile idiopathic arthritis with B27 positivity, sarcoidosis screening, and then I would probably have ordered some sort of treponemal antibody testing. At this point, 4+ cells a lot, but I'm real cautious about using difluprednate drops in kids. So at this point, I probably would have cycloplegia as a kid, and then probably started maybe Q2-hour topical prednisolone in that eye as a starting point and see how we do.
Thank you. So as far as what we did, the differential includes pretty much all the things that you mentioned. We sent a CBC, a lysozyme, a rheumatoid factor, an ANA, and HLA-B27. We did elect to start the patient on difluprednate and cyclopentolate and tried for a 1-week follow-up. She came back about 2 weeks later. Unfortunately, no drops were instilled due to the just cost nature of those drops. And she came back with bilateral cell, significant cell, and flare. The labs that we sent at that time after that visit were the anti-streptolysin and an RPR. We tried to increase the frequency of her difluprednate as well as the cyclopentolate, and we sent a note as well to the school to try and increase the amount of drops that were instilled to this patient.
I will interject here. We did give samples of
Okay.
difluprednate. Really, the goal was to see if the topical steroids would do anything.
For anybody who didn't hear that over the internet, we sent samples of the medications. Unfortunately, she was lost to follow-up for another 1.5 months. She came back 2 months after that initial presentation. None of the labs had resulted with anything positive. And unfortunately, again, she ran out of drops between appointments. So when she came back at that 2-month mark, there was pretty much the same amount of inflammation. Now we're at 4+ cell in both eyes. There is now posterior syndicate in both eyes. And we sent her out on difluprednate every hour, as well as a cyclopentolate and a course of naproxen, which was 10 milligrams per kg per day, PO, which is the PEDS JA dosing. And we also sent a referral to pediatric rheumatology. She did well after that episode, right down here. She came back a couple weeks later. Her vision was improving, her inflammation was improving, and we started to taper her down. So some more discussion. If there was anything else that you would have included in the workup, currently that was our workup just below there. And would you have made any changes to the treatment regimen or the management given so far what we know about the social history, given that we've run out of drops or not been able to afford them twice now without any messages or phone calls coming to ophthalmology?
So at this point, I'm pretty satisfied with our workup. I mean, when she goes to see rheumatology, they'll check a CMP, probably because at this point, this is a kid that I think, given how persistent this uveitis is, and it's bilateral, and she's already getting synechiae, this is a kid that's going to get moved on to some sort of probably steroid sparing agent, at least in my mind. So at that point, when my pediatric rheumatology team oftentimes will also get like ESR CRP, just, in advance looking for, is there anything we should be following to see that it normalizes over time? So I'll usually defer at that point if I know they're going to be seeing the pediatric rheumatologist for ordering those types of ones. This is hard. I think I encountered this a lot more actually at my last practice when I was more in the walk area too, where there are these just losses to care because there's oftentimes other kids in the family that are needing care. There's the family has transportation issues, and it's just hard. I think at this point, there's not much in the short term that you're going to do differently. As long as it looks like she's improving on drops, so she's not having a steroid response. But I think you guys are on the right track with getting to pediatric rheumatology. At least at my old clinic, we also had some social work availability. I don't always know what the resources are other places, but that was one thing. Sometimes we just at least get them involved so that sometimes there could be some follow-up, to make sure, oh, is that prescription really not getting to the pharmacy? So someone could do a little follow-up. And that's kind of we sometimes try to elicit that, but this can be a struggle, especially because the patient's not, you've got a family, not a patient. So it's hard.
Thank you. So unfortunately, the whole concept of lost follow-up is the prime thing in this case. She was lost for a full year after that. She was getting some of the drops that I'll get to in a few minutes, but she came back and her mother noted that she was having, in the morning, bilateral blurry vision and eye pain. And this is a slit lamp photo of both eyes. Obviously, you can see the very intense posterior synechiae on both sides. So some of the main points about the social determinants of health in this case, we have well established that she's been unable to obtain and administer the prescribed medication regimens. There was some housing instability that was kind of sussed out over the course of several visits. Her most recent visit, mom told me that she was without permanent housing and they were homeless. They kind of alternated between staying with family, staying with friends, and being homeless. And there's also other siblings that had major medical issues. Another brother with the sickle cell anemia is also a patient of our practice. He also has refractive amblyopia. And there was another child who had some major hearing issues. So at that 1 year appointment with the posterior synechiae and the slit lamp photo, she was seeing about 2250 and 2150. The inflammation was about the same. And she was seen another 5 times in the subsequent 2 months. The vision didn't really change that much. The inflammation went down, kind of a moderate amount. We added some additional lab testing, which included an ACE, TB, Lyme, CNP, ANCA, Bartonella, and beta-2 microglobulin. She kind of didn't really change the treatment regimen. She was still getting difluprednate every 2 hours, as well as atropine. And then on the right-hand side of the screen are kind of the major high points from rheumatology. They started her on 10 milligrams of weekly methotrexate, and she also developed some left ankle pain, so points us more towards the systemic manifestations. And unfortunately, she did develop a pressure response in one of her eyes, up to 27 in the left eye, so we switched to prednisolone in that eye. Yes. So at that follow-up, her prednisolone had become cost prohibitive, so we had to go away from that over time. And since she wasn't getting any significant decrease in the inflammation, we had to increase the methotrexate ourselves up to 15 milligrams because after that 1 or 2 appointments with pediatric rheumatology, she declined to or wasn't able to follow up with further appointments. So at this time, and I'll get into the posterior involvement in a second, but given the time course, kind of months and then years later in the intermittent care that she's been receiving, would you have thought about any different modifications to our treatment regimen and kind of you talked about this a second ago about when to involve pediatric rheumatology or just rheumatology. And if you think if this case, it actually complicated her care because it introduced another provider.
Yeah, I actually had a pretty similar case like this when I first started in my practice. And this is actually one of those patients where sometimes I do think about infliximab in that you know if they're coming to the visits or not. And if they're not, social work can help when you know there's a scheduled appointment. You can reach back out to social work and say, this kid needs to be in at this infusion, the transport needs to be set up. Our pediatric rheumatologist actually will see kids at their infusion appointments too. So oftentimes when they don't have an additional appointment, and that's been, we're very spoiled that way, I think, where I am. But part of the reason for that is exactly this, is it cuts down on the number of cooks in the kitchen. I think for some too, oftentimes when I've had these kids where it's really hard for them to get to so many appointments, particularly with the pediatric rheumatologist and us, oftentimes now in the era of video visits and telemedicine, oftentimes I'm more comfortable as long as pediatric rheumatology, if they can get like contact with them like once a year-ish, I'm happy to then help with some of the dosing and the prescribing and making sure there's some monitoring occurring. I do still usually ask the family, I need them still to know you, because in case there's something that comes up, I want them to be able to help me with you. But I think this is a kid that I would think about, could we figure out a way to help her get onto infliximab therapy, knowing that would be an in-house monitored type of treatment that we would know she's getting. But yeah, I agree. Adding cooks to the kitchen actually complicates things a lot of times when parents are already struggling to get the kids to all the appointments. And now you have to go wait at another clinic site for, another 2-hour visit. The other thing that sometimes we try to do for my practice is, and I don't know like your logistics here, our pediatric rheumatologists see patients actually, it's like within a mile of where I see patients. And so sometimes we'll stack it on the same day. So we'll both see them, like I'll see them at the end of the morning and then they'll get lunch and then they'll see pediatricians first afternoon appointment. That's been a little bit helpful too.
So here, her posterior segment involvement, you can obviously see swelling of the nerve, subretinal fluid, and CME on both sides. Pretty uniform on both sides. Those are her fundus photos. I'm demonstrating the same sort of idea. We can come back to them for reference. And then we were able to actually get an FA, obviously showing the same findings in the macula as well as the vasculitis. So at the follow-up, their next follow-up, she had 1+ cell macular edema and subretinal fluid and vasculitis that I just showed. We sent her with a 6-week taper of prednisone. But unfortunately, at the next follow-up, she wasn't able to ever get the prednisone, but did continue on the methotrexate, difluprednate, and her vision was the same, and her IOP was in the low 20s, which is good considering the pressure response. Still had about 2+ and 3+ cell. We then spoke to the pediatrician, trying to convey the seriousness of this case and the care requirements, the drops, the injections, the pills. Mom did seem to understand, but is clearly just overwhelmed by her social situation and the needs of her other children. So at her most recent follow-up, she was lost for 4 months. In between those visits, she was homeless at the time. Everything was basically about the same. CME and subretinal fluid was unchanged. They did attend I believe it was one more appointment with pediatric rheumatology, and they did increase her from 15 to 20 milligrams of methotrexate weekly. At the time of her visit, we were able to get the rheumatologist on the phone, and we decided the best course of action at that time was to send the patient to the emergency room for a one-time dose of methylprednisolone IV, 10 mg per kg. And we gave her an appointment within 2 days for the consideration of infliximab, like you mentioned a minute ago. And we gave the patient some more bottles of prednisolone as well as timolol. So kind of our overarching discussion questions. Our working diagnosis was for juvenile idiopathic arthritis, with all the workup being negative so far. And if you had any thoughts about management with different, treatment modalities, whether that's injections, other biologic agents, as well as injections versus PO management. And then if you had any comments about additional testing, referrals, and then obviously support resource management.
Yeah. Sub-Q. Yeah. Yeah, so I think this is a kid that I think infliximab, and one other thing that I've done in a couple of the kids with infliximab that for whatever reason, like either the parents just didn't want to give them oral steroids at home or whatever, care reasons, is sometimes we'll, with the infliximab infusions, we'll do monthly, and then we'll also give Solu-Medrol with each of the infliximab infusions to try to help with the posterior segment manifestations, at least encourage those get under control. So we'll do that sometimes for the first couple months. It's really hard to inject some kid like this and that you really worry about the post-op IOP with that lack of compliance, especially if she has a steroid response tendency already. And you worry about progressing that cataract too. I mean, this is a kid that, doesn't have their uveitis controlled. So it's like, if you give them more cataract, at least she has got some vision, right? I mean, it's not great because she probably at least function at school right now. Yeah, I mean, if you give her a hand motion cataract in both eyes and still can't get her eye inflammation under control, that's a problem. I think for her, I'd prefer lean, like we've had towards the infliximab, probably some Solu-Medrol infusions with the initial couple rounds of infliximab. But yeah, this is someone where it's just a hard thing. And I do think social work's helpful. I will say, unfortunately, one of my patients like this actually had to have CPS involved in the case, which, I mean, you clearly never try to escalate to that, right, as a care provider. But they actually then were able to get some sort of, I don't really know exactly all of the details, but it was kind of like some sort of guardianship, so I think there's a family member who then was put in charge of the child's health care only. But that was then a person that then helped ensure that they were getting to appointments essentially. Not ideal, right? But that was something that I had one patient that had to, it was what had to happen. So I don't know that you really want to have to go that because his mom's trying, as was that other parent, the other kid's family and my kid's family, but they just couldn't do it. And the kid had already lost vision pretty much permanently in one eye. So, I mean, at that point, you got one eye left. You gotta do what you gotta do. Yeah, tough case, guys. Oh.
Thank you.
I think this kid might end up having sarcoid someday down the road. I think this kid's going to probably have sarcoid discovered at some point. That's what I think. So sarcoid's really hard to diagnose, right? It's just hard. Even in adults, a lot of times, like we think they have ocular sarcoid and we don't find it on home, or they don't get skin lesions to biopsy. So we just kind of treat it as a granulomatous uveitis. But I mean, I think all the time in my head that people have sarcoid and I just can't prove it. I mean, in Milwaukee, I had so many African-American patients that had granulomatous panuveitis, and I never was able to find enough on chest CT imaging or whatever to make the diagnosis. But I mean, I'm sure that's what it was. And I usually treat along a sarcoid algorithm type then. Yeah, I think for sure that's what the spectrum is.
All right. Thank you, Adam. Next up, our case 2 presentation, slight modification. Dr. Kim is currently out on maternity leave, so her case is going to be presented by one of our chief residents, Dr. Alex Willis, who's going to be stepping in to do case 2.
Okay, so again, I'm Dr. Alex Willis, PGY4, presenting a case that we had in clinic last fall. Case is titled Familiar Foe or Unsolved Mystery, a Diagnostic Dilemma. You got it. No financial disclosures. We got a 31-year-old African-American male coming in with bilateral blurred vision, referred by his PCP. Yeah. Wow. Great. He had a 2-month onset of blurred vision. Truly right side happened a couple weeks before the left side, but he's presenting with effectively a subacute blurry vision. He reports photopsias, which he calls little white dots. Those have fluctuated throughout the course intensity-wise, but they've always been peripheral. No floaters, no field cuts. He's just not very happy with his central vision. We've seen that before in a lot of our patients. So this one's a little bit different, obviously. Review systems is positive for cough, chills, congestion. He showed up to his PCP talking about headaches. PCP is rather astute, finds cervical and inguinal lymphadenopathy and unintentional weight loss from his history. Otherwise, no medical history. He does take Truvada as PrEP. History-wise, nothing notable in medical, surgical, or ocular history, no trauma, and no known allergies. Family history, diabetes, hypertension like the rest of America, social history, no drug use, never smoker, does own 2 cats, and then the aforementioned Augmentin and Truvada. Ocular vitals, he's 20/20 minus OU with brisk pupils, no APD. Pressures are low normal, EOMs, confrontational fields, both full. Color plates does have some decreased color, checked a couple of times on the right eye, and full but a little slow OS. On slit lamp exam, eyelids and conch, relatively normal. Cornea has a little pigment on the endothelium, otherwise clear OD. We do see some fine KP OS, as well as some pigment there as well. AC, trace cell, pigment OS, a little more pigment OS than OD in general. Iris is acting normal, round, normal dilation. And then we do see some pigment on the lens. It is otherwise clear. Our posterior view is, there's a little vitritis noted in the notes. The pictures are pretty clear as far as the media. This showing, it's hard to see here, but there's a little elevation, a little obscuration of the margins with the loss of some fine vessels. Vessels are otherwise mildly tortuous, and we'll get a little more delineation on the vessels later. And then attention is drawn to these kind of deep, creamy white, ovoid to coalescing subretinal lesions, most post-equatorial and inferior in the right eye, and then kind of along the arcades in the left eye. And so that is spelled out here in our DFE. I don't think there's anything we missed. Oh, there was one frosted branch inferiorly OS that I glossed over, but that was noted. We have an FAF duplicating our known lesions in location, but there wasn't very many hidden lesions that were noted on FAF that weren't noted on exam. Hyperautofluorescent and hypo. We got an FA transit of the left eye, seemed to be more involved OS than OD, very early on the left-hand side of the screen. Then we got an early arterial phase OS, mildly tortuous vessels, otherwise relatively normal early. We're moving more towards the AV mid-stage here. What I'll say is from the left photo to the right, disc does show a little bit of leakage. If you really investigate, you might be able to see a little blocking with our subretinal lesions of the choroidal flush, but it's very minimal. And switching back a little bit later to the right eye, we have a relatively normal left-hand side photo of our right eye. And then we have staining that's very late with a little bit of leakage of the disc as well as some of the lesions. Further workup included OCT RNFL, which showed expected edema, and we have CME OS more than OD. If you scroll through these OCT max, you'll see some subretinal hyperreflectivity in a few areas, but our lesions are outside the fovea and macula mostly, so very minimal. There was a bit of optic disc edema, if you remember, and the edema tracked inferiorly and led to those lesions in the left eye. And so unsurprisingly, a almost arcuate appearing lesion on the left, maybe an enlarged blind spot, relatively normal with some superior losses, OD. So in summary, we got a 31-year-old African-American male with 2-month history of blurred vision, photopsia, B symptoms, lymphadenopathy, found out panuveitis, disc swelling, and corresponding field loss. And so when we see a patient like this, I guess the question is, broad differential panuveitis, is there anything you've seen in your practice that has fit this profile the most, or maybe like a short list of diagnoses that you'd go after?
I think the biggest thing in this case is making sure you're doing enough infectious testing, right? I mean, this guy has B symptoms and lymphadenopathy, and I think, he's on prep therapy, so you have to keep that in mind too. So, I don't routinely test all my uveitis patients for HIV, but this is someone that we're going to want to do that type of testing, because if that's positive, it can actually change how some of the infectious things will present and what we're going to do. So for him, we're going to rule out syphilis. I'll probably TB test someone like this because we're probably going to some more lenient infectious. And then I would definitely think also with the cat exposure, I'd make sure this patient gets toxoplasmosis, IgM and IgG, mostly the IgM actually I'd be interested in. You can think about whether or not there's a role for Bartonella testing with the discoideme, although I don't think of those lesions as being super classic for that. And then you'll do your usual sarcoid, sarcoid suspect. But I think for him, that's kind of a little more in my mindset there, is probably maybe pursuing more of that toxoplasmosis, Bartonella, and HIV testing that I wouldn't maybe necessarily do in a bilateral, primarily posterior uveitis otherwise. I think it looks like you guys did a lot.
Yeah, she's able to see the next screen, and so we're pretty much in lockstep with your line of thinking there. Broad differential, focusing on the few of the diagnoses that you've mentioned. I think we added in Lyme and Aves, especially in a resident setting. We're always thinking about BKH and SO. And so we had a matching workup. I put what was positive on the left, what was negative or normal on the right. So starting with what was normal, MRI, LP, syphilis, TB, HIV, Lyme, Bartonella, and Toxo. Blood cultures were negative, HLA-B27 was negative, PC ANCA negative, and then a PET scan initiated by his primary care physician due to the lymphadenopathy and B symptoms was also negative for focal hyperintensity. So what was positive, obviously, is the CT chest with higher lymphadenopathy bilaterally, a high ACE, lysozyme that was elevated as well, and then we had a lymph node biopsy that was done after this initial workup in-house. And then I'll show you the dreaded photos of the H&E with some stains, PS, acid-fast, GMS, all negative. And those are separate slides, obviously, but the H&E just shows some caseating, necrotizing granulomas. There's one up on the left here, and then a little caseating area is there, as well as there probably as okay. And so with that final workup, is there enough evidence in your mind to support our diagnosis of caseating or necrotizing sarcoidosis, and what would be your next steps in diagnosis or management? Because we've asked this question a lot to a few different groups in the past few months, obviously.
So I definitely think that's your working diagnosis right now, and this is a guy that's going to, continue to get probably peripheral lesions if we don't do something about it. So, I think if you've done your workup, you got to treat based on what you've got to date. If it doesn't work, then you can always come back and revisit. I'm a little more cautious now because I actually had a person have coccidiomycosis that I thought was going to be sarcoid because of initially their workup. But I think at this point, I'd feel pretty comfortable with going ahead, at least starting with some systemic corticosteroids and seeing how they respond. That's something that we can easily stop, if they seem to worsen somehow. And so I think that's reasonable. And then, if we get a good response to that, this is probably one of those people you're going to lean towards putting on a steroid sparing agent. I really like methotrexate for sarcoidosis, but this is a person that's going to need to also be meeting rheumatology given the other, the systemic manifestations too, and that decision can be made together there. So that's what I think. I feel like, yeah, I think I go ahead with this. I go ahead and treat this. I probably treat with some steroids.
And so we treated with steroids topically and PO, QID topically and 40 milligrams PO. And I'm so understated today. Okay, so just to recap, he's currently on a 6th month of PO prednisone. He was tapered after the first month to about 10 milligrams, and we're blessed to have a sarcoid clinic in the Baltimore metro area. And it was a blessing and maybe a curse because they wanted to pursue it more diagnostically first prior to giving him long-term treatment. And so we looked for backup and sent him to Johns Hopkins UVS Dr. Jabs, who agreed with our assessment and recommended a slow taper of PO-PRED 1 by 10, 9, 8, all the way down to off. During that taper, lesions returned peripherally and was restarted on 10 or 20 milligrams, little confused on which one he was actually taking, but he's been maintained on 7.5 with no new lesions. The hope is we can get him on a steroid sparing agent rather soon. In the sarcoid clinic, they recommended an outside infectious disease doc take a look and also agreed with the assessment. So it's a big question. And
let me tell you, I have never had an ACE and a lysozyme be positive. That plus that, even just the chest imaging outside the biopsy, I would have been pretty comfortable that this was sarcoid. And it fits too. Those look like those could be sarcoid lesions. So yeah, I concur with you guys. And who am I to disagree with Doug Jabs, right? So no, I would have felt very comfortable doing what you guys did, 100%.
Questions or comments? And that's it. Thank you.
Thank you, Alex. Yes, we're lucky in Baltimore to have several tertiary care centers at our disposal. So as Dr. Kundra and I have said, it's good to spread the bad sometimes. So when a case becomes too much, it's good to pass it along among all of us. So our last uveitis case is going to be presented by one of our PGY3 residents, Dr. Arya. And let's get this pulled up.
Okay, so hi everyone. I'll be presenting a mystery case. No financial disclosures. So we have a 51-year-old Caucasian male who presented with a red, painful right eye for 4 days, associated with some floaters, tearing, and blurry vision. He has had no prior episodes or significant ocular history. His medical history was significant for bariatric bypass surgery 20 years ago. He's on Truvada PrEP therapy, given a partner with HIV, but he himself has been tested negative for HIV multiple times. Otherwise, he lives in the woods, has noted no recent tick bites or rashes, and he also works as a nurse. So his vision in that eye was 20/50, and he had an APD. Intraocular pressures were normal, both eyes. Otherwise, left eye was unremarkable. On anterior exam was remarkable for some injection, KPs, and substantial cell and flare. Posterior exam of the right eye showed some vitreous haze, vitritis, The disc was edematous with blunted margins, some macular edema, and then peripherally the vessels were attenuated, and then these multiple poorly defined areas of whitish yellow lesions, and then the left eye here was pretty unremarkable. Kind of written out what we just talked about. And then the OCT MAC showed some macular edema, kind of tracking in from the nerve. So fluorescein angiogram was performed. A late phase image was remarkable for some vascular areas of hyperfluorescence with diffuse late leakage, potentially some peripheral areas of ischemia as well. So Dr. Colton, question for you. After looking at these images and kind of the history, what are some thoughts you'd be thinking about? And then any lab workup that you would obtain at this point?
There's nothing I hate more in life than a unilateral panuveitis, probably, because inevitably that distinction between infectious or inflammatory, it's kind of like our ultimate lumping in uveitis, right, is very important here, because a lot of bad things can be a unilateral panuveitis. So for this, you worry about ARN, acute retinal necrosis, for sure, with that ill-defined kind of fuzzy bordered retinitis look in the periphery, and some of the vascular findings already, and particularly how severe the inflammation is. Unilateral panuveitis, you do have to think about toxoplasmosis as well on your differential. You still have to do your due diligence with syphilis. You got to do your due diligence with sarcoid. This is a guy where, I've seen probably one case I truly believe is Lyme uveitis, and I check for it once in a while. Guy in the cabin in the woods, I guess I probably would check him for Lyme, although this just is so severe. I just don't know that I think that that's what that is. Probably as well HIV test here, because again, if that's positive, then we have to maybe go down some other more obscure thinking. But I think the big one here is how do you want to assess this for ARN, or do you? I oftentimes will put people empirically on Valtrex therapy for ARN while pursuing some of their other lab testing and monitoring them back versus doing an initial anterior chamber paracentesis for viral PCR. But I don't think you could be faulted if you chose to do the converse here and did it. I just think sometimes, it's nice to make sure it's not syphilis before I AC tap them, kind of thing. So I'd probably, for this person, well, I guess we're just talking differential, I won't tell you what I'll do. But I would say, yeah, I'd check them for HIV, syphilis, toxo, sarcoid, Lyme, and then I would at least empirically be thinking about ARN. I don't routinely do antibody testing for zoster and simplex, because if they've told you that the history of chickenpox, they're probably going to have a positive antibody test to zoster, and a lot of adults are just exposed already to simplex. So it's not as helpful. If negative is helpful, but I don't routinely start with testing that. I don't fall in that camp. Some do.
Thank you. So yeah, we were pretty much in agreement. Our leading differential did include ARN or porn, often associated with herpetic etiologies, like you mentioned, like herpes simplex, varicella zoster, and CMV. Other possible differentials, like you mentioned, included Lyme, because he did live in the woods. HIV, he's already on Truvada prep and tested negative, but possible. TB, syphilis, sarcoid. Other less likely would include kind of toxo, as you said, and then Bartonella lymphoma as well. And then lab workup you talked about as well. So we did pretty much pursue that as well. And it all turned out negative. So at this point, in terms of treatment, you kind of mentioned it briefly. You said you would probably empirically start Valtrex. But my question to you is, given his history of bariatric surgery, would that change your management at all? And then also consideration of IV versus oral treatment at this point.
So that's a good question. I actually don't know the answer if there's any dosing adjustments with bariatric surgery for Valtrex. I don't know the answer to that. I mean, I typically will use oral valaciclovir over IV if they're not immunocompromised, because there's pretty good evidence that you can reach the therapeutic concentrations with that, and so you can use the high dose 2-gram dosing and get to therapeutic concentrations. If they do have underlying immune compromise, then I do think there is sometimes a role for using intravenous antiviral therapy. And so that sometimes then is where we go. I think for me, the bigger question is when do I reach for intravitreal antiviral therapy? And that I have a pretty low threshold to try to do early if I'm pretty convinced that what it is. Now, in this case, since we're still not maybe 100% certain, we might start him on that high dose Valtrex and have him back there in a day or two, see where we're at with things. If we start getting that, circumferential spread and the, more posterior extension, because right now this is still fairly peripheral. Although he has a lot of nerve edema, then we could think about getting into intravitreal therapy, because I do worry, with that much disc edema, we'll probably want to try to get this viral process under control soon so we can start introducing some steroids to try to limit our inflammatory sequelae, basically, or fallout. So I guess short-term oral Valtrex, and then probably some injections are coming their way if this is on.
Okay, so yeah, you guessed it, you nailed it. So this patient had an interesting clinical course, keeping in mind his bariatric surgery, potentially limiting oral bioavailability here. So here we kind of chart his clinical progression, going across the days up here, and then with corresponding images down here. So over the first few days, his vitritis worsened, the peripheral lesions started to coalesce, and visual acuity continued to drop. So initially an AC tap was performed ASAP, and the patient was actually admitted for IV acyclovir. Intravitreal foscarnet was then injected, and oral prednisone was then started. The peripheral lesions, however, did seem to increase and worsen, and the vitritis and the vasculitis worsened. And so another dose of foscarnet was injected. On day 6, the AC tap came back positive for varicella zoster. So infectious disease was on board. And so they suggested oral valganciclovir. But given that the patient didn't seem to be responding to oral steroids or IV acyclovir, he was then switched to IV ganciclovir, and then intravitreal ganciclovir was injected as well. The patient now seemed to have some mild visual improvement, and mild improvement of the lesion borders, especially nasally compared to before here. Treatment was continued, but he continued to have vitritis and inflammation. So moving forward. So we did stop the prednisone. Yes, I forgot to mention that. Yeah, so over here around day 7, so that's right here is when we stopped the prednisone. So given his persistent inflammation and then some apparent effect of the antivirals, steroids were eventually restarted. And then with concern for limited oral bioavailability, sublingual steroid was started, subtenon Kenalog injected, and IV ganciclovir was continued. And then going through the treatment, examine visual acuity improved, and this is what he finally looked like with a final visual acuity of 20/25. With that, and then he was lost to follow up. Yes. So after this, he was exactly. So after this, subsequently, he was lost to follow up. But per recent PCP notes, he has not had any vision changes or problems. So we'll see if he ever decides to come back. But just to overall summarize, so. Exactly. Yeah. So that's exactly what we thought was unique about this case was his clinical course response to treatment and his history of gastric bypass. So it's been suggested that oral Val esters, kind of as you suggested, may be preferable as first-line therapy in ARN, given that they do achieve high vitreous levels. Additionally, he had a poor response to IV acyclovir, which is traditionally the first-line therapy for ARN. He only improved when IV ganciclovir was brought on board, and ganciclovir has been used less frequently to treat ARN, unless it's treatment refractive, but more so for CMV. And then lastly, the intravitreal did seem to provide some beneficial adjunctive therapy, as has been recommended in macular disc involvement, both of which he seemed to have in this case. So overall, a bit of an interesting course, but let's see.
Yeah, that's what I was just gonna say. It's amazing he didn't detach with how bad that looks, because I feel like the zoster iron patients, when they just get that much confluent retinitis, they just all seem to detach. That's amazing. No, it's very interesting. Actually, that's a good thing though. That's a good teaching point about the history of the bariatric surgery and the Val Esters there. Actually, that's a great teaching point. But one thing I was going to say is, I don't think it's surprising that initially he kind of seemed to get more of the confluent lesions. That's why you treat till you see them start to turn. But a lot of times they already have a lot of infected retina that's not clinically visible yet. And so I feel like that there's always that delay between what you're doing and the response you see, I feel like, with iron. And so that's why I'm really aggressive though, because until you start to see it turn the corner, there's probably more worsening coming. And so, yeah, you guys are totally on board. All those injections, that's how this goes. I see less and less this in my practice only because I'm the only specialist, CVI specialist where I am, and I don't have a fellow as of now. And so I can't inject them every 3 days. Usually I'm just not in clinic often enough. So I often get these early and then they kind of bounce back and forth with me in retina, but I can't believe you didn't detach. That's amazing. Yeah.
Keep going, right?
Mhm.
It's better. There's always this fear of, what is this?
I know.
Missing something or missing something, then finally like day 5 hits, you're like, okay.
Yeah, exactly. Yeah, I think we do worry about that. In theory, I think for a lot of these, if you have resistance, but you're still doing intravitreal injections, you're able to overcome that a lot of times with the intravitreal drugs. But if you're not sure, then I think they usually do change the ganciclovir essentially. Yeah, that's what I saw. There is ways to test for it, but I think a lot of times that is what infectious disease will say too. Because otherwise, like, you got another specimen of the eye. This is already not, it's a high risk for an RD, like the phakic in this patient. How many times you want to go in that eye? I think kind of the the answer sometimes is just empirically switch them and see if they do better. But it's possible that's also a possibility here. You're totally right. I just don't think there's a way for us to know without having to gone in and drawn another specimen for them to do. I think they genotyping. Yeah. Yeah. To. Yeah. Yeah. Enzymes, yeah. In the future. And sorry for those at home, the question was asking about resistance to the acyclovir, because this patient's still going to improve even once switching to intravenous acyclovir, and then some conversation here about how even further in the cornea literature, there's been increasing resistance to acyclovir and valacyclovir as some of the enzymes like the thymidine kinase develop mutations and what that's going to look like. And yeah, that will be rough because valganciclovir is one that needs more monitoring too. I mean, Valtrex and acyclovir are somewhat kind drugs to be on, and that we can put people on them and leave them on them for fairly long periods without a lot of concern for downstream side effects or lab abnormalities. Whereas with like valganciclovir, you be monitoring blood cell counts and liver and kidney function somewhat routinely while on that. So, oh man, let's hope we don't get too much resistance out there. I think the one other thing I was going to say with this case too is, for obvious reasons, you guys decided to give Kenalog because there just wasn't this good systemic bioavailability. But that's something that I think is really, you have to make sure the patient has a very good understanding about their need to then, while that's still on board, be covered with some sort of maintenance antiviral therapy. Or I actually, one of the things I've seen too is a toxoplasmosis patient that got a Kenalog injection for CME, but then came off their Bactrim and then had macular reactivation. So, the patients need to have pretty high understanding that injection they get lasts for a while, and you need to have that cross coverage. And that's something that, if you don't have a patient that can understand that, you really probably don't. I always tell residents, don't inject unilateral panuveitis until you're real sure you know what it is, because you can really make trouble for yourself there. If it's infectious and you have a long a steroid on board, it's going to last for months. So, yeah, he seems to have a good understanding. So that, and for him, it makes good sense. You didn't have another way to get him steroids. So, it makes good sense for him, but that's just always you got to make sure your patient has a good grasp on what you're doing, because you can get into trouble that way. Great case though. Let me remember that about the bariatric surgery.
Yeah, so quick point on that. So in patients with gastric bypass surgery, oral bioavailability limited has been noted for prednisone and for certain antibiotics like fluoroquinolones. Short term for sure, but then also some like long-term studies. 20 years out, I didn't really find any data, but definitely like some years out. Yeah. Thank you.
All right, great. Well, we are going to break for lunch. We'll resume at 12:30. So enjoy 12:15. Sorry, we'll resume at 12:15. Okay, great. Enjoy your lunch, everybody. All right, welcome back, everybody. We're going to get started again for the afternoon sessions. First up, we have our cornea specialist, Dr. Claire Kelleher, who's going to give us all an update on corneal cross-linking.
Sorry, which arrow here? No. Okay, so good afternoon, everybody. I got the coveted post-lunch slot, so hopefully not too many of you are asleep. So I'm just going to talk about corneal cross-linking. And, you know, I think at this stage, everybody's very familiar with what it is, what it's doing. But basically, we're trying to strengthen a weakened cornea. So we can see there the picture of keratoconus. We can see what a pentacam of keratoconus looks like. And basically, it uses riboflavin and UV light. And the story is that back in Germany in the 1990s, a German ophthalmologist was at his dentist, and he asked why the dentist was using UV light on his filling. And the dentist explained to him that the UV light was used to polymerize and to harden the material that he was filling the tooth with. So this led to some interest. Okay, what's this about? What happens? And the other thing clinically that had been noticed was that patients with keratoconus typically, and not always, typically do not progress as much when they get older. And, you know, all of this research led to then understanding that the corneal collagen fibrils are cross-linked, or they're linked to each other. And that's what gives the cornea its mechanical strength. Using riboflavin, which is a B vitamin, and UV light, you can artificially cross-link the cornea. So the riboflavin is to allow, when you have oxygen UV light, the riboflavin allows an oxidative stress reaction to happen and allows us to artificially cross-link and strengthen the cornea. So there are two big reasons for using corneal cross-linking. The first is progressive keratoconus, and I'm going to go into that in a minute. But the big things, anytime the residents come to me and they've found somebody with keratoconus, one of the big questions I have for them is, how are we going to stop it progressing? And the two big things are to get patients to look out for eye rubbing. So I always ask the residents, have you flipped the lids? Have you looked for allergy? Have you started them on something to stop any allergy? The other thing is sleep position. People will sleep in the most unusual way on their hand or something like that, that again, that is putting physical pressure on the eye and will lead to progressive keratoconus. The other big indication for corneal cross-linking is corneal ectasia after laser vision correction. And as time has gone on, as we have learned to screen people better before laser vision correction, hopefully the numbers of people developing corneal ectasia are going to decrease. But typically, when we talk about proceeding with corneal cross-linking, we're looking for progressive disease. We're looking for a change. So one of the big issues we actually have with all our studies is progression is really poorly defined. As I say, this all started in Germany. They started off with a reasonable bunch of patients. It was 60, 80 patients. But again, they didn't define very clearly what they meant by progression. And what happened was they did a study. It looked like this cross-linking worked. And because we had nothing else to offer these patients to slow down the disease, the use of cross-linking just became adopted very quickly in a very widespread area. The US was kind of an exception. And it actually just got into common use before a lot of the studies had been done. And then you ran into this problem was, is it ethical to have a control group? We've nothing else to offer these patients. So a lot of the studies aren't great, but typically when we're looking at trying to get people approved insurance-wise for doing cross-linking, what are we looking for? We're looking for an increase in astigmatism of 1 diopter, an increase in their steepest K value by 1 diopter, myopic shift, and then the other two here are a bit more woolly, a bit more fuzzy, failed contact lenses or spectacle correction, progressive deterioration of their best spectacle corrected visual acuity. Those are the kind of things that we may have a bit more trouble getting them approved for cross-linking. So what are the contraindications? Who can't have cross-linking? The first one is corneal thickness less than 400 microns, and I'm going to come back and address that more later. One is prior herpetic infection. We don't want to reactivate that. One is corneal scarring, and this is the pity of corneal cross-linking. So many of our patients with advanced disease, and I still see patients presenting all the time. I have one patient I'm operating on Monday, count fingers in both eyes. At presentation with corneal scarring, she's not suitable, at least in one eye, she's not suitable for cross-linking. And you're also going to look for anybody who's not going to heal well afterwards. Any history of poor corneal epithelial healing, severe ocular surface disease where they're really just dry or diseased, you don't think it's going to heal well, or autoimmune disorders. So performing it, typically do one eye at a time, and we typically wait 1 month between eyes. Why? Because we remove the corneal epithelium. We need the corneal epithelium to recover, to mature, and also corneal haze. Corneal haze is a normal reaction after you do cross-linking. It's typically present and kind of maximizes around 1 month and then will resolve over time. Now, scleral contact lenses can be refit at 3 months. However, refraction can change for years. And the ongoing change in patients' refraction is something we have to be very aware of when we're doing any follow-on procedures. Say, for instance, if you have an older person who then needs cataract surgery, again, you just need to know that the cornea, the refraction is stable before you proceed. So how does it actually happen? What happens? Well, topical anesthesia, then the central epithelium is removed. We put a speculum in, remove the central epithelium. For the next stage, we take away the speculum, and we're putting something called Photrexa, that's the trade name for it. Again, it's just that riboflavin vitamin B. And that goes on every 2 minutes for 30 minutes. After 30 minutes, the central corneal thickness is checked, and the goal is 400 microns. The AC is checked for flare. And again, if we have enough riboflavin on, this should have gotten into the anterior chamber. And then UV light is administered for 30 minutes. And again, this is going to mean that the speculum is needed. And the Photrexa viscous, more of that goes on every 2 minutes. Then right at the very end, we're going to rinse the eye really well with chilled BSS. Again, just to try and kind of keep the patient as comfortable as possible. We'll use a drop of non-steroidal, and a bandage contact lens will be inserted. What can they expect? They can expect that they're going to have foreign body sensation, blurred vision, mild discomfort, and light sensitivity, but they should be back to normal activities over a couple of weeks. They're going to be using antibiotics until the epithelium heals, and then prednisolone, again, to try and help with recovery. They're seen back very frequently, and one thing that they have to be aware of is that the Ks may initially steepen. Their vision may really worsen initially, and after the steepening happens, then they're going to flatten again. Corneal haze, again, which can affect the vision, is going to be worse over 1 month. So what about when you do have a patient whose cornea is too thin? Well, there are two options available. One is that you can use a special type of the Photrexa, a special type of the vitamin B, that is hypotonic, and it helps the cornea swell. And again, if it can get us over the 400 microns, why is that important? Because we're putting this UV light onto the cornea. We don't want the UV light to go too deep. If the UV light goes too deep, it's going to affect the endothelium, it's going to affect the lens, should make its way back to the retina, but it can cause damage if it's going too deep. The other option, kind of an ingenious option, if the cornea is just too thin, and again, typically the issue you face is if the cornea is really, really thin, it's going to be scarred, and then they're not suitable anyway. But if you have a thin cornea without scarring, another thing is getting a contact lens that has no UV filter. Typically, contact lenses have UV filters, but you can get them without a UV filter. So you can actually put the contact lens on top of the cornea. That can act as, again, another spacer to let the UV light not go too deep. So what are the complications? Well, non-healing epithelial defects, that's what everybody worries about. You want to get the epithelium healed and closed quickly. Corneal scarring, and as I said, haze is a normal healing response. It happens in the anterior stroma, and a lot of it is due to kind of a cellular inflammatory reaction Then typically the keratocytes that were killed off will migrate back in, but about 9% of people are going to be left with some scarring. Then we can see peripheral sterile infiltrates, and rarely infection can be seen. And actually why I say rarely is that this does tend to be a sterilizing procedure. All this UV light kills organisms. And some people have actually looked at cross-linking as a way to treat corneal infections. This isn't something that's moving mainstream anytime soon, but it has been used in some kind of really, as a last-ditch effort in some bad situations. So what about the results? As I said, there's a huge issue in the cornea community because the standard of the studies that have been done on cross-linking are really poor. Now, the FDA only approved this. As I said, the research initially was done in Germany in the 90s, came into widespread use across Europe in the 2000s. It was only approved in America in 2017. But the 10-year results are now actually already starting to come through. Because if you think about it, it was FDA approved in 2017, but they were collecting their patients for, from before 2007. So some of these 10-year results are coming through. And actually, one practice published their results. And again, they had very good long-term results. But what was really interesting was that there was quite a few patients they had lost to follow-up. And they actually mentioned how difficult and how much they had to hound these people to come back in for their follow-ups. But that's actually going to be probably one of the best control groups we're ever going to get. And actually hounding these people, going to their homes, physically bringing them in might give us the best information we ever have, because at this stage we're stuck that it's not ethical not to treat, but we don't have good control data. So even in the 1 year kind of FDA trials, we saw that in the trials, people who were treated had a decrease in their K values of 1.4 diopters, whereas the control group had an increase of 1. So that's a 2.4 diopter difference between the groups. Obviously, that's huge. What they did notice were that steeper Ks possibly respond a bit better. And again, you want the Ks, the steeper Ks have more room to improve. We still don't fully understand what happens in terms of the corneal remodeling. When you have a thin protuberant cornea, the epithelium actually thins over that area. When the cornea flattens, the epithelium will thicken again. But there are also stromal changes that we notice. The stroma itself will get thicker after cross-linking. How much does the epithelium impact the stroma? Does the stroma impact the epithelium? What's actually happening with this remodeling? We don't know yet. It's still something under investigation. And then how about the corneal thickness changes? It may actually thicken. The refractions may change for up to 3 years. So the future, what's going to happen, as time goes on? Some things we have to look at. The epithelium, does it definitely need to be removed? There are many different groups, including the group that have the FDA license for epithelium off cross-linking. There's only one group are FDA approved. They're all looking, can we leave the epithelium on? It's going to be a much more comfortable procedure if we can leave the epithelium on. The biggest thing is, can we get the riboflavin deep enough? Can we get enough of it? And they're looking at all different formulations of riboflavin that we can possibly still get to penetrate the corneal stroma without removal of the epithelium. And then what about the treatment time? Is there any way we can do things like pulsing the UV light or adding in oxygen? This is an oxidative reaction. So the idea of pulsing the UV light is that if you have continuous UV light, you kind of run out of oxygen. If you pulse it, you get a better chance for the oxidative reaction to happen. What about if you add in supplemental oxygen? Will that help? Performing at the slit lamp right now, this is done lying down, but could we perform it? There's been a few groups that have performed it at the slit lamp. And then what about looking at this as a refractive procedure? Can we do corneal cross-linking and PRK at the same time? Can we really, really fix you? Can we say, hey, you have keratoconus, we're going to strengthen your cornea and reshape it all at the same time. Your epithelium is going to heal, bang, you're done. This is still kind of being worked out, but I hope that is where we're going to move. And then the big one that I would love, because I still see so many patients with advanced disease, could we do it prior to PKP? I'd love a way to stabilize the host periphery. Because if you remember, when I do a PKP, I always leave 1 to 2 millimeters at the edges. I need to hide from the immune system. So I don't want to go all the way up. But that 1 to 2 millimeter cuff, that actually, that can get disease over time. That can change over time. So even if I do PKP, this isn't going to be stable over the long term. Wouldn't it be great when I have to do a PKP if I could stabilize my host cornea first? So, you know, this is still something that there's a lot to be figured out, but at least we finally have a treatment for these patients. And we would love you to send in any patients you have. One of the big things we are going to try and do here is offer this to Medicaid patients. There's nowhere we're aware of at the moment in Maryland that is doing this for Medicaid patients. It's not a covered service. What we're trying to do is the company will allow us get the biggest cost is getting the medicine, getting the vitamin B medicine. The company will comp us the vitamin B medicine. But what they do is they give you basically a token towards future purchases. So we can't do all Medicaid patients. We need to match them with people who have commercial insurance, or otherwise we can't do it. So the more patients you can send us in, the more we can be of service to our community. So thank you all very much.
You mentioned that people who have corneal scarring are not candidates, but kind of going off of what you mentioned, if you had a patient who had eye drops, for example, and has a central scar that you think is going to need a PKP, would you consider doing it in that case, even if it's not going to be for necessarily the same therapeutic purpose?
I would love to. And the big thing is, are you going to get it through insurance? Oh, sorry, the question, I'm sorry, I forgot, I know, golden rule. So the question was, if you have somebody who had a patient who had corneal eye drops, they have a scar, but you know that they have to go for PKP, you know that you know their vision isn't going to be good enough afterwards, would you consider cross-linking them just to strengthen the cornea before you do it? And I said, you know, yeah, you kind of can't make the situation worse in that, you know, you really, even if you had a non-healing central defect, well, you can just go in and do your PKP. You know, infection rates are really low. It shouldn't be an issue, but I think getting insurance coverage might be the issue, that if they read through the notes that they may not be as happy to do it. I think it's reasonable though. Any other questions? Medicaid, why it doesn't, I don't know. I don't know why it doesn't cover it. And actually, again, it's a very legitimate reason. And Medicaid, I think, as we all know, often underpays for procedures, which is a huge issue with Medicaid. If Medicaid suddenly started covering it, they may drive down the commercial reimbursement so much that it actually isn't worth people's while to offer cross-linking. And it has happened in other procedures where literally people have unplugged the machine, put it against the wall and said, I can't feasibly offer this. You know, because you can't say that I just don't offer it to Medicaid patients, or that I'll only offer it to commercial patients. So it's, you know, one of these genuine insurance issues here in the States. Okay.
How much does the medication cost someone who needs to pay for it?
So if someone paid for the medication out of pocket, how much does it cost? About $3,000 per eye. And then that's obviously that then there would be no operative, you know, that doesn't include any kind of an operative or a clinic fee. But yeah, the medicine itself is about $3,000. So it's a fair whack. Okay, thank you, everybody.
All right, great. Our next, we have two talks for the price of one, I guess. Dr. Mark Hirschbein, our oculoplastics attending, is going to be presenting a couple talks today. We have a slight change in our program. Instead of the second case being presented by Dr. Daigle, Dr. Hirschbein is going to be doing 2 lectures.
All right, thank you, everybody. Thanks for that help, Chow. So the first talk I want to give is on teprotumumab for thyroid-related orbitopathy, what we now know or what we know now. No financial disclosures, no off-label use of this product. So this is going to really be a review of the original teprotumumab study, but more importantly, a review of some of the newer articles that have come out since the 2020 study. This is not going to be an extensive review of pathophysiology or other treatment options. But just as a reminder, we consider thyroid-related orbitopathy a combination of any or all of the classic clinical findings, preferably but not always in the setting of known systemic hyperthyroidism or positive thyroid antibodies, proptosis, motility abnormalities, lid retraction, optic neuropathy, and inflammatory changes. So teprotumumab or Tepezza blocks the IL-1 receptor, thereby preventing the IL-1 autoantibody from binding to the receptor, thus blocking this inflammatory cascade, shown with a different cartoon, but the same process going on. And how do we know that the IL-1 receptor is the key point of attack? And this goes back to the earlier studies by Terry Smith that shows the co-localization of the IL-1 receptor and the thyroid receptor in cells cultured from patients with active thyroid-related orbitopathy, abbreviated as TRO. So the OPTIC trial was the original study published in January 2020. It was 107 patients, eventually had 83 divided into treatment and placebo groups. Overall, the demographics were very, very similar between the two groups, and they kind of parallel what we expect for the disease process, a higher percentage of females, age around 51, race predominant white, duration of thyroid disease was about 6 years, duration of Graves' orbitopathy about 3.5, 20% smokers in each group. Initial proptosis measurements ending the study were about 22 to 23 millimeters, and the initial clinical activity score was 5. Primary outcome measure they looked at first was proptosis response. We'll talk about proptosis numbers also, but they just gauged as proptosis response being 2 millimeters or more. And that was an extremely large percentage in the treatment group. They looked at a clinical activity score reducing to 0 to 1, which we consider to be inactive disease, but we'll talk more about that. Reasonable response. And then again, just to mention clinical activity score, and we've used this well before the Tepezza came out. We used it based on the UGOGO recommendations, which we've talked about before, we'll touch on later. But this is just a really good clinical measure of disease activity, which we consider to be signs of inflammation. So it's the 7 different scores to begin with, 3 on subsequent visits. Going back to efficacy outcomes, they looked at mean change in proptosis, and the average was 2.8 millimeters in the treatment group versus 0.5 or half millimeter of the control group. And importantly, the diplopia response was there, but not quite as high of a percentage. And all these were very significant p-values. So the efficacy outcome graphs are fairly impressive. The top curve, starting out is the teprotumumab compared to placebo and proptosis response. In terms of clinical photos, this is an example of a placebo non-responder. And this is the classic photo we now see of a responder to teprotumumab at 24 weeks. And this is 8 treatments over 3 weeks per treatment. MRIs have been very impressive, especially in the treatment group, especially in the ones they choose to show us. And adverse events, have been relatively low. Muscle spasms and GI complaints seem to be those common things that we're hearing from patients. Since that study came out, there have been some reports about hearing abnormalities, but also some case reports saying that patients are willing to put up with that. So what are the key takeaways from the original OPTIC trial? Well, first, that teprotumumab certainly works. It works particularly well for proptosis reduction in terms of an 88% response rate. And again, that's number of patients who achieve 2 millimeters or greater reduction in proptosis. But we somewhat overlooked that the median reduction was about 2.8 millimeters compared to control of 0.5 or half millimeter. That's good, but if you kind of think about it, we can get greater decompression numbers than just from the teprotumumab. It works fairly well for diplopia. It does show significant reduction in clinical activity score, and side effects have been mild. So what else do we want to know? We've had a few mentions with different presentations today about the cost, and the cost is expensive to say the least, if not prohibitive. It's 8 infusions. This is from the original article when it got accepted by the FDA, $15,000 per vial. And again, that's 8 treatments and requires more than 1 vial per treatment. It's dosed based on weight. So they had an annual treatment course of $343,000. But by my calculation, using the DePezzo website for an 80 kilogram patient, we're looking at almost $500,000 per treatment. So it's kind of not surprising why the drug rep is constantly showing up at my office. That'll be part of talk number 2. So what else do we want to know since that first study? And what's really intrigued us is, does it work for chronic disease or recurrent disease? And this is now the OPTIC X study, which obviously is the follow-up to the OPTIC study. And the way they designed the study, it's confusing and interesting at the same time, or interesting and confusing at the same time. What they did, this was a follow-up study with the same patient population that was in the original OPTIC trial. So first you have the original placebo group of approximately 40 patients that received sham treatment. Presumably they still had active disease and they now qualified to enter the study. So this is basically looking at a group that's had a longer duration of thyroid orbitopathy before treatment. Then you've got the group of non-responders from the OPTIC trial. So they received treatment. They were deemed not to have responded, mainly based on the proptosis measurement. And then finally, you have the disease flare-up groups. These are patients that received teprotumumab, responded, met the endpoints, but then had a recurrence or a flare-up sometime later. And again, this is how these numbers break down again. So this is the placebo crossover group, and ends up with about 30-something patients, 37 in this group. And if we look at these graphs, now this is the OPTIC trial treatment versus the OPTIC X trial treatment. And now you can see how these graphs parallel each other. So it's maybe not that surprising, it was only 6 months, time difference, but it shows that they can still be responsive with a longer duration before initiating treatment. Next, you have the more confusing groups, and these are very small in terms of clinical numbers. You have the 5 non-responders and you have 9 flare-up patients in these next groups. So these are now showing the responders and the flare-up side by side. So the blue is the non-responders, the orange or whatever color you want to call that is the flare-up. And you can see in terms of now these becoming proptosis responders after initiation of this second course of treatment, that the flare-up had a much better response than the non-responders. And that makes sense because we usually, ascribe the response rate based on clinical activity score. So presumably the flare-ups are going to have a higher clinical activity score. So only 40% of the non-responders showed a proptosis response. These are people that didn't respond the first time, went through an entire another treatment. So we're about $1 million of treatment, and only 40% have response. And 60% of the flare-up showed some response, which again, not surprising. When you look at the flare-up group, you can actually get this in the supplemental, you have to click through a few things, but you can get the data for each patient. So of the 9 patients, we have 1 millimeter, 0 millimeter, 2 millimeters, which is good, 4 millimeters, which is fantastic, another 1, 3, which is great, a couple more 2s, and then a 5. So you can see how that would skew the numbers somewhat. And again, that was for the flare-up group. Just looking at the non-responders, the numbers are much lower. So that's 1.5 millimeters over the course of that. So my takeaway, flare-ups, I think it is potentially worth retreating. Non-responders, maybe not so much. We still need to consider surgery or pulsed IV steroids as we've always done. Now, what about truly chronic disease? And we'll consider this not based on duration, but we'll base it on a clinical activity score of 3 or less. Limited data. This was the first case report on chronic disease, which again, just looking quickly at both the clinical photo and the imaging, that's a pretty dramatic response. And this was a patient with a clinical activity score of 1, so we consider that inactive. And a 5 millimeter reduction in proptosis in one eye, 6 millimeters in the other. I have trouble sometimes explaining these numbers, but they're reported. Next, this is a sort of a confusing study. This is looking at chronic progressive disease. So this is almost like the flare-up group, but they didn't receive the initial treatment. This is not from the OPTIC-X trial, but these are patients that have prolonged disease, but still have a very high clinical activity score, and we would expect these to show a good response. So this is still preliminary reporting, and the quote was, all patients improved subjectively by the first infusion and objectively by the 4th infusion. So I'm going to anticipate a very similar response to the original OPTIC trial for that. Another recent study in the journal Orbit, this one was retrospective, only 10 patients, but again, a CAS of less than or equal to 1 with mean proptosis reduction of 4 millimeters plus or minus 3. So somewhat confusing out of 10 patients. This one's interesting. This is also very preliminary data and confusing. This is from some of the authors from the original OPTIC trial, some of the main study participants, and they're looking at the treatment of chronic thyroid eye disease. So disease greater than 2 years. Again, they're now reporting reduction in proptosis greater than the original OPTIC study of 3.5 millimeters with a 90% clinical activity score response. This shows the proptosis improvement, the CAS improvement, and again, not as much motility improvement. So my thought with the motility is that maybe the motility component by the time we're treating the disease is more at the fibrotic stage and less of the inflammatory stage. So for chronic TRO patients, surprisingly promising to the point that I can't explain how good these results are. I'm thinking maybe the IL pathway is just it doesn't, necessarily show the same amount of chronic inflammation, but it's still disinhibiting the situation. But it definitely appears more promising than in retreating the non-responders. Now, I mentioned before the UGOGO consortium, which is what I've always based my treatment on, at least as long as it's been out. This is the European group on Graves' orbitopathy. They release consensus statements every few years. This is their most recent one where they give their recommendations and they give the validity of the scientific data. So number 19 on this is teprotumumab, which they think is very promising. They currently consider it second line still to the current treatments of post-IV steroids. And they mention that it has to do with availability and affordability, but the research they do say is good. All right, what about going back to post-IV steroids? We seem to have forgotten about that. I still think it's an extremely valid treatment. Again, this is an interesting recent meta-analysis in JAMA by the OPTICS trial leader and some of the other OPTICS trial participants. They're comparing post-IV to teprotumumab. My concern with this is that somehow the response rate from post-IV seems to have dropped from what we consider normal of 2 to 3 millimeters to 0.16 millimeters in this study. But obviously they're making the point that teprotumumab still works well. Now this is the original post-IV paper, which like I said, this is the numbers we normally expect, about a 2 millimeter more reduction. And finally, can teprotumumab be used for the management of acute dysthyroid optic neuropathy? Possibly. There's one anecdotal case report which does show good improvement, including improvement of optic nerve compromise. And again, the MRIs are very telling. This second, I'm not sure if I'd even call it a case report. This is in Ocular Surgery News. The problem with this study is that they literally had every treatment possible. So I will certainly be willing to say that one of those treatments worked. So to wrap up talk number 1, it continues to prove efficacious for active thyroid orbitopathy. Current early studies are showing surprising efficacy for chronic orbitopathy, including a low CAS. Flare-ups appear to be responsive to treatment. Non-responders, in my opinion, have limited value of retreatment, and it may play a role in dysthyroid optic neuropathy. And we can all agree that it is very expensive. And the final quote, I'm old to die young and too young to grow up. And this was actually told to a reporter the week before he passed away. This is Marty Feldman, if people didn't know who that was. Thank you very much. Any questions? So the question, which I'm happy to repeat without being reminded, is, do I think there's any value in a different scoring system other than the CAS score for these chronic patients? My answer would be yes, based on the data, but I don't think we've figured anything out yet. You know, it's tough when it's such a prohibitively expensive medication just to kind of throw a dart at it, but the results continue to be surprisingly good. And I tell the residents often, you know, I've followed Terry Smith's research from the beginning because it was my one missed opportunity that he was actually at Albany when I was there for fellowship, and my preceptors told me to go over and talk to that guy about doing your ASOPers research, and I didn't walk across the street to end up working with Terry Smith. So I know the data is extremely good. Any other questions? Yes. The question is, again, repeated without being reminded, how easy is it to get insurance to cover it? It's a process, and it's a process I don't really feel like dealing with. So luckily my staff is very, you know, committed to doing this. And obviously the drug reps and everybody from the Horizon company, I have no financial interest in Horizon. They do everything possible to get these covered. All right, if I can have my tech support up here to switch talks. Okay, so on to topic 2, and I've hinted at this, and it's come up in a few other talks somewhat indirectly, but we'll touch on some of the things that were talked about today. I've developed an interest over the years in medical ethics and, you know, medical practice, and I thought we'd stop and talk about the real cost of prescription drugs in this country. I will provide financial disclosures by the end of this talk. So we touched on the cost of teprotumumab, but what about all the other prescription medications? So there's a lot of data out there. And honestly, this is a rabbit hole that you can just keep going down all night long if you choose to. But in 2016, the US spent $3,337 billion, or 18% of the GDP, on national health expenditures, of which $329 billion was spent on prescription drugs. More than 3 in 4 adults in the US think that the cost of prescription drugs are unaffordable and that they may not take their medication because of that cost. And if we look at slides, this is the cost in the United States from 2004 to 2019 compared to other similar countries shown averaged in blue. So the last year for comparable data, the US spent $1,100 per capita on prescribed medications compared to $552 on average for other similar countries. And again, this is shown breakdown. Purple is insurance coverage or national health coverage versus blue is out-of-pocket expense. Just looking at some drugs out there, and you can see, and this doesn't surprise any of us, that for every single drug, the US pays significantly more than other similar countries. We'll talk about Humira later. Also in the US, and you know, this may be study bias, but we have a higher percentage of patients taking drugs, which contributes to the overall cost to our economy. So how have costs gotten so out of hand? The drug companies like to tell us that's the cost of research and development, so we're going to touch on that. Maybe it's more the cost of marketing. I think that a contributing factor is the US consumers' expectation to receive all treatments regardless of cost. And part of it is that we don't have a centralized payer system that can allow us to negotiate better. So Focusing on research and development costs. There's a recent article in the Atlantic that really calls into question some of these explanations that Big Pharma always gives. One of the companies, when asked why things are so expensive, basically say, in other words, the prices are necessary to fund expensive research projects to generate new drugs. Therefore, they spend more on research and development. But this study that's referenced in the Atlantic article evaluated the top 20 selling prescription drugs in 2015. The confusing statement, but they found that the profits earned from the US alone for these drugs was more than enough to fund the entire company's R&D for all products. So if you look at it another way, if you look at this graph, the 100% line, anything above the 100% line is profit, and how much of that profit could fund the entire R&D development for that, not just for that drug, but for the entire company. So you can see for each company, for Biogen, they have 2.5 times what they need just from the profit from US sales to fund all of their R&D. So to account for all research costs about 80 billion a year, drug companies had 40 billion more on top of that just from the top 20 drugs alone. Then you look at the next 100 to 200 brand name drugs, and that's going to continue to add to those profit margins. Sorry. So when they talk about having to fund the cost of unsuccessful drugs, they kind of debunk this as well, because 90% of drugs that enter human trials fail, but most of these fail very early on at phase 1. That's 40% of them at a cost, we're using the phrase just, but in terms of the number we're talking about, 25 million, compared to the billions we're talking about. And then the next group that failed during phase 2 is probably another 60 million per drug. They find a quote from the former Pfizer CEO. If you look at the last line, he talks about how they decide on the drug, but basically says it's the anticipated income stream rather than repayment of sunk costs. That's the primary determinant of price as far as the drug companies are concerned. We know that these drug companies, through the patent system, they essentially have a monopoly on these drugs. They exist for 20 years. You assume that most drugs take 8 to 10 years to develop. So that gives them 10 to 12 years while they still have the patent going. But the patents, they keep finding little tweaks to the patent to extend it even further. So let's talk about Humira. So this article came out within the past few years. The House committee uncovered that they spiked prices by 470%. And you'll see there was tremendous price growth even before then, once they started tying it directly to the executives' bonuses. So in the first year that they very clearly tied bonuses to drug profit, the cost or the revenue from here rose from 6.5 billion to 8.4 billion over just 1 year. And I'll blow this graph up. This is still from the time this started in 2003, it cost $500 a vial. It's inexplicably gone up to $3,000 a vial over this 17-year period. Amgen's competing drug Enbrel literally mirrored Humira's prices. So talk about price fixing. So you can't even separate the two lines. They went lock and step. When one company raised their prices, the other one, they even say in the article, they gave them a high five and they raised their prices the next level. So if it's not R&D, where are they spending their money? Well, a lot of that goes into marketing. So if you look at this breakdown here, 18 cents, some articles say 22 cents in profits on every dollar, 19 to 20 cents in marketing, and the other costs are listed there. I'm quite jealous of the 10 cents out of the dollar that goes to their taxes. Since the FDA loosened the requirements or the restrictions on advertising, the amount spent on advertising has gone up exponentially from 1.3 billion in 97 to 6 billion. This is marketing to consumers. We'll talk about marketing to us later. So like I said, in 2016, they spent $6 billion on 4.6 million DTC direct-to-consumer ads, including 660,000 television commercials. Coupons, we're always telling our patients about coupons, but that's just another form of marketing for them. The more coupons they put out there, they're going to steer patients towards the higher priced drugs. It just increases their profits, doesn't lessen them. And does direct-to-consumer marketing work? Absolutely. Another hidden marketing cost is the funding of consumer advocacy groups. And I'm not saying these things are necessarily wrong, but we need to be aware of it. And even going back to Tepezza, if you search on thyroid eye disease, this is the first hit on Google. And it's this wonderful thyroid eye advocacy group. It's got a lot of great information. but not surprisingly, it's funded by Horizon, the company that makes Tepezza. And we just need to be aware of that. You know, sometimes for some of these less common diseases, this is the only source of funding and recognition these diseases can get. So there's value to that. But there's also some interesting articles I didn't have time to present where the drug companies use these literally orphan patients to kind of bog down, you know, all of Congress with what's going on. And that gets the hitting marking of lobbying expenses. So the pharmacy industry spent approximately $360 million on lobbying in 2021. One of the later comments that I have, they actually have 2 lobbyists for every member of the Congress and the House. All right, so let's turn the spotlight briefly on us as medical professionals. Where do we fit into this equation? TANSSAAFL, there's no such thing as a free lunch. Popularized by Milton Friedman, actually occurred before then, but he's kind of credited with it. So Big Pharma shells out $20 billion each year to schmooze docs, $6 billion on drug ads. We already knew about the $6 billion. And this is back to that earlier slide. So marketing physicians went from 15.6 billion in 97, supposedly at the time when they started having greater restrictions on physician compensation or physician paybacks, whatever you want to call it. It's still up to 20 billion in 2016. Half of all US doctors accept some form of compensation from the drug industry, even if that's just a quote unquote free lunch. And that total is more than $2 billion. The group from Sloan Kettering performed a meta-analysis of 36 other studies or reports, I'm not quite sure, and they, not surprisingly, found a positive, strong correlation between financial incentives and physician prescribing patterns. I'll read some of these quotes. The results were unanimous. All 36 studies showed that receiving industry money increased prescribing, consistent across all medical specialties and all types of drugs. These money-fueled nudges harm patients. It led doctors to prescribe, in their words, expensive, worthless drugs with more severe side effects in the case of leukemia. It causes them to deviate from prescribing guidelines. And obviously, we all know about the opioid epidemic. So how does Big Pharma justify these physician marketing expenses? First, they say is that it's to provide information that, you know, the drug reps are the main source of information. That's how they kind of get the job done. But the evidence shows that the industry information is often biased, which makes them worse prescribers, not better prescribers. The next defense that they say is that they're funding innovation. But as we've talked about, the amount of money spent on R&D are separate categories that has nothing to do with the money that they're spending, you know, doling out to doctors. Here's a list of the prescription drugs with the top spending, and Xarelto is topping the list for 2016, 2017, 2018. You know, and the numbers are staggering. These are doctor payments. These aren't just their marketing campaigns. The number of what they call big ticket promotional speakers, I'm getting no money for this speech, by the way, is up more than 30% in 5 years. These are physicians who receive $100,000 a year or more as direct payments from the drug companies for giving speeches. One case study, they looked at Avenir Pharmaceuticals. From 2014 to 2018, they spent $22 million on this drug, Nudexta, which treats pseudobulbar effect or uncontrollable laughing or crying. Somebody that was interviewed by the prosecution talked about one of their paid physicians who put entire units at a nursing home on this drug, even if it wasn't really recommended for their disease. Another doctor in the same facility would take them off the drug only to have the first doctor put them back on the next day. They were eventually fined $108 million to resolve the criminal complaint. So there's a website I came across called ProPublica that actually keeps a detailed database of physician payments. So literally this shows 12 billion in payments to over 1 million doctors, 1,200 hospitals. It breaks it down by the top 20 companies in terms of highest amount. It breaks us down to the highest earning doctors, and the numbers are staggering. There is an ophthalmologist on this list. I don't know him. I think his is more for developing the product than for payments from the drug company. But again, the numbers are just staggering. And it's an extremely, extremely detailed list. So here's my financial disclosure. Apparently in 2018, I paid $49, I'm assuming, for food. I'm pretty sure I didn't eat any of it. Now, another reason I think that prices are so high, this is what I call the Veruca or the Veruca salt effect. And I mentioned this before. The American population as medical consumers think that we're entitled to everything right away, regardless of cost, regardless of time, regardless of what else is going on in the world. And we want somebody else to pay for it. But maybe that can't continue. So what else can we do? Let's go back to some of the earlier slides. We need to get from this number somewhat closer to this number. So why are drugs cheaper in the United Kingdom and other countries, sorry. It's simple. In the case of the UK, they have a national health system that's the main purchaser of drugs. This gives them strong bargaining power, but also they can and they do decide to limit which drugs they're going to carry and provide. You got some great acronyms here. So the National Institute for Healthcare Excellence, NICE, evaluates drugs and negotiates with the drug companies. NICE uses a metric known as QALY, the Quality Adjusted Life Years. This was actually invented by a US economist, but it's used primarily by the UK and some other countries. So I'll show you how this QALY works, but the agency usually only approves drugs that cost less than £30,000 per quality adjusted life year, which is equal to a year of life in perfect health. So the QALY score, if you look in the dark blue, this is without intervention. So, you know, along the vertical axis, that's perfect health and happiness. Along the horizontal axis, that's life longevity. So they compare that, you know, so you can a drug can either extend life or improve quality of life, and they factor those both in. It's a simple equation. If you have 1 year of perfect health, that's one QALY, or if you have 2 years of 50% perfect health, that's also one QALY. They can also use this metric to compare a current treatment to a new treatment. So you're looking at the delta between the two. So how are QALYs used in this situation? Basically, if it's under 20,000 and there's, you know, valid research, they'll approve it. If it's 20 to 30,000, they'll approve it as long as there are certain criteria met. And if it's over 30,000 per QALY, certainly Tepezza would fall into that category, they're not going to rush to approve it. So I'm not saying that this is the only option, but I do feel, and this is not a political statement, but I feel like as a country, we need to do something about this. So what was brewing in the US is HR3, or was HR3, which was a pretty aggressive attempt to control some of these drug costs. It was supposed to give Medicare the power to negotiate with the drug companies as a quote unquote single payer, but it was then going to apply the negotiated prices to all insurances, even private insurances. It was going to stop the drug companies from overcharging the US compared to other countries, create some out-of-pocket stuff, yada, yada. It sounded great. It had tremendous bipartisan support, 80 to 90% bipartisan support, but somehow when push came to shove for both the past president and the current president, it disappeared. So even in the new spending package, or whatever they call it now, the Build Back Better, this has been watered down to the point that all they're going to allow, do I have it on this one? All right, so here's the compromise version. They're going to be able to negotiate the price of 10 drugs beginning in 2025, expanding to a maximum of 20 drugs by 2028. And the drugs that are preliminarily on this list are drugs that have already been on patent for at least 10 years. So with the current watered down, they're saying that over 10 years, that'll save the US government $80 billion. With the original version, it would have saved $500 billion over 10 years. One more point, in a recent book talking about how to fix this problem, John Abramson said that if we had a super bill called HR3 XXL, and we paid the US government $1 trillion in drug revenues, that would still leave the industry one of the highest percentage returns on investment of any industry. So to sum it up, I feel the rising cost of prescription drugs are crippling our economy. We as a society can't expect to have every treatment right away. Big Pharma has to be a little more realistic on their profit structures, and we need to all accept some responsibility for what's happening. Thank you. The question is, do I think is it ethical for physicians to buy stocks in their personal accounts in the pharmaceutical industry? I think it's a good question. I mean, you can make an argument both ways. I think it's okay. You know, some people argue it's the same question. Should you invest in, you know, an arms manufacturer or something else? I think, you know, if you're choosing just to say that you're going to invest in the free market, and you're going to go where the profits are, then you can choose to do it. You know, I don't think one person not investing is going to really change, you know, the face of that industry. So, you know, I think you have to go with your own ethics at that point. Yes.
Like, for example, I use a lot of adalimumab, right? As a uveitis specialist, and I've been appalled since I've been a fellow. It's essentially double the price, right? It's the same product. But at the same time, there's such good evidence to move to that as an almost a second line agent now versus a second anti-metabolite. So in my individual patient, oftentimes I feel compelled to move them that way. But from a societal thing, maybe I should try the second line anti-metabolite that's half the cost and see if that's good enough. That's what's hard for me.
So I'm going to repeat the question verbatim, word for word. Actually, I'll distill it down. So the question is, if we take any imamimab that's out there right now, that we always know once it ends in imamimab, you add a couple of zeros to the end of the price, and we have the individual patient in front of us, and we feel like that's the best way to go at that moment. How do we balance out what I'm saying is the appropriate thing for society versus the appropriate thing for that patient? I think we make the hard choice as a society. I mean, you know, it's somewhat freeing, I would think, if you're in England and the United Kingdom, when you can say, hey, sorry, not an option. You know, I mean, and we're talking about numbers so prohibitive. It's not like saying, oh, you can go fly down to the US like they used to in Canada to get your fancier cataract surgery. So I think we can do it. I mean, I didn't even touch on, there are countless studies that some of these end-of-life cancer drugs, you know, they've been rushed through because, you know, the support groups, which are basically, again, funded by the drug companies, want these drugs out there right away. They cost hundreds of thousands of dollars, and a large percentage of them have no significant increase in the duration or the quality of life. They probably worsen the quality of life without significantly increasing the duration. So I think it's okay as a group of medical providers to say this just isn't realistic. All right, thank you all.
All right, thank you, Dr. Hirschbein. Okay, so we are going to take a short break. We will come back at 1:30. All right, thank you. And at 1:30, we'll be having a talk with Dr. Sonal Tuli from University of Florida. All right, thanks everybody. Welcome back. We are going to move on to our next named lecture. We have Dr. Sonal Tully, who is joining us from Gainesville, Florida. Dr. Tully started her medical education in Mumbai, India, and subsequently traveled to Beaumont Hospital in Michigan for her internal medicine internship before completing her ophthalmology residency at Indiana University. She then did her cornea fellowship at Bascom Palmer Eye Institute before traveling a few hours north to the University of Florida. She has served many roles at UF, from cornea fellowship director to residency program director, and now serves as chair of the Department of Ophthalmology. She's very active in the AAO and has received several teaching awards, numerous publications, and has given talks all over the world. We're very lucky to have her here with us, albeit virtually. So thank you, Dr. Tully, for joining us.
Thank you, Parvati, for that very kind introduction. Thank you for having me. I've had a wonderful time today. I've learned so much, and I always learn a lot from you and Laura Green about how to educate. So thank you for that. So again, welcome everybody, and thank you for listening to me. I'm going to talk about ulcerative keratitis. I have no financial interest or relationships, but I will be discussing some off-label uses of medications. And please feel free to put stuff in the chat box if you have any questions, or pipe up, unmute yourself. I don't have a problem with that. So basically what we're going to talk about today is what are some of the classic features of different kinds of corneal ulcers. And I'm hoping everybody can hear me well. If not, let me know. And even though I say this, we know from studies that it's very hard to tell different kinds of ulcers and what the diagnosis is, even for corneal specialists. It's not much better than basically tossing a coin. But it does help if you can start thinking about what the ulcer might be caused by, because that might help you target your treatment. And then we'll talk about some of the medical treatments and some of the surgical treatments for corneal ulcers. So the most common thing you'll see when you look at a corneal ulcer is going to be bacterial, right? And you really want to start making that diagnosis or thinking about that diagnosis when the patient starts talking. We know that contact lenses are by and large the most common cause of bacterial keratitis, but these patients will come in and they'll give you a very discrete history. And they'll say, yesterday at 4 o'clock, or when I woke up this morning after sleeping, my eye was hurting and I took my contact lens off, my vision was blurry and it got worse over time. And the reason for this discrete time period is that bacteria replicate very quickly. And so before it gets too far, they have caused a problem, and patients are aware when they have this problem. Now, everybody complains of pain when they have a corneal ulcer, but again, looking at the type of pain patients have is really important. So these patients with bacterial keratitis will complain of a foreign body sensation. So they'll complain of a rock in my eye. Every time they blink their eye, it feels like there's something in there. They'll have mucopurulent discharge. And even the gram-positive bacteria are much more common in the community. At academic centers, we tend to see more gram-negative because they are more severe and they end up reaching us because they don't get treated medically. So how do you tell if it's a gram-positive or a gram-negative? And again, this is not perfect, but when you look at the picture on the left, you can see the soupy discharge, which is basically necrotic cornea, right, falling off of the eye. So this bacteria is very virulent. It's causing a lot of damage. It's causing a lot of inflammation. And so you can see that layered hypopyon in the eye, lots of mucopurulent discharge, and then lots of destruction of the tissue, so they can melt through very quickly, cause perforations. And the edges are typically ill-defined because this is replicating so fast and causing so much inflammation that you really can't form these discrete borders. And you can see over here too, hopefully my arrow shows up, but you can see this ring starting up superiorly. As a gram-negative or the gram-positive, on the other hand, much more discrete borders, less inflammation, edges are well-defined, and not so much discharge. And sometimes these can actually form intrastromal abscesses. So if you try to scrape it and you see it fluctuating, that can be a little bit of an abscess, which will help you think that this is gram-positive. Every resident on here should know immediately what this is. So this is crystalline keratopathy. Why does it look so pretty though? So the reason it looks so pretty is because what are these patients all on? They're all on steroids, right? When they get this infection. So there's no inflammation, problem with no inflammation. The good thing is it looks very pretty. The bad thing is you have no inflammation fighting this infection. And so these are basically chains of strep or enterococcus growing between the corneal lamellae, which is why it looks so pretty. Problem is also they form a nice little glycocalyx around themselves, and that protects the organism. And so most of these are very hard to treat medically. By and large, I've had to do corneal transplants on a majority of these patients. Often they've already had corneal transplants, but they end up needing surgical intervention much more frequently. So how do you manage a bacterial ulcer? Well, simple. So other than very tiny peripheral ulcers, my residents know they have to scrape and culture and send for smears, everything that's central, larger than 1 to 2 millimeters. And then you start them on immediate fortified antibiotics. And again, how frequently? Very quickly. And why is it so frequent? Why do you put them on every half hour? How quickly does a Pseudomonas replicate? So if you have one Pseudomonas, how long will it take it to become 2 Pseudomonas? And so I know we can't answer questions, but if you want to pipe up, feel free to, but it's about 20 minutes. So if you have one Pseudomonas again, and you leave that Pseudomonas alone and don't fight it, how many Pseudomonas would you have in about 24 hours? So about 300 trillion. So lots and lots of Pseudomonas, right? So it replicates very quickly. So if you put the antibiotics in less frequently, now you're letting the bacteria replicate and you're just chasing your tail. So you want to put them in very frequently. Some people will start every 5 minutes to begin with, try and kill as much as you can, and then put it in every half hour. So I tell them to put one of them on the hour, the other one on the half hour, through the night, at least for 24, maybe 48 hours if they can make it. And we typically start something that covers gram positives and negatives. Tobramycin, I tell my residents, if I was on a desert island, I could only take one antibiotic with me. What would I take? Tobramycin, probably, because it covers gram positives, it covers MRSA, it covers gram negatives. But you usually put them on 2 antibiotics and then change it based on your culture results. We'll talk about steroids in a minute, but I do insist that they put people on cyclopentolate. There's nothing worse than treating a corneal ulcer very well, get a nice little scar, and then their pupil is completely stuck down and they get angle closure glaucoma. So you want to keep their pupil mobile, you want to help them with the pain, and so you put them on cyclopentolate. I don't typically use oral or subconjunctival antibiotics, but if you have somebody who's non-compliant, a child who may not let you put drops in, you could supplement these things. Now I'm going to go through this just to see that, depending on what organism you have, you might need to change the medications so that it's efficacious. SCUT was the study that was done, the steroids for corneal ulcer study, that was done to definitively decide, do you put people who've got bacterial keratitis on steroids? Is it helpful or is it harmful, right? So does it help with the healing, with the reduction in the scarring, or is it harmful? Does it cause melting and you will get perforations? So what they found was that really didn't make too much of a difference whether you put them on the steroids, no harm and no benefit. Now I put a little asterisk there because the study was 90% done in India. So the bacteria and the treatments are a little bit different, and these patients were not put on fortified medications. They were put on fluoroquinolones. So maybe take it with a grain of salt, but they did find that larger, central, deeper ulcers did benefit. And if you started that early, that was better than starting it late. So unfortunately, though, if you had nocardia, they did much worse with steroids. Fortunately, we don't see a lot of nocardia in the US, but you have to be careful. In the US, again, in South Florida, or mid-Florida, where I am, you have to be really careful about fungus too. So you really want to take patients who have bacterial keratitis, or you've proven have bacterial keratitis. And so usually you'll get, with Pseudomonas, the results back within a day or two, and then you can put them on steroids within 48 hours and then watch them carefully. The person you never want to use steroids on is fungal keratitis. So depending on, again, where you are in the country, you might see fungal keratitis very frequently or very little frequently. In my residency, I saw maybe one throughout my residency. Here at Florida, I see maybe one every 2 weeks, one every week. So lots of fungal keratitis here. Now, again, it's a little biased because we get all the bad stuff. But we were always taught when I was growing up that trauma was the major cause of fungal keratitis. We know now that contact lenses has far surpassed trauma, even for fungal keratitis. These patients will complain a little bit slower. So they will say, 4 or 5 days ago, my eye started bothering me. I took my contact out. It was a little blurry. I put a new one in. I felt a little better. And then I took it off again and it was getting worse and my vision went down. So a little bit slower progression, less discharge from the eye. And these people will complain of the foreign body sensation, but more than the foreign body sensation, they'll talk about, like we talked about in the scleritis talk, more of this deep throbbing pain, like a toothache in my eye kind of a pain. If you get that more toothache pain with something that looks like a fungal or a bacterial keratitis, start thinking fungus, especially if they're a contact lens wearer in a warmer climate. What are some of the features that fungal keratitis make you think fungal keratitis? So these feathery borders, right? And we think of feathery and we think of pretty feathers. And these are not pretty feathers. These are not like the little crystals. These are not like HSV that we'll see in a minute. These are sort of ugly pseudopods sticking out because fungus is growing within the corneal lamellae. So when you see these pseudopods sticking out of the eye, or out of the cornea, that should make you start thinking fungus. When you see rings, especially with this feathery ulcer in the center, again, start thinking fungus, or at least think of fungus as one of the things that can cause this. And then you'll see satellite lesions and these endothelial plaques. We'll talk about that in a minute, and a formed hypopyon. And certainly if you see pigmentation in an ulcer, then you know what your diagnosis is without any problem. So talking about formed hypopyon, what's a formed hypopyon? So normally, when you see a hypopyon, it's a layered hypopyon, like a boat. It's because there's PMNs in the eye from all the inflammation. These are not infections. So if you have a pseudomonas with a hypopyon, that hypopyon is not pseudomonas in the eye unless the eye is perforated. So that's usually a reactive hypopyon. These patients, though, will have these hypopia that have a mind of their own. They're not layered out from gravity. They're sort of sitting up like a mountain. And this picture shows really well why you get these. So these are fungus can actually get through an intact Descemet's membrane. So you don't have to perforate an eye to get fungus in the eye. And you can see that on this anterior segment OCT. The fungus is sort of grown through the cornea into the anterior chamber without dissolving the cornea itself. So when you see a hypopyon in a fungal ulcer, or what you suspect is fungal ulcer with this formed appearance to it, you should start thinking fungus, and not just fungus, that the fungus is actually in the eye and you want to treat that a little differently. So just like bacterial, I like to treat everything with 2 medications. So you want to take any 2 of the 3 big 3, natamycin, amphotericin, or voriconazole. There are others you can make up, but these are the most commonly used. And then again, change based on the organism. And this treatment is much longer than bacterial keratitis. You want to treat them for at least 2 to 4 weeks. If they've been on steroids, you often have to treat them much longer. Never ever use steroids to treat these, even if you think it's better. Let them scar up, and you can always take care of the scar. If you put them on steroids, they'll get much worse. And then these patients, fungal keratitis, I do treat with adjunct treatment very frequently, and that has really changed my practice. We would take these patients to surgery much more frequently, and now that we're doing more intrastromal, intracameral antifungals, the rates have gone down substantially. So again, you don't have to belabor this, but if you have a filament, you really want to use natamycin and ampho. Aspergillus really responds to voriconazole, and then Candida, natamycin doesn't do much for. Again, if you're on a desert island and can only take 1 antifungal with you, amphotericin is probably the one to take with you because it covers both filaments, Aspergillus, Fusarium, as well as Candida. So the MUT study was done similar to the Scott study, but this time looking at the comparison between voriconazole and natamycin, because people were moving more and more towards voriconazole for fungal keratitis because it's much easier to get. It's much gentler on the eye. It doesn't cause that chalky stuff in the eye. And all you have to do is take a vial and pull it out, and that's your eye drops, 1% eye drops. But what they found was that voriconazole was really not as good as natamycin for filamentous fungi, and especially Fusarium did not respond to voriconazole at all. So they suggested not using that as monotherapy. And so if we do use voriconazole, I usually use that in conjunction with either ampho or nata. MUT2 looked at adding oral voriconazole to topical natamycin for filamentous fungi, and they found that it did help, but it did have significant side effects, again, for Fusarium, not for all. Getting to more tough things, acanthamoeba incidence again is increasing. And here it's pretty much all contact lens wearers, though we did find about 10% were trauma in our cases. And this is a tough thing to diagnose. Most of our patients were diagnosed at an average time of 4 weeks. So now a lot of them came in 4 weeks later after having been treated. And the other thing that was very common to all of them was HSV. So 50% of them that came to UF were treated for HSV before we diagnosed them with acanthamoeba, and 100% of them had been suspected to be HSV before they came to us. Now, this pain is again a little bit different. So we talked about the foreign body sensation. We talked about the toothache in the eye kind of pain. This, I tell my residents, is the jacket over the head kind of a pain. So these patients are have a lot of pain. They're eating in the dark. They're showering in the dark. They can't turn the lights on at all. And they'll have a jacket over their head. They'll have 2 pairs of sunglasses and so you can diagnose these people walking in the door. And so this is the earliest signs of acanthamoeba. This is not something we think about typically. It looks like a dendrite, but it's an ugly dendrite. And we'll look at some pretty dendrites later, so you'll see why this is an ugly dendrite. But this is raised epithelial lines, and that's the earliest diagnostic feature that you'll see. If you diagnose them at this stage, you'll be a hero because you'll scrape all this off the eye. They'll be treated even without medication. But most of the time, by the time we diagnose these patients, they've got ulcers. But if you see these perineuritis, then you have your diagnosis, because really nothing else causes these perineuritis where the amoeba attacks the nerves. And that's why it's so exquisitely painful. But you can get these stromal infiltrates, intrastromal infiltrates, without damaging the epithelium, or the epithelium heals up. You can also get ring ulcers. And so again, treatment, same protocol. You take 2 medications. We used to use either PHMB or chlorhexidine, along with either Broline or pentamidine or hexamidine. These have gotten really hard to find unless you can have your patients order these online. They're over the counter from England or Australia. So we've been at least starting out with both PHMB and chlorhexidine. These patients have to be treated for 6 months. You start them on 2 medications, and then you can cut them down to 1 after 2 months. Some people have found that oral medications, Vori or miltefosine, might help. We haven't had a whole lot of experience with this, but medications do treat these, but it is a long treatment. Very quickly about herpes, because this is a 2-hour talk just by itself, but because it's my favorite, I wanted to talk about it. But herpes basically doesn't cause an infection when you get the infection. It's reactivation of latent herpes in your trigeminal ganglion. We were talking earlier about serology for herpes, and I really don't do serology at all because of the way it's transmitted. It goes through the nerves. So there are people who are seronegative that actually have HSV, and most people are seropositive, so you can't really tell that they have herpes just because they are seropositive. But just to artificially divide it, the epithelial infections are by and large live virus, whereas the stromal infections are by and large an immune response to dead virus in the stroma. Necrotizing, on the other hand, is both infectious and immune, so you would treat it differently. Now, in these patients, the sensitive sign you have is the opposite of pain, right? So not having pain. So you'll see an ulcer on their eye, and they will not be complaining of pain. They might have a little photophobia, but they really don't have a rock in their eye. And then when you look at the epithelial disease, you want to look for this dichotomous branching and terminal bulbs. And when you look at stromal disease, you want to look for granulomatous keratic precipitates, and that should make you start sort of thinking that this might be HSV. So here you can see this nice dichotomously branching. You can see these bulbs at the end. You can see that here it's branching in 2s. The edges stained with rose bengal classically. And even in this geographic ulcer, you can see how the edges stain, that are infected cells stained with rose bengal. The center will stain with fluorescein because there is an epithelial defect. This is epithelial disease. In stromal disease, you can have it without necrosis, so that will look just like a little dusting or little patchy areas. Epithelium is intact, endothelium is intact, and you'll have white cells in the stroma. Whereas in necrotizing HSV, so stromal disease with necrosis, it'll look just like a Pseudomonas or gram-positive ulcer. So the dead giveaway here is that you will often find granulomatous KP on the endothelium next to this, and patients will come in complaining of my vision's blurry, not that I feel like there's a rock in my eye, even though they have a large epithelial defect over this area. You can have endotheliitis, what we used to call disciform keratitis, and you can see how this is a disc shape. We used to call, can be confused with a ring ulcer, but this is not really a ring. This is a ring of endothelial damage. So endothelial cells are all chock full of white cells, lymphocytes, and that's why the endothelium cannot function. So the stroma swells up. This is not really stromal infection. This is just swelling of the stroma over this ring of endotheliitis. And then if you have long-standing stromal disease, you can start growing blood vessels and get a pannus or get interstitial keratitis that can then leak and cause lipid keratopathy, which is really the most common reason we do transplants in these patients. So how do you treat HSV? Epithelial disease, remember live disease, so you want to treat with topical or oral antivirals. They're thought to be equally effective. Certainly, if you have any problems with your gut, you will not absorb oral antivirals. And the other thing to remember is that acyclovir has lactose in it. And so if you're lactose intolerant, you may not absorb acyclovir. So you might need to go to topical or something else. Debridement, I love that for epithelial disease because now the cells that are infected are not adherent to the eye. So if you take a cotton tip applicator and just wipe the eye gently, you'll take all the infected cells off, and now you can treat them in 3 days rather than 2 weeks. So I debride them and then put them on antivirals. Stromal, no live virus, so you want to treat them with steroids to get rid of the inflammation, but I do treat them with oral antiviral prophylaxis because we know that people who have herpes, the more herpes they have, the more likely they are to reactivate and recur. And people shed by HSV at all times without realizing it. So if they happen to be shedding HSV while they're on steroids, they will get a really nasty geographic ulcer. And that was what this previous patient had. Right here, this patient was on steroids and so had this really nasty infection. So I do put them on oral antiviral prophylaxis so they don't get a bad disease if they happen to shed live HSV while they're on stromal keratitis. Necrotizing, you want to throw the kitchen sink at them. So you treat them with oral and topical antivirals to get rid of the HSV, the live HSV. And after 24 to 48 hours, you do need to put them on topical steroids or they'll melt through the cornea and get a perforation. Again, you know this, but these are the only 2 topical medications available in this country, trifluridine, ganciclovir. Trifluridine is much nastier, causes a lot of inflammation, and systemically, the typical things we use are acyclovir, valcyclovir, which is a prodrug of acyclovir, and then famvir, which works a little bit differently. Whenever you see an ulcer, do not forget to look for a cause. If you have a contact lens, great. If you've had trauma, great. But if you can't figure out what caused this ulcer, look for things like lag ophthalmos. Sometimes people will not tell you that they can't close their eyes, and you can't tell unless you ask them to close their eyes gently. Look for anterior or posterior blepharitis. Check their for dacryocystitis. Press on their lacrimal system to see if they get a gush of mucoid stuff coming back out. Have them squeeze their eyes really tight to see if they develop an entropion by squeezing their eyes, and always check a corneal sensation to rule out HSV or HSV with a secondary infection. If you can't figure out what the diagnosis is, like I said, we culture all of these patients except for very tiny peripheral ulcers, and I usually culture them with vanilla, chocolate, and strawberries, what I tell my techs to bring. And then you want to do thioglycolate broth or some other broth for anaerobes. You can use all kinds of things. You can use calcium alginate swab. You can use a blade like this, a 69 number blade, which is dull, so you won't perforate through the eye. I really like this because you can get, especially for fungal, you want to get a pretty deep culture. You don't want to be very gentle. Always remember to culture at the edges of the wound because that's where the replicating organisms are. But this blade just helps you get a little bit more tissue. And then viral culture medium, we always send at least 2 smears for gram stain and GMS or silver stain, which shows acanthamoeba and fungus. So 2 smears. If you have access to a confocal, that's great. That's how we are diagnosing most of our fungal and acanthamoeba these days. If you're lucky enough to get a good picture, usually it looks like a little blur and you have to squint your eyes and kind of imagine what's going on. Adjunctive treatment, we've talked about the medical treatment. What are some of the adjunct things that I like to do for corneal ulcers, especially rapidly replicating ulcers? The reason they're melting through the eye is because they have proteases, the matrix metalloproteinases, which basically act like meat tenderizers and melt the cornea. Doxycycline chelates these proteases. So I put them on oral doxycycline. You can load them up with a couple 100 milligrams and then go down to once a day. And then if they're intolerant to doxycycline or any of the tetracyclines, you can try erythromycin. Vitamin C is an adjuvant to the collagenase inhibitors. So I like to use this. So we always put patients that have got bad ulcers on some sort of a tetracycline and vitamin C. We talked about steroids again, decrease the rate of healing. They do reduce the production of collagen and keratocyte proliferation, so that's bad. But in inflamed eyes, the white cells are actively producing these collagenases. So if you use the steroids, you will calm things down and actually prevent damage. So if there's inflammation but no infection, definitely use. If there's no inflammation, do not use. And if there is an infection, make sure you know what you're treating and then use cautiously along with those antimicrobials. Again, I talked about intrastromal injections. This has really changed the way I practice with fungal keratitis. It produces a little depot in the eye. Most of the antifungals don't penetrate very well. So you take a 32 gauge needle, what the retina guys use to put stuff into the vitreous, and then use either amphotericin or voriconazole. These are the intravitreal doses of these medications. And so you use that, right. So if this is the ulcer, this is a therapeutic PK that we did for a fungal keratitis. And then at the end of the case, we gave intrastromal injections all the way around. But if you assume this is a fungal ulcer, go outside the ulcer and then make a bleb, sort of hydrate the wound like you would with cataract surgery, and make a bleb that goes into the ulcer. You don't want to really go into the ulcer, because if you pop into the eye, you don't want to inject the fungus in the eye if it's not there already. Peripherally, if it goes into the eye, no big deal. You've now done an intracameral injection, which, as we talked about with fungal keratitis, it can go into the eye without penetrating or perforating the eye. And so now you've treated it from the surface and from the inside. Other things that we talked about, intracameral injections, amniotic membranes have been thought to help to decrease inflammation once you're sure you've gotten rid of the infection. You put the stromal side down because that's got the good humors to help with the inflammation. It's got anti-VEGF, which prevents blood vessels from growing. And then gluing we'll talk about quite a bit because I love gluing. Again, that's changed the way I practice. We used to take people into the OR in all times of the day and night for PKPs, and now we can stabilize them with gluing while we get them ready for surgery. Cyanoacrylate glue is the only kind of glue you would use for these kinds of therapeutic indications. For peripheral ulcers, it's fantastic. This was a drilling for a foreign body that went a little bit too aggressive, and there was a pop and the AC flattened. We put glue in there into the hole, and after a few months, this heals up with a fibrovascular scar. Nothing ever needed to be done. Vision was still 20/20, even though it had a pretty significant scar. Glue causes blood vessels to grow in there because it's a little irritating. And so now you have a fibrovascular scar, and nothing's going to happen to that down the road. Various kinds of glues you can use in a pinch. I've sent my medical student down to the Home Depot to get just super glue, but we get this Histacryl. There's various other kinds available. They're a little bit tinted purple, so you can see them on the eye. You can buy these little pipettes online for, you can buy a box of 100 for $5 or so. They're really nice. They're very soft pipettes. And so if you have a little gutter, you can use these pipettes and fill it in with the glue. And then once it dries, it fills in the gutter. Always remember that when glue polymerizes, it swells up. So put in less than you think. So I almost put in like 1 molecule at a time. Paint the bed, and then you can always put more layers. If you have an ulcer that's not, if a descemetocele or something that's sticking up and glue would just form a big mountain on the eye, then we use this glue, this drape method, which is really good. You take a Derm punch out a sterile drape, a little disc of sterile drape, get your glue into your little pipette, take a cotton tip applicator, put a little ointment on there, and then pick up one of these little discs with that, just so it sticks to it. And then put your little glue on the little disc. And then you want to keep something to dry the eye in one hand. The ulcer needs to be really, really dry, because if it's wet, the glue will just polymerize to itself and it won't stop the leak. You want the glue to polymerize to the fluid that's sort of in the cells around it so that it sticks down. So you dry the ulcer, invert that cotton tip applicator with the glue and the disc on the eye. The disc now pushes everything down and forms a nice little flat surface. You put a bandage contact lens and you're done. So this really works very well for bulgy sort of corneal ulcers. Certainly, if you have a large corneal ulcer, you'll do a corneal transplant, but remember, not all corneal transplants need to be central. This was a fungal ulcer that was sent to me from a community doc. This was on the back surface of his cataract wound. The AC was full of fungus. So what we did was actually, we went in there and peeled all this fungus out of the eye, but did a baby transplant, basically removing that infected nidus. This lady did really well. Remember, if you have a tiny little corneal transplant, you don't have to worry about it rejecting. You don't even have to put them on steroids. The endothelium will reject. The endothelium from the patient's own cornea will migrate over this area, because this is such a small area. There's plenty of endothelial cells to cover this up. And now it's permanently in their eye with their own endothelial cells. You don't have to worry about rejection. So we do a lot of these funky little baby transplants, or peripheral banana-shaped or crescent transplants for pellucid and things like that, because then you don't have to worry about them rejecting. So in conclusion, always make sure you know why you would get an ulcer, remove any of those aggravating factors, treat initially with antimicrobials, and then change it based on what you find or what you think might be going on. Eliminate all the toxic medications, put them on collagenase inhibitors, and then use adjunct therapy as needed. And then surgical management, really, if you can get them to a scar and do an optical transplant, that will be great. But if you can't, and they're unresponsive to medical management, you would put them on, you would try to do a transplant. Try to do the smallest transplant you can possibly. Thank you for your attention, and I'm happy to take any questions. Any questions at all? Sorry, I know this is, I'm remote, so it's kind of harder to ask questions live, but Parvati, if you want to turn on the mic over there and have somebody ask questions, I'm happy to answer any.
Yeah, absolutely. So I'm going to have one of my residents come up and ask you a question.
Hey, Dr. Seeley, good afternoon.
Hi.
So I had a question regarding culturing an infiltrate on the cornea. Let's say if you run into a situation where the infiltrate was overlying an extreme area of corneal thinning and you don't have enough to sample the base to get like all of the plates and tubes that you want, would there be like one or two high yield ones that you would absolutely get?
Absolutely, that's a great question. So yeah, if you have a corneal ulcer that's really thin, for one thing, often you can find thicker areas around the ulcer where there might still be an infiltrate, so you could take a culture from there. But if you really, again, in line with the desert island, if you could only take one, I would probably culture on a chocolate plate, because that would grow bacteria, fungus, basically anything, right? You can even see acanthamoeba on chocolate plates if you're careful enough. The hard thing is that you have to, sometimes the bacteria can overgrow the fungus. And then at least one smear. And you can, if you send one smear, they can actually do a gram stain and then decolorize it and do a GMS stain on the same slide. And so that is beneficial. Now, if it's a really bad ulcer that's causing a melt enough to cause a perforation, often that's gram negative, and those are floating everywhere. So you might get an adequate culture or adequate specimen just from the secretions, so the tear film or the mucus, the mucopurulin discharge. With fungus, you won't, but fungus doesn't usually melt through the eye quite as frequently. So yeah, if you had to pick one, pick the chocolate plate, and then send one slide. But if you can, for the others, send the culture, a culture from the secretions or from the edges where you might not have quite as much of an infiltrate, but they still might have that replicating bacteria or fungus. Did that answer the question?
Hi, Sonal. I have a
Hey.
question. Good to see you virtually.
Yes, it is.
And are there any pearls you can give the residents about after you've eradicated whatever microorganism and the ulcer is now having a difficult challenge in the cornea is having a difficult challenge in terms of reepithelializing. What kind of brief pearls can you offer the residents about your approach to helping that surface that's been traumatized by the medications you've applied, but then also from the microorganisms?
That's a great question too. And the other half of this talk is really how do you manage non-infectious ulcers, right? Because that's what you're left with. Once you've gotten rid of the bacteria, now you've got this really unhealthy eye, unhappy eye, especially in acanthamoeba and things where you're treating them for months and months with these really toxic medications. And even though it's really, really scary, one of the things I try to do is to just stop cold turkey, right? Stop all the toxic medications, especially things like tobramycin or vancomycin that are really toxic to the ocular surface. If you're scared to just stop everything cold turkey, you could put them on a fluoroquinolone while you stop the others, and just keep them on a little bit to make yourself sleep better, but try and stop as many medications as you can. We talked about steroids. So if you see a lot of inflammation in the eye, put the patients on steroids, because if you don't, that inflammation will never quiet down and you'll never get the epithelium to heal. If there isn't a whole lot of inflammation and the eye is just really mad, right? So then you put them on the doxycycline, the vitamin C. You could try doing things like amniotic membrane or just a bandage contact lens, just putting something on so that the eyelid's not rubbing against the eye all the time. You could do a punctal occlusion if you're really sure that there's not a lot of inflammation in the eye, just to get more tear film and more of the good humors in the eye. I love serum eye drops. Those work really well for non-healing neurotrophic ulcers, especially things like HSV, where you really don't have the nerves in the eye to produce the nerve growth factor, and so you don't have enough good humors to help the epithelium heal. No EGF, no NGF, no IGF. And so if you put them on serum actually has much higher levels of IGF, for example, than even the tear film does. So it'll really help the eye healing up. It'll help this comfort because it's like a non-preserved, thicker artificial tear. You could try things like oxervate, the nerve growth factor, Synergimin, but it's super expensive. It takes months to get the approval or weeks to get the approval. So that's really not very practical for an acute phase. So, amniotic membranes, serum tears, if you can get a hold of those, and then just protecting the surface, getting rid of the toxic medications, putting them on steroids really helps. And it's a little scary to do those things because you're sort of taught, oh my gosh, infection equals antibiotics, but sometimes stopping the antibiotics is the best option.
Thank you.
Other questions from the virtual audience? They've been very quiet today.
Nothing in the chat? Okay.
All right. Well, thank you all for listening. Appreciate it.
All right, so now we have resident cornea case presentations to discuss with Dr. Tooley. And the first resident case is Dr. Alexandra, or we call her Ola, Petruskevich, who is a PGY3 resident who is going to come and present now.
Alrighty. So the first cornea case will be a 72-year-old female who presented with blurred vision. I have no financial disclosures. So she presented with blurred vision at all distances, slowly progressive for several years, and notes that her left eye has been giving her more trouble than the right eye. Her vision fluctuates a bit, and she does wear an RGP contact lens in the left eye and typically just wears progressives over the RGP for reading. Her past medical history is significant for hypertension, Parkinson's, and hypercholesterolemia. And past ocular history is notable for hyperopic LASIK in the left eye only. That was done almost 20 years prior. At this point, it's about 2017 that she's presenting to clinic. And she did have one enhancement a year after the original LASIK. Per the patient, she said that the left eye was meant to be her monovision reading eye. And she also has a history of cataracts and dry eye. Her family history is non-contributory, and her medications and allergies are listed here. So looking at her ocular vital signs, her corrected visual acuity with the contact lens in the left eye is 20/20 minus, and her visual acuity without correction in the right eye, which is how she normally functions, is down to 20/70. Following manifest refraction, her best corrected visual acuity is noted to be 20/40 minus and 20/25. And she does glare slightly in both eyes. So cataracts are suspected to be becoming visually significant at this point, and possibly the cause of her chief complaint, which is the bilateral blurry vision, in conjunction with the dry eye symptoms that she has been having. And her vital signs are otherwise unremarkable. Just a quick note about this small discrepancy between her two best corrected visual acuities, one in the contact lens and one after having taken the lens out, and then having a manifest refraction immediately after. More so just a teaching point for the other residents that we always expect that somebody's best corrected vision is best in an RGP lens, just based on the interface that it forms with the tear film and its rigid shape, which is resistant to drying out, like soft contact lenses may, and just provides a lot of clarity of vision, particularly in people who have astigmatism. And this is just a representative photo of a very well-fitting RGP lens. So the remainder of her exam was mainly significant for moderate cataracts in both eyes. So some vacuoles and at least 3+ NS in each eye, with a PSC component as well. And her posterior exam was unremarkable. So at this point, I just wanted to pause and see if at this point you would order any additional testing at her initial visit, and what you would counsel her at this initial time.
Thanks, Ola. So I guess this is her first visit to see you that you're talking about, where you've diagnosed these cataracts. Given anybody that wears RGP contact lenses has had refractive surgery before, you always want to get a topography, right, of some sort. If you have access to Steinfug, then you would get something like a pentacam to see the anterior and posterior surfaces, just because this patient has been wearing contacts all along. You don't know what kind of she told you what kind of treatment she had, but you're not really sure. So you want to make sure whether they had myopic, hyperopic LASIK, and then also what their ocular surface looks like. Now, keeping in mind that if they're born, she only wears the contact in one eye, is that correct?
That's correct.
Okay, so with the left eye, you have to keep in mind that whatever you get would possibly have some warpage, right? Because contact lenses, RGP contact lenses, do flex and they do cause warpage. And so you want to take that with a grain of salt, but you do want to see what their topography looks like. You already got the bat measurement. You would get an OCT, I guess, to just make sure, if you can't get a good enough look back there, to see if there's other causes of her. Again, I'm not telling you guys anything that you don't know, but when you diagnose somebody with cataracts, you want to make sure it is a cataract that's causing that, and it's not the ocular surface. I would stain her ocular surface. People that have worn contacts for many, many years can sometimes have limbal stem cell deficiency that may not show up unless you actually put stain in there and look for the little whorled epithelium. So those are the things I would probably get at that point, just to make sure that I was dealing with cataracts and not something else.
Yeah, so all very good and routine testing that we get. In terms of what happened after this initial visit was that she was prescribed the glasses. All right, sorry, can you hear me now? Is that better? Okay, so what happened was the patient was prescribed glasses and she was advised to stop wearing the RGP in anticipation of future cataract surgery. So like you were mentioning with that suspected potential warpage that had happened to the cornea prior to even obtaining the first pentacam or corneal topography, it was recommended that she just abstain from wearing the contact lens and then follow up several months later for the whole routine cataract evaluation. So she ended up following up 6 months later, and unfortunately, she was still wearing the contact lens. So not much had really changed. Her chief complaint was pretty much the same, mainly that she was having difficulty reading music. And so at this time, the corneal topography was obtained. This is her right eye, which had not had any previous history of refractive surgery. And we can see that there's sort of minimal astigmatism and not too much abnormality with respect to her corneal thickness or her posterior and front of the corneal elevation maps. And now going to the left eye, which is the one that had refractive surgery, we see that there is a little bit of an increase in her Ks compared to the other eye, but nothing so significant. However, when we look at the pachymetry map, we do see that there is a little bit of decentered thinning down to the 460s. And also when we look at the back elevation of the cornea, we see that there is this area which is highly abnormal that correlates with this area of thinning that we see here. So preliminary IOL master was done as well. And, you know, from here and then comparing to what we got on the Pentacam, we see that there isn't very good correlation between the two, both in the axis of astigmatism and in the degree of astigmatism. And so this inconsistency, you know, would be something that may lead us to, you know, again, counsel her to stay out of the lens for some time and repeat measurements. And my question at this point is, you know, given how that map looked, are you concerned about post-LASIK ectasia or more so about, you know, changes that may have been induced by the contact lens? And how would you approach surgical planning for this patient?
Yeah, so you know, even though she's that's kind of surprising. I would not have expected a thinning with hyperopic LASIK right centrally, because the treatment is usually more peripheral. You're trying to steepen the center, and it's exceedingly rare to get ectasia from hyperopic LASIK, which it really looks like she had, because she's steeper centrally than she is peripherally. So I would be more inclined to think that she had warpage from her contacts. Just because that's hyperopic LASIK does not usually cause those changes. It is exceedingly hard to get people out of their hard contact lenses though. I totally get that she showed up with her contacts again. All my patients do the same until I threaten them. So I would again, what's one of my optometrists does actually is sometimes we'll switch them to soft contact lenses, because they don't want that whole 4 to 6 weeks of no hard contacts. So she'll switch them temporarily to a soft contact lens so that they only have to be out of it for 2, maybe 3 weeks, rather than the 4 to 6 weeks that we do for hard contacts, sort of as a staged thing to getting to their glasses. But I would get them in glasses first and figure out what's going on.
Mm-hmm. So in terms of what happened, the patient was again advised to stop wearing the contact lens, and at this point was referred to a cornea specialist for further diagnostic testing and management leading up to planned cataract surgery at some point in the future. So this is now 2 months later, and she shows up in the glasses that had been prescribed to her earlier in the year. So it's been a little bit over 6 months, and we can see that there's been a significant change now in her manifest refraction during this period of time, with additionally greater glare testing that was obtained as well. So we know that the cataracts are progressing. She's only been out of that. She's been out of the hard lens for 2 months at this point, and there isn't a significant difference in the astigmatism that we see in this refraction. So we do obtain repeat testing, and the repeat testing is on the left-hand side of the screen compared to the Pendicam from 2 months prior. And we can see that there is now an increase in the Ks, as well as even slightly more thinned area, whereas before it had been in the 460s or so. Now we're down to the 450s, which may just be margin of error level, but we do kind of see two factors that lead us to see that there's been this change since she's been out of the lens. So we kind of touched on some of these before, but when would you expect the cornea to stabilize after her being out of the lens? And how many times would you repeat measurements? And then what are your initial thoughts about IOL options for this patient? And would you consider toric IOL in her?
So as far as the first question goes, when do you expect the cornea to stabilize? We say 4 to 6 weeks, but I've had a patient that should severely dry eye. She'd had a couple of blepharoplasties. And so it took us a year to get her to a point where we could actually let her cornea relax. So as far as how many times would you repeat, I would do it until I got similar measurements twice. Now, again, that's the caveat to that is that if this patient successfully wears RGP contact lenses and she doesn't mind going back to contact lenses after her surgery, knowing that the quality of vision would be so much better with RGP, I wouldn't care then, right? I would do the surgery whenever we decided to do it, and then the question is, where would you aim for? You obviously wouldn't put a toric lens in if you're planning to go back to a contact lens, right? So that's a complete no. But if you, for contact lens wearers, especially women, I tend to aim for about -2 or 250, because the only thing they need to see without their contact is their contact. And so you want to be able to see that up close. Or the other thing they want to be able to see is their face when they put makeup on. And so, I can say that because I'm a woman, but so they don't like being distance corrected. So they would like to be near corrected. So it depends on whether they want to go back to a contact after or not. If they'd like to get rid of the contact, then yes, you do want to get, 2 measurements where they're stable, and then only do a toric lens if they're absolutely sure. If you think that the corneal parameters are relatively regular, which this doesn't look like, and they're absolutely sure they're never going to want to go to contacts. So I will do torics on patients who have irregular corneas to decrease that, if they've been wearing glasses all along, to correct their astigmatism, right? So just because they've got keratoconus doesn't mean they can't get a toric if they've worn contact lenses successfully before, or glasses successfully before. But in this patient, if she wants to get out of her contacts, then I would wait.
Mm-hmm. Yes, so that is essentially what happened, is that there was initially high variability in particularly the biometry readings, and she was seen essentially every month for 6 months with repeat measurements before they were kind of satisfactory and stable. And the discussion with the patient really centered around, the understanding that the contact lens would likely provide her with the sharpest vision after surgery. However, she was really concerned at this point about her progressive Parkinson's disease and the ability to manage the contact lens as she got older. So the goal for this patient was to get out of the contact lens. And so for that reason, understanding that even with the toric lens, she may need glasses, there may be a little bit more change at some point in the future. That was what was decided with her. So this was the final set of measurements that was taken prior to the IOL being chosen. And we can see here that there's a fair amount of consistency with regards to the Ks that we're seeing. That area of thinning is still around the 450s. And then I included the elevation map in this as well. And we do see some changes that are concerning, but had sort of been stable on several readings at this point. And also what was interesting on this day was that the IOL master was run on this patient 3 different times on the same day with slight variability, but overall there was enough consistency and correlation with both the axis and the degree of astigmatism from the Penacam that it was possible to choose the appropriate lens for her.
So did you end up putting a toric lens in her?
So she
Or-
did end up getting a toric lens.
Okay.
Yes, and so this was her refraction both post-op week 1 and at post-op month 2 once both of her eyes were done. And she was very happy with this. Her main goal going into the surgery was to be able to read her sheet music, which was at a slightly farther than near distance. And so this was a very ideal refraction for her. And she was only occasionally using reading glasses. And then she was sort of lost to pandemic for about 1.5 years and presented again for a routine visit. And her vision, her perception of her vision was stable at that time. You know, without correction, she was 20/25 minus and 20/30 minus. But on the refraction, there was a bit of a difference with respect to the astigmatism that was noted at this time. So she got repeat testing again at this visit, and the Penacam shows more steepening of the Ks than before, and this sort of irregular corneal thickness map, which may be an artifact of the test. We can see that, you know, normally we see this little centered mark a little bit more centrally, or previously had been infracentral. Here it's more superior, so that's a little bit different than before. But what was concerning was that the astigmatism seemed to have increased in her cornea compared to the March 2018 visit, which is when the last Penacam had been taken prior to her cataract surgery. So I think we touched on this a little bit before, where you had mentioned you think it would be unlikely that this could represent a corneal ectasia, but that was one of the things that was considered at this point, that this patient may have had a slowly progressive corneal ectasia. Now, after being out of the RGP lens for several years, it was difficult to explain these changes just based on warpage of the cornea due to being out of the lens. So the question at this point is, you know, if you would consider corneal cross-linking for this patient, or if what management considerations you would have.
Yes, you know, again, like I said, with hyperopic LASIK, you seldom expect to get ectasia. But looking at her corneal thickness, you make, you know, and the fact that she had an enhancement makes you wonder if the enhancement wasn't an enhancement, but a revision. And so she had hyperopic LASIK and then had myopic LASIK on top of that to correct something, because why else would she have central thinning after hyperopic LASIK? I guess you could have a little bit, but you know, at this point, she's how far out from her refractive surgery?
So that was done in 99, and this is 2021. So over 20 years, 22 years.
Gosh, if this was ectasia, that would be reportable, right? So unlikely, I guess, though she has changed a lot. So I'm not a cross-linking person. So, but I would start thinking about that if she continued to progress. Again, seems very unlikely to me, but could certainly consider that. So I would watch her carefully and see if this continued to progress, in which case probably.
Yeah, and there was certainly, you know, a bit of kind of questioning about exactly what was going on. So I don't think that you're alone in your, you know, questioning about what is actually going on with this cornea and what the diagnosis is. I'll kind of skim through this for the interest of time, but basically just summarizing some retrospective case series looking at cross-linking specifically for post-refractive ectasia, and most of them have pretty positive results with good safety profiles. The one recent one from 2021 showed a bit of a mixed result, and when it compared patients who received cross-linking for keratoconus with those who received it for post-LASIK ectasia, with better response in the keratoconus patients, but still some improvement also for post-LASIK ectasia. So this is something that I know some groups are doing. And the final slide here is that, you know, she had repeat testing done a couple of months after that initial Pennicam, and it showed a slight improvement, both with respect to the Ks and with respect to the thickness. And so there might have been just some intervisit variability there, but this is somebody that will just continue to be monitored closely at this time. To my knowledge, there's not a plan that she will necessarily undergo cross-linking, but definitely an interesting case and somebody who will be followed closely with continued repeat studies over time.
Yeah, that was fascinating. I am still at a loss to know what was going on, but well handled and great outcome. So congratulations.
Oh, thank you.
All right. Thank you, Ola. We will now move on to our second cornea case. We have one of our PGY3 residents, Dr. Franklin Zhang, who also was up here asking a question a minute ago. So we get to see his face briefly.
All right, good afternoon, everybody. So I have the second cornea mystery case for today. I have no financial disclosures. So same objectives as previously. So my case is an 89-year-old female that presented to our resident clinic with bilateral blurry vision of several weeks to months in duration. The right eye felt a little bit blurrier than the left one. She had some associated sharp eye pain and light sensitivity without any antecedent trauma, and she was not a contact lens wearer. Of note, she is being followed by rheumatology for rheumatoid arthritis. She was diagnosed in 2010 when she was in Russia, and she was previously being managed on a maintenance regimen of prednisone and methotrexate. However, because of increased back and joint pains, our rheumatologist started her on Plaquenil 400 milligrams daily. Her review of systems was otherwise negative. Other past medical history besides the rheumatoid includes some chronic conditions like hypertension, hyperlipidemia, GERD, and some degenerative conditions. Ocular history was significant for cataracts in both eyes. Medications that she was on are as listed. Like I mentioned, she was on a low dose of 2.5 milligrams each of methotrexate and prednisone, along with the hydroxychloroquine. Her initial visual acuity was 2800, but pinholing down to 2060 in the right eye, 2080 in the left eye. Pupils are equal round and reactive without any afferent pupillary defects. Intraocular pressures were in the low range of normal, but fairly symmetric in both eyes. Extraocular movements and confrontation fields were essentially full. This is an external photograph during the day that the patient presented to our clinic. She has a pretty significant amount of involution ptosis that was also affecting her vision, but attention is mainly drawn to the conjunctiva and the cornea, where you can see a significant amount of inferior perilimbal injection. And it was also noted to have an irregular light reflex in an area with a peripheral crescent-shaped area of thinning of the cornea. There weren't any infiltrates noticed on exam. The left picture shows a fluorescein stain of the cornea. There was approximately a 2.8 by 7.5 millimeter epithelial defect ranging from about 4 o'clock to 8 o'clock. And on the right-hand picture is a slit beam of the same area where we can highlight the epithelial loss and the stromal thinning a little bit more clearly. The left eye was relatively uninvolved. It had a little bit of ocular surface dryness with punctate epithelial erosions. The cornea in the right had about 60% thinning. She did also have brunescent cataracts in both eyes. The posterior segment exam was significant for a staphyloma surrounding both optic nerves, but was otherwise relatively unremarkable. So I'll pause over here, just quickly just thinking about what we saw on exam and with the patient's symptoms. I was wondering what kind of thoughts you had about our patient at this time, and what are the top things you're considering that could be contributing to her symptoms?
Franklin, can you go back to the picture that you had of the patient with the slit beam?
Sure.
Thank you. So typically, you know, I mean, obviously you've got the medical history, but typically when you see an ulcer on the eye, you have to look at where you're seeing the ulcer, right? So when you look at inferior ulcers or peripheral ulcers, so typically ulcers will happen centrally because that's where it's most avascular cornea. They can set a post and go. When you see peripheral ulcers, you have to start thinking, is something going on that's causing the ulcer peripherally, because that's usually a protected area. In this case, especially when you look at the shape of the ulcer, where you have the inner edge, if you will, sort of more sharply cut or overhanging, whereas a peripheral area is more sloping. That little overhanging thing makes you think that there was a stromal melt to begin with, and then the epithelium has broken down on top of it, which would make you start thinking of PUK. Certainly in a patient with rheumatoid arthritis, you have to think of things like keratomalacia or the sicca sort of just corneal melts from drying out. It's in an exposure area inferiorly. So you have to think, you have to rule out, even though she's got ptosis, that she doesn't have exposure, she doesn't have reduced blinking, which could cause an exposure keratopathy. She's not neurotrophic, which would again cause an inferior. But certainly when you see these overhanging kind of ulcers, you might want to start thinking of PUK. So I would work her up. She's got rheumatoid arthritis. You want to make sure, though, that she doesn't have any other autoimmune things that could be nastier, the ANCAs, the GP stuff. So I would do that workup and essentially bump up her immune suppression if that was my patient, or talk to rheumatology.
Yeah, definitely. And I'll go through. And aside from the testing, like you mentioned, for the other inflammatory conditions, would you consider anything else like anterior segment OCT, and would that contribute to your decision making?
So you obviously want to do a full, review of systems, make sure they don't have nosebleeds, all the other things that go with the other ANCA diseases. I would get the serology for, syphilis, Hep C. You want to make sure it's not a Murren's ulcer kind of thing. Is that what you're talking about? Get a chest X-ray, exactly. So get the workup for autoimmune diseases, but especially things that would cause necrotizing corneal conditions. So you could get a CT if it's indicated. I would get ANCA testing. I would get the rheumatoid factor, see what her activity levels are, serology activity levels, get an ESR and things like that.
Mm-hmm. Sure, all makes sense. Advance forward. So this is just another slide of an anterior segment OCT that we obtained on the day of her initial visit. Just want to highlight the area of absent epithelium, as well as the stromal thinning and irregularity with the hyperreflectivity on the anterior stroma. And I agree with everything that you said. Our top things in our differential were basically PUK, given her strong history of autoimmune disease. We also entertained the other possible cause of peripheral corneal thinning, but they were much less likely at this time. There weren't any infiltrates to suggest an infectious cause of the corneal process. And she was relatively asymptomatic for us to even really entertain things like Adelin or Terran's marginal degeneration. And we already talked about how you would manage the patient, so I'll continue moving forwards. So our working diagnosis was peripheral ulcerative keratitis at this time. We saw this patient with our cornea service, and given her strong autoimmune history, as well as rheumatology's notes that said her rheumatoid arthritis was not under control, We did not pursue a further extensive workup with the ANCAs and other vasculitities and things like that. We decided to just focus on reducing the inflammation, promoting reepithelialization, and minimizing stromal loss, since we felt that rheumatoid arthritis was the main driver of her process. So we increased her prednisone to 40 milligrams daily. We added vitamin C and doxycycline. And to promote ocular surface lubrication, we gave her artificial tears and erythromycin ointment 4 times a day. We did take a look at her on the slit lamp too. She did have a good blink reflex, so there wasn't much convincing evidence of an exposure keratopathy that was driving all of this, and she did have intact corneal sensation in both eyes as well. We also got in touch with rheumatology and had them schedule the patient for a reevaluation, since we felt that the hydroxychloroquine was probably not enough to control her rheumatologic disease. On day 3, she was noted to have stable thinning with a slight decrease in the size of the epithelial defect. By week 1, her epithelial defect continued to improve with the treatment that we had her on. And we decided to space out her follow-ups to occur weekly at this point. Her visual acuity continued to improve. Her cornea also continued to stabilize. At that point, we started to taper the prednisone down to 30 milligrams and down to 20 milligrams on subsequent weeks. And her surface also continued to improve as well. She followed up with rheumatology at around our one month appointment, and they planned to start her on some induction therapy with rituximab and requested that we kept her on a 20 milligram maintenance dose of prednisone for now until we see her clinical response to the infusion therapy. So at month 2, her epithelial defect had completely healed, and she had received a total of 2 rituximab infusions thus far. We continued to do a slow taper of her prednisone, and she was interested in cataract surgery to help improve her vision, since she had significant brunescent cataracts in both eyes. But the patient got a little bit worried about the whole surgical process, and she decided to change her mind, and we held off on that. And at her most recent follow-up visit, her prednisone was tapered down to 7.5 milligrams, and our OCT just highlights, because we didn't get a clinical picture at that time, the reepithelialization of that area where she had the peripheral ulcer, as well as a hyperreflective demarcation line in the anterior stroma. So just wanted to open this case up to the audience. If anybody had thoughts about anything that they would have done differently in terms of the management. And I was also curious to hear your thoughts on if you were to schedule this patient for cataract surgery, knowing that she had this ulcerative keratitis in the right eye, how long would you wait? And if there are any perioperative considerations you would take before you proceed with cataract surgery?
So no, I think I would have, you managed it perfectly. I probably would have held off on tapering the steroids until I got some other immunosuppression on board. I mean, it worked out fine, but the worry is that if you taper down the steroids don't really change the disease process, right? So if you've looked at some of those papers on PUK, what really changes the disease process, or again, we're trying to save the eye, but really what you're trying to save is the patient's life, right? Because something that's causing vasculitis and causing damage to the cornea is also damaging their kidneys and their heart and all the other organs. And so what you're really trying to do is to save their lives. And that's where, you know, the PUKs are sort of like, oh my gosh, I diagnosed something that actually could have killed this person. And so I would have probably kept that steroid going until I got rheumatology on board and something going before I started tapering it too rapidly. But in this patient, it seemed like it worked out fine. But that was the only thing I would have maybe, without knowing it in hindsight, done differently. With cataract surgery, I was going to actually ask you, what would you do? Would you have any special considerations when you go in there to do cataract surgery? What would you worry about with this patient? So, you know, you've got an irregular cornea, so we've had that whole conversation about toric IOLs and things like that. But would there be any other considerations when you went in there to do cataract surgery?
I guess the main considerations would be like the stability of the cornea, whether any kind of inflammation from the cataract surgery could reactivate the disease process. So I was just thinking off the top of my head, maybe like bump up the immunosuppression or start her on some systemic steroids, maybe a couple weeks to a couple months before surgery, just to make sure that she doesn't have a reactivation that could lead to more complications from the surgery.
Certainly. And what about intra-op? Would you worry about anything intra-op? If you do patients like this, or somebody who's had an RK surgery, are there other, or somebody with, Terriens or pellucid? I had a patient that was referred to me recently, well, not so recently, but cornea specialist actually doing cataract surgery on him, and a patient with unrecognized Terriens, marginal degeneration, broke the cataract, and halfway through the surgery, the eye popped open, like literally popped open, and they couldn't get it closed. So you do have to be careful. I mean, this one was not so bad, but very thin, right? So when you have a thin cornea, the other thing to be careful about is when you go in there to do cataract surgery, I usually do these in slow motion. So lower the bottle height, or lower the IOP, lower all my parameters. And so you want to do this very slowly and with very low parameters. You don't want stuff gushing through the eye, because you can, in some of these thin cases, or with RK patients, pop the wounds open. So just be careful with that when you do cataract surgery on these very thin corneas, because sometimes the cornea looks thick enough, but as you saw in this case, by 50% of the thickness or 30% of the thickness was just epithelium, which is not providing any structural integrity. So the stromal part is what's going to hold the cornea closed. So just make sure that you put these, you do that with very low bottle heights and things, slowly.
Got it. Makes sense. Thank you. You have a question?
Yeah.
Actually, I was just going to point out too, rituximab's, even though it's an infusion, it's still slower acting, just like a lot of our antimetabolites. So when they did the scleritis phase 1/2 trial on it, people would actually get a bump of inflammation in the first month or two sometimes, because of all the B cell lysis basically spilling out all the mediators inside those cells. And so something to think about when you're talking about when do you want to do surgery on this patient. She's really only 4 weeks out from getting rituximab. She's actually probably not therapeutic yet with it. And that's something to think about too, with when you're planning your prednisone taper. Like here, it's been okay, thankfully, but she's not therapeutic yet. And that's just something to keep in your mind. Now, if they're on rituximab where they get like every 6-month infusions, maybe you don't need to be 2 months out from when they get their next infusion, to time your surgery, because you're just maintaining those levels. But that's definitely something too, where we were talking about this a little bit over the break, like, maybe you don't want to plan to do someone's surgery at like month 5.5 in between their rituximab infusions too. And I agree, I would have probably have left this person on higher dose prednisone. I mean, it all came out well, but this is a case too where sometimes you have to coax rheumatology a little bit to, they're very overbooked. There's not enough rheumatologists in the world. But sometimes you need to be like, hey, this patient has puck and their cornea is literally melted in front of us. Could we get rituximab going a little bit sooner instead of like a follow-up 4 weeks later with rheumatology? Because you don't really want that delay in care here either. This person clearly needs to boost their immunosuppressive therapy. And sometimes they can even work on that even before they see the patient back nowadays with all this telemed stuff. They'll call them, do a video visit, get the patient consented for doing something Rituxan, and then start the work on that process. But I agree, I would have probably left them on there. But that's just something to keep in mind with the timing of that agent. It's not, rituximab probably 6 weeks in there. I'm sorry, infliximab 6 weeks in, they're probably pretty therapeutic, but this is a little slower.
Excellent point. And I totally agree. I usually keep them on the steroids for a few weeks after they've gotten their whatever it is, because I figure it's not going to be therapeutic. And so I don't start the taper until I feel like they're therapeutic, and certainly with rituximab longer. Great point.
So we have another question. Yes. Yeah. So it depends on how healthy they are as an 89-year-old, to be honest. That's a great question. The question was, are we concerned about leaving an 89-year-old on high dose prednisone? is some concern with that, right? But we have to remember, and just this is what Sano-san is saying too, is this is a sign of active vasculitis, including elsewhere in their body. And so they are at risk for having a mortality effect from their underlying autoimmune process at this point. So even though the steroids, we think of them as being this kind of risky medicine to be on, and sometimes you can talk to rheumatology about where they'd be comfortable, but that's probably why they wanted to leave her on 20 is they were partly worried about that systemic process. But that's where, you know, the sooner they can start them on something else, the sooner you can get them off. And that's where sometimes you can negotiate behind the scenes for a little earlier start on meds, even if the patient hasn't yet come in for their full rheumatology, you know, clinic visit. But if they're a sprightly 89-year-old, you know, without a lot of comorbidities, it's probably okay. I mean, rituximab is a pretty risky drug too. When you think about it for an 89-year-old, especially in the COVID era, there's pretty unpleasant mortality data associated with being on Rituxan therapy because people can't mount that B-cell response to COVID. And, you know, with an 89-year-old, I mean, they have a lot of other risk factors for that too. So it's a pretty aggressive treatment that they went with for. And I think it speaks to how much rheumatology probably was worried about the fact that she had a melt at that, you know, at that age. So she's lucky.
Yes.
All right, thank you very much.
So while you're setting up, there's a question in the chat about whether corneal surgeons use a purse string suture to stabilize the cornea that's difficult to repair. I've certainly tried to double breast suture very thin corneas to temporize it, but typically I'll go in there, for example, if it's a Terriens or a pellucid, and do a crescent graft instead, so I can get thicker tissue in there. And again, like I talked about earlier, with that crescent graft, because you're replacing more peripheral, very little bit of cornea, it's possible, you know, you can do that and not have to worry too much about rejections and things. So you can certainly do some double breasting of a very thin area, but the definitive treatment would be really to replace that area.
Does that work? Does that work? Where I took it off?
Our third case is Dr. Cassetti, who's one of our PGY2 residents.
All right, hi everyone. I'm gonna finish up with the third mystery cornea case. No financial disclosures. This case is about a 14-year-old female who presented to our resident clinic with bilateral red eye. The onset was fairly acute. She first noticed a little bit of redness and irritation in her eyes the previous night. And then over the course of this day that she presented, the redness got a lot worse in both eyes, and she developed such significant photophobia that she could barely open her eyes. She was also having blurry vision, but she denied any trauma to either of the eyes. There was no discharge, and she didn't have any skin lesions either around her eyelids or on her face. Her past medical history is significant for anxiety, for which she does not take any medications. She denied any family history of ocular diseases. Social history. She's a student in high school, lives at home with her parents, 2 sisters who are healthy, 1 dog. She denied any tobacco or recreational drug use, and she has an allergy to eggs. For her ocular history, I'm actually going to purposefully leave out her ocular history as well as a portion of the HPI, just for the sake of keeping the differential broad. And I'm going to show some photos of her exam. So if we view these with an open mind without that piece of the history, I think it'll lend to a better discussion. On exam, she was seeing 20/40 in the right, able to pinhole to 20/25 minus, and 20/30 in the left, pinholing to 20/20, but still very blurry. Pupils were round and reactive with no APD. Pressures were 13 and 12. Extraocular motions were full, as were visual fields to confrontation. This is what we see on her anterior segment exam. So in the external photo of the right eye, what stood out the most at first was how injected the eye was without any perilimbal sparing, very diffuse injection. And then even grossly, before doing a slit lamp exam, I was able to see that there were these pale circular oval opacities that were lining the periphery of the cornea. With the more magnified view on the slit lamp, we can kind of appreciate that the opacities are slightly gelatinous looking. Some of them are even a little bit raised. They're very discrete. Size was about 1, maybe 0.5 millimeter to 2 millimeters in size. And there was always this like a 1 millimeter space between the limbus and where those opacities were. So these are at the level of the epithelium, and we called them peripheral infiltrates at this time. And the left eye had very similar, kind of symmetric findings. Those peripheral opacities are in a very similar distribution. And then similarly with the slit lamp photo, we can see that they're a little bit raised on the epithelium, kind of stuck on looking. So to just kind of summarize her exam and touch on some things that weren't visualized in the photo, in addition to the injection, she had a 2+ papillary conjunctivitis reaction, trace corneal edema. There were multiple, as I said, the multiple peripheral raised white infiltrates about 1 millimeter from the limbus. No thinning was associated with these infiltrates on the cornea. She did have some mild diffuse staining, 1+ scattered punctate epithelial erosions, but no frank epithelial defects. And the AC was actually completely quiet without any cellar flare. Her posterior exam was perfectly normal. Her lenses were clear, discs were flat and sharp, no vitritis, macula and periphery looked good. So at this point, I know I've left out some critical information in the HPI, but I'm just wondering, Dr. Tooley, if you can kind of touch upon these exam findings and maybe describe or talk about what parts of this exam make you think of what diagnoses as possibilities. And also, does your gut tell you, just looking at these photos and hearing a little bit about the story, is this an infectious process or a sterile one?
Thanks. Thank you very much for that. That's a tough one. So, you know, again, acute onset, lots of photophobia, lesions with inflammation, obviously, because there's, you know, injection and with a clear area, any vascularization, any old scars, I can't really tell, but you know, it makes you think of some sort of a hypersensitivity reaction, right? So we're thinking flectenulosis, staph marginal, some sort of an atopic condition, vernal. So those would be my primary diagnosis or thoughts, just given the appearance and the acuteness of the onset and the location. So I guess I would try to find out if she had any, you know, so it doesn't look like she's got a whole lot of blepharitis. So I would ask about the allergic conditions more so, whether she's got vernal, atopic stuff, eczema.
Definitely, yeah. So I've left out so much information that would be helpful to you in that standpoint. Do you think that your thoughts would be any different if there were frank epithelial defects, maybe closer to the infiltrates? Would that make you, or in any case, would you want to culture this?
I would probably, if there were epithelial defects, culture it just so I would, for completion. But again, I don't see a whole, I mean, I see some mucoid discharge, but I don't see a lot of, mucopurulent discharge. So I think it's unlikely, but certainly if you've got, larger areas with epithelial defect, you could. But she has no history of getting anything in her eye, not a contact lens wearer, no trauma. So I would think that's lower on my differential.
All right. I mean, I did lead you astray a little bit with that, with kind of leaving out some pieces of the history. So she typically has great vision, is not normally a contact lens wearer, but she did end up using contact lenses in just the one day prior to presenting with us. And I will complete that part of the story. But just to kind of touch upon a few things in the differential diagnosis here, just like you said, most of these are related to hypersensitivity. And I guess that seems to be the main theme in what can cause infiltrates that are that kind of dramatic and acute. So contact lens related injury can definitely be infectious or non-infectious. Marginal infiltrates can be caused by hypoxic injury to the cornea, and it would be a hypersensitivity reaction in that case. Also, so staphylococcal infection like chronic blepharitis, where the lids are colonized by staph bacteria, even though staph is a bacteria and it is implicated in the pathophysiology, it's also technically a sterile process as well, because it's more of a hypersensitivity to the endotoxin that's released from the bacteria. And then in VKC or flictennular keratoconjunctivitis, that's again a hypersensitivity to the antigens that are associated with those conditions. So the hypersensitivity and that inflammatory reaction draws PMNs towards the epithelium, and then these can coalesce along the periphery, creating infiltrates. I suppose in herpetic stromal keratitis, you can also see marginal infiltrates, although these will more likely have or start with epithelial defects. In anesthetic overuse, that causes breakdown of the epithelium over time and can induce an inflammatory reaction. And then with post-refractive surgery, that's very much not common. I think it's more of a case reportable situation where after LASIK or PRK, there's been some reports of seeing kind of an arcuate infiltrate that is kind of present near where the flap would have been. And then, of course, we've talked quite a bit about some autoimmune conditions and the associated peripheral corneal ulceration that can sometimes have infiltrates as well. So now to complete the story, what happened with this patient was the one day prior to presentation, bought some cosmetic contact lenses from a beauty store, and she wore them through her whole school day that day. When she got home, she had some mild redness and irritation in her eyes. She did remove them overnight, stored them in some tap water, and then she put them back in the next morning to go to school. And after only about 2 to 3 hours, she developed severe redness in both eyes, significant photophobia. It was very dramatic. And I think one of her teachers called her mom and told her to pick her up, and they came directly to the emergency department. And that's how we ended up meeting her. And I think kind of in hindsight with the findings being so symmetric between the eyes, it kind of makes sense, but without knowing that piece of the history, it's not an obvious choice for what could have caused this.
That was a little bit of cheating.
It was a little bit of cheating. Have you seen findings like this before, or kind of this dramatic and large of infiltrates with contact lenses?
So you can get these mucus balls kind of thing on the corneas from wearing contact lenses, certainly. There again, it's not always an infection or pure infectious, like, infiltrates kind of thing. So they can respond to things like, a little bit of steroids with a little antibiotic. But certainly you can get these kind of lesions from contact lenses. Sometimes they're gram negative, but often they can be like these little mucus balls that you can get from hypoxia. So I guess she removed her contacts overnight, but you can get those from contacts.
Yeah, we were assuming that it was just probably a very tightly fitting lens, because even though she removed them overnight, I don't know, something about the probably the way that they fit just caused a really dramatic hypersensitivity reaction.
Right, and she soaked them in water, which could change the curvature, right? Because it would typically you would have them in some sort of a saline solution, which would be isotonic, not hypotonic, which is what water was. So it's possible that the water changed the curvature of the contact lens, which is why the second day around it caused more of a problem.
All right, thank you. So now knowing the full story, how would you manage this patient?
Well, that would definitely culture her. But again, I think there's, again, the short duration, you could, I would want to treat her with an antibiotic initially, given the contact lens history, because you don't know what beauty store contact lenses were. They're usually not sterile, and other people have worn them before. So you definitely want to treat it sort of like an infection, but I would have a low threshold for putting them on something like Tuberdex and getting the, too short to be a fungus usually. So we would think it would be more of an inflammatory response still. So send a gram stain, check and make sure it's not little gram-positive abscesses or something. But even if it is, often you can treat that with a quick steroid, as long as you're not worried about fungus or acanthamoeba, which would be too short a period to have.
All right. So for this patient's clinical course, on her initial day of presentation, what we ended up starting was moxifloxacin and prednisolone at the same time, QID, and had her come back the next day just to make sure that things were moving in the right direction. At that point, her vision had improved a little bit. She was still having quite a bit of blurriness. And she ended up getting the drops kind of late in the day, the previous day. So she had only used, I think, 2 to 3 doses of each drop by the time she was seen again. And even so, her symptoms had actually improved quite dramatically. The injection had improved quite a lot. She didn't have any photophobia anymore, but she did develop this mild AC reaction on day 2 that was not noted initially. So she had 5 to 10 cells per high power field in both eyes, but because overall her symptoms looked so much better and the eye overall looked to be moving in the right direction, we continued the same management. We saw her again at the end of that week. Vision was pretty much stable at that time, but her symptoms had completely resolved. She did still have some subjective blurriness, even though she was seeing much better than before. The infiltrates were still there, but they were definitely fading. And the AC at this time was completely quiet. So we dropped the moxifloxacin and kept her on the prednisolone just to see if we could prevent any kind of scarring from the infiltrates that were there. And then 10 days later at her 2-week visit, she was seeing 20/20, but still pretty blurry. So at this point with the refraction, even with that kind of best corrected visual acuity, she didn't like the way it looked. I couldn't get her seeing crisp and clear. And it was thought that maybe she developed a little bit of irregular astigmatism from where those infiltrates were. So we wanted to continue her on the steroid a little bit further, dropped it down to 1 day for what we intended to be 1 more week, and then to see her again a few weeks later. But this was actually the last time I saw her. I'm hoping because her vision cleared up and she was happy, but I'm not sure. So I guess, would you have done anything differently with the steroid at this point, kept it on longer, or do you think that you just kind of adjust to what the patient's symptoms and clinical exam is?
Right. Yeah, I would have stopped it just like you did, tapered it off and stopped it. Once it's scarred, you really are not doing very much with steroids, right? So the steroids work as long as there's white cells. Once you've gotten rid of the white cells, once you're left with scars, putting them on steroids is really not going to do much good. So I would taper it off. And these peripheral scars really should not cause significant irregular astigmatism. It's probably from a little bit of edema in the cornea that's still not completely resolved. So I would think that that her vision would go back to baseline, whatever that was, eventually, with no other intervention.
All right, great.
But yeah, beautiful pictures and dramatic case. So very cool.
It was a lot of drama.
I bet. There was a question in the chat, if can I answer that, about fashioning the wound and graft for making a crescent graft. So I don't know, how you guys do it over there, but what I'd like to do is I take 2 tree fines. I take 1 tree fine that's sort of the size. So if it's a peripheral melt, right? So you've got a crescent at the periphery. I take a, oh, you know what? Maybe I could share my screen here. So I take this is your cornea. Here's your melt. Can you guys see that? Right. So I take a tree fine that's the size, that's the diameter of this, and I make a mark. Then I take a tree fine that's a much larger diameter, so it's flatter, and I make a second mark like so. So now you've got a mark here and a mark here. I don't know if that makes sense. Here. So a mark here from the smaller tree fine, and then a mark here from a larger tree fine. And then I enter this and use scissors to cut that out. And then you do the same thing with your corneal graft. Take the same two tree fines, make your larger tree fine, the smaller tree fine, and punch it out. And then you put that in here and suture it up. Hope that makes sense. James, you asked that question. So let me know if that made sense. But that works really well. You can use that for little banana shaped transplants too, by truncating the edges for PUK. And that works pretty well. All right, thanks.
Sorry, there's one more.
Oh, okay.
Question here. Okay.
Hi, Dr. Tooley. One other question. I see a lot of stuff online now about using PCR in infections. Have you started moving towards PCR? Are you still sticking with culture? When do you use it? What are your thoughts about it?
Yes, so definitely for, virus PCR is the only way to go anymore. For acanthamoeba, they're not doing cultures anymore, so we do PCR. So we actually send that in a little, bottle with BSS in it and stick the culture in there to send for PCR. With fungal, our lab is not doing that, but I know overseas they do a lot of PCR for fungal, which is nice because you get instant results. So at my clinic, we basically do it for acanthamoeba or virus at this point.
Yeah, as I say, I've just seen it online that some people are starting to move more here, I think, towards it. I didn't know if you'd started yet. Okay, thank you.
Not yet. And I worry about false positives too. I mean, we worry about that with cultures anyway, but with PCR, it's hard to tell wheat from chaff sometimes.
Absolutely. Okay, thank you.
Yeah.
Great. Thank you so much for your time, Dr. Tooley. It was really a pleasure to have you virtually with us.
Thank you. And thank you for inviting me. I had a great time.
Thank you. So that wraps up our cornea cases. We're going to move on now to our senior resident research presentations. And before I do that, I just wanted to do a bit of housekeeping. There is an email that you all should have received with a Google Drive link to an evaluation. You can fill out that evaluation, and that's how we will know that you attended and be able to give you the CE or CME credits. So if you did not get that email link, please send Rose Herring a message at rherring@lifebridgehealth.org, and we will get that to you ASAP. All right, now our first senior resident research presentation, Dr. Malak Hamade will be presenting on the impact of eye drop primer in patient care. Dr. Hamadi, after she finishes her residency with us, will be going on to do a pediatric ophthalmology fellowship. All right, go ahead, Malak.
Hi, everyone. Good afternoon. Thank you so much for having me today. I apologize. I wasn't feeling that well this morning, so I decided to quarantine just to make sure that I'm not exposing anyone potentially to anything. So I'll be doing this remotely if that's okay. So I'm going to go ahead and share my screen. Can everyone see my screen okay?
Yes.
Okay, thank you so much. All right, my KEI project is on a glaucoma eye drop primer that I made basically partially as a request from some of my internal medicine colleagues. So I have no disclosures. So just a little bit of a background. I think this is a story that we're all too familiar with. Patient comes in after having been in the inpatient setting for some acute medical issue. They're a patient of yours, they have a history of POAG, you notice that there's some progression on their testing, and so you question them a little further, and you realize that they hadn't been receiving their drops while they were inpatient. And that led to the progression of their disease. So lack of eye drop reconciliation in the inpatient setting is a frequent problem just based on what we know from just seeing our patients day to day. So I went a little bit further and I spoke to my internal medicine residents just to kind of gauge how comfortable they felt with glaucoma eye drops in general and why they thought it was that this was a problem and why patients may or may not have received their drops while inpatient for some other acute issue like say chest pain or COPD or sepsis or anything of the sort. And these are just some general feedback that I got from them. One of the things that they told me was that patient was there for an acute medical problem and, their drops for a chronic issue fell off and they were so busy with their acute medical problem that no one noticed, which isn't ideal, but they were just being truthful and I do appreciate that. Or they tried to reconcile the meds, did not have outpatient records, and the patient either did not know the name of the drop or only knew the color. And because they weren't very familiar with our color scheme for these eye drops, it was kind of difficult for them to figure out. And so even if they did eventually start them on the drops, it may have taken them days between trying to get the records and speaking to the patient's family members that the patient themselves didn't know. So with that in mind, I did ask them if they thought it would be helpful if I put together kind of a basic glaucoma eye drop primer to kind of help them with that during their admissions and such. And the feedback I got was that, yes, that would be helpful. And so that's what I ventured out to do. Basically, the objective of this was to develop a basic primer that would just kind of give a small short background into POAG and why it's important to treat the different classes of drugs that we use to treat glaucoma and the different drugs within each class. And also, of course, the color coding that we use, which is really important. It touched briefly on the mechanisms of action, on the side effects and the different considerations that a provider should kind of consider when they're prescribing these drops, the different preservatives that are used in the different drops, a little bit mention of which ones have generics available and delving a tiny bit into the cost, and then also the algorithm that I use at least for prescribing drops. And this was all just to kind of see if it would help non-ophthalmologic providers kind of be more comfortable giving these drops while their patients were being admitted for other issues. So I just gave a very basic overview of what glaucoma was in the primer. My apologies, my cursor is acting up. So it's an irreversible disease of the optic nerve, results in a characteristic cupped appearance of the optic nerve head, and it is the leading cause of irreversible blindness in the world. And although the definition doesn't include pressure, lowering the pressure is the only approved approach to preventing glaucoma in ocular hypertensive patients or delaying the progression in people who've been diagnosed. And so we're going to start with the first class of drugs, prostaglandins, best safety profile and the most common first line for POAG. Prostaglandins are F2A analogs activated by corneal esterase. They lower the intraocular pressure by acting on the uveoscleral outflow pathway. And we prescribe them very dilute doses because higher doses are associated with higher pressures actually. The side effects luckily are mostly orbitopathy. So lash growth, deepening of the sulcus, due to tissue atrophy, darkening of the iris are most common in those who have hazel green eyes, not so much an issue with people who already have very dark irises or blue irises. And then some considerations, but definitely not, excuse me, not absolute contraindications, potential for uveitis, CME, or worsening of an underlying herpetic keratitis. And the cost is variable depending on the different drug that you're using. Okay. And I made sure to list the different drugs with both their brand names and to make a mention of whether or not there was a generic available. So latanoprost, the most common use. Travoprost, also known as Travatan Z, uses Sofia, so an alternative to BAK. Also available in a generic. And then Manoprost, which, you know, even if you don't know about glaucoma, you do know about Latisse, the lash growth miracle serum. And then that does not have a generic. And then Tafloprost also does not have a generic, but is a preservative-free option. This was just a meta-analysis that kind of looked at the different drugs to see which ones were more efficacious, excuse me. And it seemed that the Manoprost at the 6-month mark was more effective than latanoprost and Tafloprost, but was associated with higher rates of hyperemia. And then we moved on to the aqueous suppressants. So 3 classes fall under this: carbonic anhydrase inhibitors, beta blockers, alpha-2 agonists. And these drugs lower intraocular pressure by their ability to decrease the rate of aqueous humor production in the eye. And so starting with our beta blockers, our most common is timolol, under a lot of brand names. It comes in 0.25% and 0.5% formulation. It's the most common beta blocker prescribed and luckily has a generic. The gel form is associated with reduced systemic absorption, and it's been shown to be as effective as the twice daily dosing. And then we have Betaxol for patients who can't tolerate or have a history of COPD asthma because it's cardioselective and has a similar efficacy to timolol. And then also important to note that they can be prescribed as part of the combination. So Combigan or Cosap, Combigan not being generic, so more expensive, and Cosap being generic, so more affordable. And then important to consider patients who have bradycardia or shortness of breath, history of COPD and asthma, very important to ask those questions prior to prescribing. And then moving on to our carbonic anhydrase inhibitors. We have Durzolamide, which is available in a generic formulation. As previously mentioned, also in combination with timolol, giving you Cosapt, dark blue color cap. And then Brinzolamide Azopt, no generic available, but also available in combination with Bronbean or Cymbrisa. Side effects, so as we know, PO formulation can cause increased urination, KEI, and a very rare red cell aplasia, and that is not dose dependent. So questions for any provider to ask while prescribing: a history of sickle cell, important, especially if you're treating lymphoma, and any sulfa allergies. Well, I believe that's a relative contraindication. Okay, then you have your alpha-2 agonists. Brimonidine comes in alpha-GAN and alpha-GAN P. The P stands for purite, again, an alternative for BAK. It comes in a generic. And then there's aproclonidine, which we no longer really use for long-term management of glaucoma, but important to know. Use it paraprocedurally for laser procedures. Then our newer agents, latanoprostine by Solta, has a teal cap, metabolizes into latanoprost and nitric oxide, acts on both uveoscleral and trabecular outflow, and atorcital, Rho kinase inhibitor. Ropressa, or in combination with latanoprost, becomes Rocklatan, and this increases the trabecular outflow. Both are relatively expensive compared to the other drugs we spoke about. So just looking at a first-line treatment algorithm for POAG, if there's no contraindication for prostaglandins, they're commonly the most common first-line drug. So you can start with a prostaglandin or SLT if the patient's amenable. If there's a contraindication to prostaglandin, you have to see if it's tolerance related, if the patient isn't tolerating the side effects, or if it's cost related. You can always switch to preservative-free prostaglandin if it's causing irritation, or C, depending on what the patient's insurance coverage is, or offer them a generic. Prostaglandin is still not an option. You can start a beta blocker, usually timolol. They've been shown to be just as efficacious. And if contraindication to both above, you can either start Durzolamide or Brimonidine. And then my escalating treatment algorithm. So if patients are already on prostaglandin, you can add timolol 0.5 once daily or even twice daily, depending on which brand you buy. Switch the timolol to Cosapt or Combigan. Add Brimonidine or Durzolamide as a fourth. You can trial Ropressa as fifth. Switch any of the prostaglandins to Vysulta also as a fifth. And then by the time you are considering PO Diamax, it's usually a temporizing measure for or pending surgical intervention. So this was all provided in table form. with plenty of pictures. And so I sent the primer out a few weeks ago. I just took a general survey from my internal medicine colleagues, and in general, the feedback has been that they found the primer helpful. And when asking them if they would use it to initiate treatment by themselves, they said, the majority said no, and understandably so. It's not their profession. They're not their subspecialty, sorry. But if they, when asked if they felt more comfortable prescribing eye drops inpatient or switching between the same class of drugs, but just giving a different drug, they said yes. And they thought that the primer was very helpful for that, and they would keep it on hand. And then when asking them basically how many classes of drugs that they can name, that average went from 2.7 prior to the primer to 3.4 after the primer. And they also requested more primers for antibiotics and such. So those are pending. Yeah, that's my QI project. Thank you so much. Did anyone have any questions? Great, thank you all so much.
I was just wondering how many people total received the primer? Was it the entire internal medicine class? It was just the 9 people that you initially surveyed?
Yeah, so I actually asked the Sinai Med Chiefs to send it out to everyone. I do have to double check if that was to attendings. I did share it with some attendings, but not through a chain email. But I would presume at least the residents received it.
I didn't see anything in your presentation about this, but did you go over with them what the different colors were for the bottles and all of that kind of thing?
Oh yeah, I apologize. I should have taken a screenshot of the primer itself, but I just divided it up in slide form. So I put them, I highlighted them on the primer itself just to indicate, and I put under in like parentheses basically that prostaglandins are teal and then beta blockers are yellow and so on and so forth. So yes.
Malak. We'll move on to our second senior resident research presentation. We have Dr. Alex Willis back up here. Dr. Willis, after graduation, will be most likely moving back to the Midwest and joining a practice in Springfield, Illinois. He's going to be talking to us about the enhancement of the VA resident rotation.
Hello again, everyone. This is my QI project. I was pretty traumatized as a second year heading out to the VA. There's a lot to do. There's a lot of different things, different processes. The vets are different. They're awesome, but there was a big learning curve and there wasn't a whole lot of structure. And so I took it upon myself to hopefully improve the onboarding process. Obviously, no disclosures. So background, the VA Veteran Affairs out in Martinsburg, West Virginia had a very long-term, like multi-decade contract with the previous institution that they were working with. They sent out their own attendings, so there was a little bit of familiarity, and they'd just been there so long that I think the process was just ingrained into their residency. Obviously, when we took over the contract in 2018, we went in bright-eyed, bushy-tailed, and ready to take care of the veterans, but didn't have as much structure or support. And given the fact that there was a large turnover in the faculty and staff, and some new additions like laptops and Omnicell access for medications in clinic, there's just a lot more to get started. And it always seemed like every week there was something new, different, or a different process that we hadn't heard of that we needed onboarding on, and it was month 2. And so I kept track of all of those and put them all into a document, and we'll get to that in a second. But yeah, it's very complicated to get on site at a government facility. It's almost like a government base. So the question entering the project was, can we simplify, streamline that onboarding process at the VA by creating a resident guide, which was supposed to be about 2 or 3 pages. And that's just the preamble now. There's like 12 or 15 pages about how to succeed. at the VA, and I'm sure there will be more, and there's edits and the whole bit. But anyways, the benefits are less stress, increased efficiency, help out the veterans a little bit more efficiently, and provide high quality care. So I already spilled the beans about the resident guide, but the big thing is you just weren't quite sure how to accomplish the goal that you were set out to achieve. You didn't have all the tools you needed. So we created a 9-item checklist of the most important things prior to starting the rotation. And if you had those 9 things, you were fully functional resident and you were able to complete your job. And then implement that with the rotation that went out in November and collect the data regarding completion of those 9 tasks before and after. Obviously, it'll be a small data collection, but we did it. And then identify the length of time to complete all of the onboarding tasks, officially being fully onboarded at the VA. So what did we survey? Were we able to log in? Were we able to use the PIV card, which is awesome? You can put the PIV card anywhere and get access with just a pen. So that's great, but did you have access to it? Did you get all the exams you needed? Did you get a tour? Just all the basics, everything that you would want in an onboarding process. Did your badge give you access to the OR as a surgical resident? Did you have access to Omnicell so you could get out the ILEA to do injections on Tuesdays? All of those things needed to get done. And so here's my results. So I pulled the 5 residents. The graduates from last year and myself and Dr. Arya before this implementation, and asked them what they thought they were able to complete. The residents prior to then just couldn't quite remember, and there was going to be too much bias, I thought, because that day is pretty stressful. So it's really hard to remember the fine details from a year and a half prior. And so just to discuss the small amount of results I had, on average, you were only completing about 40% of the tasks you needed prior to day 1. And then afterwards, almost 70%. So we're D+ range, but we'll get there. Post-intervention group still had difficulty with medication access and remote CPRS access. I think they would tell you remote CPRS access isn't necessarily vital to succeeding in the VA, but the medication access, I'm sure, was a bit of an issue. And then the most telling, I think most important thing to me is success of the project was the length of time until the completion of all of those onboarding tasks. And pre-implementation, it was over 2 months. Sometimes people didn't even get fully onboarded throughout the entire rotation, which is just a tragedy, I think, because it just is so stressful. And then post-implementation was about 1 to 2 weeks. So that was a big success in my book. Just reiterating what we talked about, but tasks completed were nearly doubled, and the newer technologies were the things that were kind of holding us back. So the limitations, obviously the size of the data, and there's only so many residents that we send out there, so it's always going to be small. The recall bias, and there's just like innate want to improve that rotation. So there might be some exaggerations there. I don't really think so, because it's either you did complete it or you didn't, but opens yourself up for bias. And then you can't really quantify inability to provide quality care necessarily unless you compared surgical volumes and complications and resident clinic volumes, which I'm not sure directly correlate either. You could also compare patient satisfaction surveys and how long it takes to get into that VA clinic, because sometimes it does take a long time. So if that decreases, it might be due to the fact that we can see more patients and get better things done. Thanks to Dr. Bowe and Dr. Mohideen for helping me out in the project, and Dr. Blank. Thank you.
All right, and our last presentation of the afternoon, Dr. Chao Lee, who after graduating in a few months will be going on to a comprehensive private practice job in Charlotte, North Carolina. He's also been our tech support today. So Thank
Thanks,
you,
Brendan.
Dr. Lee. He's going to be talking about the rate of outpatient follow-up after initial ophthalmic consult.
All right, great. Thanks for the introduction. So no financial disclosures from my end, unfortunately. So as far as the clinical scenario, this is something I was faced with whenever I was an intern, PGY 2 and 3, as I was fielding consults. So internal medicine consults us for a 53-year-old man with uncontrolled diabetes complaining of blurry vision for the last few days. Resident comes in, examines the patient, does a bedside DFE, and is found to have moderate diabetic retinopathy, and we recommend outpatient follow-up for further treatment and evaluation. Patient's discharged and given discharge paperwork, and that generally includes just a tiny slip with our office number on it to call the clinic to set up an appointment for further evaluation. So what happens next? It's really hard to tell. A lot of times we do see these patients, but we don't really have an exact number on what the rate of follow-up is. So that was the idea for my QI project. So the question is, what is our outpatient follow-up rate after initial consultation? Now, this is specifically for inpatient consults. The ER consults are a little harder to track down from the EHR standpoint. That is a potential different project that we can do. And we also looked at secondary objective is to identify any risk factors that can be correlated with follow-up. So for us, this was a retrospective chart review, so IRB exempt for inpatient consultations that were required in the year 2021. I think initially we had started with around 360 patient encounters. So they were excluded from the study if follow-up with a primary ophthalmologist was recommended, no follow-up was necessary, or they expired during a hospitalization. So at the end of that sorting process, we came down to 132 individual patients that were included in the study. So follow-up was determined by looking at our outpatient EMR through EMA to see if they did follow up for that initial evaluation after discharge. Secondary outcomes, we looked at ICD-10 codes that were included in their chart, as well as gender, race, age, and health insurance for analysis to see if there's any correlation in regards to if they follow up or not. As far as ICD-10 codes, we looked at a bunch. These are the ones that we had looked into. I'm not going to go through all of them. So as far as the results, so out of 132 patients, 48 presented for outpatient follow-up after discharge. So that gives us roughly a little more than a third. I think national average, it's a little hard to track down because this is very specific to inpatient consultation. But I saw, as far as optometry referral for diabetic screening, anywhere from 30 to 50%. Secondary objectives that were statistically significant with a p-value less than 0.05. We found that older age, those with chronic obstructive pulmonary disease, chronic kidney disease, and the specific one, Z86, personal history of certain other diseases, which is kind of non-specific, but interesting that it became statistically significant. But I was originally looking for stroke, but, and then also insurance category. So a little busier slide here, but this is for age. So we had the cutoff at age 65, so those older than 65 and those under. And if we read these horizontally, we can see that a little more patients came in under the age of 65 versus those were older, and p-value was 0.03. So that would suggest those over the age of 65, they were less likely to present for follow-up. Same here for COPD, as we can see the discrepancy between these numbers, p-value less than 0.05 here as well. CKD, same thing. And then this non-specific, but statistically significant, Z86. So as far as insurance category, this was a little harder to figure out because Chi-square with 9 degrees of freedom is a little tough. We had a limited sample size. If we look at, specific insurance categories, we had Blue Cross. This would suggest that those with Blue Cross are more likely to follow up versus MA Health Choice, which were less likely, and also Medicaid more likely to follow up. But I would love to have more numbers for these versus, N of 9, 14, and 34. So conclusion for our current rate of follow-up, it's a little over a third at 36%. And we found that patients age 65 and older with CKD, COPD, or Z86 in their chart were less likely to follow up. And if you want to think about the insurance categories, but I think those weren't as relevant as I had hoped. So, the original thought is to identify patients that were at risk of lost follow-up and potential vision loss, and identify such patients so that we can set them up for a clinic visit without them having to go through all their discharge paperwork, call us, and find a time slot that they can come in. Especially those with multiple comorbidities and older age, they're probably not driving on their own. They'd have a lot of barriers to care. So future plans that I would love to do is to have an improved way of consultation. Currently, it's kind of all over the place. They page us, they call us, and there's also a way to order it from the EHR system. But one way to do it standardized and being able to track it would be great. And then potentially finding a way to identify high-risk patients and implementing a system to where the clinic can get a list of these patients after discharge, and we can have our front desk staff call and schedule those patients for follow-up. Questions?
Yeah, I think that's a great idea, getting a list. I wonder if some of these older patients already have an ophthalmologist, because they're older and maybe they already have somebody that they see.
Right. So it's a little hard to narrow down, whenever I looked through all the charts. So, it was 300 something patients. So I had to go about a year back. If the chart had mentioned an outside primary ophthalmologist, I just threw them out of the study. A lot of them didn't. So I included those. I just don't think that infrastructure is there, to be honest. We give them a clinic number, and that's in the discharge paperwork. That goes for pretty much all outpatient clinics, from what I know. Yeah. I think rehab is a little different. If you get admitted into rehab, you go directly over there. I don't think they call in for that. I'm not sure what the PT and OT guys do on outpatient wise, to be honest.
Any other questions? All right, well, that is about all we have for this afternoon. Dr. Abrams, did you want to say any closing remarks? Or do you want me to? Okay, so thank you everybody for joining us virtually. I want to thank our two guest speakers one more time for contributing so much to our education, to our residents' education, and for presenting such great lectures today, and to our faculty and residents. Thank you for your great presentations and for a good discussion. We look forward to hopefully seeing everybody in person next year. Please give us some feedback on how you feel about the virtual model. There's a chance going forward we'll try to do some sort of hybrid if the technology allows, but I think for discussion, it seems to be easier when people are in person rather than when everybody's virtual. If there's any other last minute questions or discussion points that anyone in the audience has, you can also unmute yourself and ask a question. I'll leave it up for just a minute and then we can. All right, great. Thank you all. And again, please remember to fill out your evaluations. The certificates will be emailed to you probably in a week. Our program coordinator is out of the country for another week. So when she gets back from her vacation, she will be taking care of all of that. All right, thank you. And thank you for all the positive feedbacks in the comments. We appreciate it.